Thank you, Dr. Nafisa, and welcome everybody. Join me in welcoming Professor Kotlik Oktay. Professor Oktay is a professor of obstetrics and gynecology and reproductive sciences, the director of Laboratory of Fertility Preservation and Molecular Reproduction at Yale University School of Medicine. He's a leading clinician scientist in fertility preservation, and he had extensive work and research in the field of ovarian cryopreservation and fertility preservation. He received numerous prestigious awards. So join me in welcoming Prof. Oktay. Prof. Oktay.
Morning. First of all, I would like to thank you for inviting me to present here, even though virtually. And I hope you guys are having a good time there. I will be talking to you about fertility and pregnancy in women with breast cancer. First of all, I'd like to let you know that the guidelines for our American Society of Clinical Oncology fertility preservation were updated in 2018. And this document, which we co-chaired with Dr. Lauren, still has very valuable information. And in this talk, I will update a few pieces of information, but this document is still quite current. First, I want to talk to you about the ovarian reserve and the impact of breast cancer chemotherapy on ovarian reserve. Then I will give you an algorithm in decision-making in fertility preservation. Then we will talk about specific topics of fertility preservation in breast cancer. These will include specific stimulation protocols, the status of BRCA mutation carriers, and ovarian tissue cryopreservation for fertility preservation. And then we will have a brief discussion on whether there's a room for ovarian suppression and fertility preservation. First, I want to review our knowledge of ovarian physiology and how chemotherapy affects them. Women are born with all the eggs they have, so they're born with about 1 million eggs at birth, which steadily declines till about age 37, and after that, there is a rapid decline. So whatever affects this reserve will result in earlier menopause. Now, when we say ovarian reserve, we're talking about primordial follicles, which are quiescent and initiate growth through an unknown process. And that growth process takes at least 3 months. Now, once these follicles reach to their late stages, they will start producing hormones, and that's what results in menstruation. The agents that damage ovarian reserve and cause infertility, they damage primordial follicles, as we have shown through inducing DNA double-strand breaks. However, the drugs that do not have that effect do not damage that reserve, but all classes of agents will damage the developing follicles, which produce hormones. So this means that losing periods does not indicate that there was a permanent damage. The opposite is also true. Temporarily losing a period and gaining doesn't mean that you did not have damage to your ovarian reserve, because even if a fraction is left, follicles will be formed from maybe 3 to 6 months, even a year later, periods may recover. For that reason, we need to rely on more quantifiable markers, and the best marker for that is anti-Mullerian hormone, which is produced from early stage follicles. One can also count antral follicles on ultrasound, which is all in similar accuracy, but this would require an experienced person. To put this into context, I have to share with you a prospective longitudinal study that we performed with Memorial Sloan Kettering Cancer Center. 207 women who received either AC, T, CMF, or tamoxifen-only regimens were longitudinally followed with serum anti-Mullerian hormone levels. Now, AMH is a hormonal agent, so it does not damage ovarian reserve. As you can see that other than for age-related decline, the AMH levels do not change much. But you can see that both ACT and CMF, they result in significant decline in ovarian reserve. You can see that there's almost 90% drop in ovarian reserve in both regimens. And you also see that there's no recovery after 12 months post-chemotherapy, post-completion of chemotherapy. So if we measure AMH at baseline before chemo and 12 months post-completion of chemo, and that will show us how much damage that has occurred. And that's a lot. So based on these kind of studies, we estimate that an average breast cancer treatment will result in the loss of 10 years worth of ovarian reserve. So let's take a 25-year-old who received an ACT dose-dense chemotherapy regimen. This then would have declined her ovarian reserve to that a level of a 35-year-old. And if we add 10 years of delay for tamoxifen treatment on that, then her ovarian reserve would be reduced that of her 45-year-olds, at which age we know that fertility ends. So that tells you that any young patient that you see who's going to receive chemotherapy should be referred for fertility preservation. For that reason, we've developed this algorithm. So in this algorithm, we say that if they're going to receive chemo, you refer them to fertility preservation. If they have time, we can do stimulation and freeze embryos or oocytes. But as I will discuss later, if they don't have sufficient time, we can freeze their ovarian tissue. On the other hand, if they're only going to receive tamoxifen, you have to consider their age. And for example, if they're older than 28 and if they're going to be delayed for another 10 years, then they're passing that age where ovarian reserve sharply declines, the egg quality declines. So those patients may also need fertility preservation. Only those that are under age 27 who are only going to receive hormonal treatment may not need. So they need good counseling. So I told you that if they have time, we normally resort to oocyte or embryo freezing, which are established techniques of fertility preservation. However, this method requires about 2 weeks. Originally, this was from the beginning of menstrual periods, but now we have random start protocols which do not require waiting for the period. The problem with that, estrogen levels can be significantly high during the stimulation, which is obviously not desirable for a woman with breast cancer. Now, you have two agents that you commonly use for endocrine treatment of breast cancer, which are both ovarian stimulants. Number one, aromatase inhibitors. They block the peripheral ovarian and peripheral aromatase enzyme will reduce estrogen levels, which result in the break in the negative feedback to the hypothalamus, which will increase FSH hormone levels, follicle-stimulating hormone levels, which will stimulate ovaries. In the case of tamoxifen, tamoxifen will block estrogen receptors in the hypothalamus, and which will then break the negative feedback of estrogen to the brain. Again, will increase follicle-stimulating hormone and stimulate ovaries. So we took advantage of that in earlier studies. We used tamoxifen, then combination of tamoxifen with follicle-stimulating hormone, and then in the third rendition, aromatase inhibitor letrozole with follicle-stimulating hormone to stimulate women with breast cancer so that they could freeze their ovarian oocytes or embryos in prospective trials. We found that, as you can see here with letrozole, estrogen levels were most suppressed, comparable to tamoxifen-only cycles, which are closer to natural cycles. And letrozole cycle gave the largest number of eggs. So we chose letrozole in most cases as the stimulation protocol of choice. With that protocol, live birth rates are something like 50% or higher, even for patients that are 36-year-old or so. So it's a very successful protocol. How about, as I told you, that you used to have to wait for a patient's period, which resulted in further delay before we could start ovarian stimulation. But back in 2011, we reported this approach where we found that we could start stimulation at any time during the cycle, which is called random start And since then, the success rate has been shown to be equivalent of standard protocols. So don't hesitate to refer patients to fertility preservation, even if they're in the middle of their cycle. What about the effect of these stimulations on survival? We have had several studies on this, and I'm showing you the longer-term follow-up study, which was about 5 years for the fertility preservation group. And this study showed us that there was no relapse-free survival rate difference between the fertility preservation and control groups, or those with BRCA mutations undergoing fertility preservation or not. Also, no effect of estrogen receptor status, or whether you did this before or after surgery. One interesting thing that emerged while we were doing stimulation answer was that we noted that the women with BRCA mutations produce fewer oocytes than those who were negative, as you can see, 11.3 to 7.4. In fact, in subsequent studies, in studying DNA repair pathway, ATM-mediated DNA repair pathway, where BRCA is, as a mechanism that plays a role in ovarian aging. So DNA repair efficiency in oocytes turn out to be important in maintaining their quality and life. And that's why these women are losing their oocytes early. In fact, I told you AMH is the most valuable marker. This is from our individual patient data meta-analysis published a few years ago, looking at serum AMH levels in women with BRCA mutations. We had 5 centers. We got their raw data. One of them is ours. And regardless of how you adjust the data with smoking, center, age, or not, women with BRCA mutations have 25% lower AMH, meaning 25% lower reserve. And other studies have shown that they experience menopause early as well. So it's kind of a double, triple whammy that women with BRCA mutations, when they have breast cancer, they have a lower ovarian reserve. On top of that, it turns out that they may be losing more reserve with chemotherapy. So what happens with age is that, okay, women with germline mutations, they have an intact BRCA allele, but the function of that declines with age. And that results in accumulation of severe DNA damage both in breast and ovary, which induces carcinogenesis, but which also accelerates oocyte death, and that's why they lose their oocytes early, enter menopause early. But it also increases sensitivity to genotoxic agents, and chemotherapy is one of them. Because chemotherapy induces double-strand DNA breaks, and if the oocyte cannot repair this, the oocyte would die. We hypothesize that a woman with BRCA mutations, when they receive chemotherapy, they would lose more oocytes. So we performed this prospective study, and we measured their ovarian reserve before chemotherapy and at 12 to 24 months post-chemotherapy, and compared those who were BRCA positive versus negative, or who were untested because they were low risk at that time. So this study shows the AMH recovery, meaning that we measured at baseline, we measured at 12 to 24 months post-chemotherapy, and there is some recovery at that point, but you can see that in patients who are negative or not tested because their low risk, recovery was better, and in women with BRCA mutations, the recovery in AMH was lower. This is logarithmic scale, so there's like 3 to 4 times difference. And if you limit this to just ACT, again, you see a 3 to 4 times difference. In other words, there are 3 to 4 times less recovery or more damage from chemotherapy to ovaries if you have BRCA mutations. This also goes hand in hand with the amenorrhea data. This is a data we presented at the San Antonio Breast Cancer Symposium, and the manuscript is under review. Again, longitudinally, we follow these women and looked at their menstrual recovery. And the 2 things that correlate with the risk of amenorrhea post-chemotherapy is 1, having an AMH of less than 2 at baseline, and having a BRCA mutation. In fact, in other models, BRCA mutation status appears to be most strongest predictor of chemotherapy-induced amenorrhea. Again, this is because their oocytes are more liable to chemotherapy-induced DNA damage and death. I told you that oocyte and embryo freezing can be done if you have at least 2 weeks, but with the advent of neoadjuvant treatments, there may not be enough time. So for those patients, we are using ovarian cortex freezing. This is something I first reported in 2000, which requires a laparoscopic outpatient surgery, but there's no need for ovarian stimulation, so that can be booked in a very short time. In a recent meta-analysis, worldwide, we show that live births are about 25% with this approach, with at least 2/3 of the women are conceiving after transplantation and about 80% regaining hormonal function. However, in our hands, the technique is even more successful. We've developed a specific technique with robotic surgery and using revascularizing agents to enhance graft survival. You see the first babies with these techniques, and they are now they are having brothers and sisters. If you look at our data, 100% of the transplanted patients had endocrine function. We were able to generate embryos, and those attempting pregnancy all conceived. So the outcomes look very good. And so this is a technique that's no longer experimental as well. And finally, I want to talk about the ovarian suppression. During the guidelines, we reviewed the 7 randomized controlled trials. With the exception of 1, none of them showed any benefit to fertility. One study initially suggested, that's the POEM study, there may be some benefit, but when we adjusted it for the intent for pregnancy, because it was different, then the difference disappeared, because women who had ovarian suppression were probably more likely to be triaramine controlled for that. So we do not recommend ovarian suppression as a fertility preservation method. There's also no biological plausibility. Remember, the primordial follicle targets primordial follicles by inducing massive DNA double-strand breaks. And these follicles do not have any hormonal receptors, whereas GnRH analogs work through suppressing hormone production, estradiol, FSH, LH, and eventually estradiol production, but follicles do not see that. So there's no biological plausibility. This is a method that's proven ineffective in males because it's easier to show in men. You can just count their sperm easily, but in women, we can't count their primordial follicles easily. But in animal studies, we can see that it's ineffective. So we do not recommend ovarian suppression. Finally, safety of pregnancy. Every single study showed benefit or no damaging effect. But I wanted to show you one of the later studies from Lambertini, about 8,000 women in control and study arms. And this study shows an actual benefit in a protective effect in breast cancer, pregnancy in breast cancer prognosis. And they also didn't find any detrimental effect in BRCA-mutated patients, but the data are small there. There is now a current study going on, which we're also contributing. Hopefully, this will answer that. One interesting thing was that the woman who had breast cancer and pregnancy seemed to have higher risk of low birth weight and preterm birth, which needs to be further studied. With that, I want to conclude that there are numerous fertility preservation options are available with sufficient success, which include embryo and oocyte freezing. They're not experimental. There are new flexible ovarian stimulation protocols which shorten the time for fertility preservation. Ovarian freezing success rates are clinically acceptable. It's no longer experimental. Women with estrogen-sensitive cancers may safely preserve fertility, but BRCA mutation carriers have triple whammy. They start low, they may lose more, and on top of that, they may be aging at a faster rate. So these patients have to be counseled, especially more carefully. Ovarian suppression is not recommended for fertility preservation. There's no biological plausibility, and pregnancy appears to be safe after breast cancer. Probably women with BRCA mutations too, but we need further data. With that, I would like to acknowledge my research laboratory at Yale, our Fertility Preservation Institute, my collaborators at Yale, Dr. Lasberg, Dr. Rosenbluth, my Memorial Sloan Kettering collaborators, and the support from NIH and NICHD. Thank you so much for allowing me to present here. Have a nice day.
Thank you so much, Prof. Oktay. Definitely the breast cancer and pregnancy and fertility always a big concern, especially when it comes to young and breast cancer. So no doubt chemotherapy can impact on the infertility, but also endocrine therapy and the duration of endocrine therapy also can impact on the timing of pregnancy, and that's probably lead us to the next topic for today. I would like, it's my pleasure to introduce the next speaker for today's event, Dr. Kausar Sulaiman. Dr. Kausar Sulaiman is a medical oncologist at King Faisal Specialist Hospital in Riyadh. She's a medical oncologist, senior medical oncologist who's working on breast cancer for many, many years. And so she has quite experience in this field. And definitely this is the most question that we also have at our clinic is when to interrupt the endocrine therapy, how safe is to do this, and just to have pregnancy. So she will walk us through how to hold endocrine therapy for a pregnancy. Is it safe in those patients with the breast cancer? So the mic is yours, Doctora.
Assalamu alaikum. And Nafisa, thank you very much for inviting me and providing me such an interesting topic, which is my area of major interest. And thank you, Dr. Tojri, about your kind introduction. And all ladies and gentlemen, Assalamu alaikum. So today I would like to present the pregnancy outcome and safety interruption therapy for women with endocrine responsive breast cancer, initial results of positive trial, which was presented in San Antonio Breast last year. And this is a very interesting topic and very challenging trial, which was very courageous. And we all were provided a guidance, basically, which we were using our brain and struggling, and depending on your confidence level, we were talking to the patients. So basically, background is, as we all know, especially when we are treating these patients, and especially in our part of the region where we have very young patients with the breast cancer, and we see that they have a desire, and it is natural to have a desire of pregnancy. There are many retrospective evidence that showed that the pregnancy after breast cancer does not worsen the disease outcome, regardless of the hormonal receptor status. And as we all know that when we have a patient with a triple negative or ER negative, we become more comfortable after 2 years. Okay, yeah, you can try to go for pregnancy. But once it becomes the ER positive or the stage of the cancer, what we did like a stage 3C like this, then we get like really shaky what we should advise them. So as we know that the standard 5 to 10 years of adjuvant endocrine therapy compromises the conception in women with hormone receptor positive disease. And as we got just now very detailed about the infertility thing, this lecture prior to this, which really gave me the numbers also that how much is the decline in the hormonal sensitivity of patients and anti-Mullerian level monitoring. So pregnancy after breast cancer, interruption of endocrine therapy to attempt pregnancy has not been studied prospectively, as we all know. And it is a very courageous study. What they did is a positive trial they designed with the safety criteria. Of course, we want patient safety is first for any type of management we do it, especially in curable stage. So they did this trial with the thoughtful, detailed thinking about how they should run this trial. They addressed the question, is it safe from a breast cancer relapse perspectives to temporarily interrupt endocrine therapy and attempt pregnancy, or enroll only women with hormone receptor positive disease? As we all know, when we are treating these patients, even before trial, those patients who were willingly and were persistent that they want to get pregnant. We all have done these type of things in our practice with the patient when they were insisting to get pregnant, but we never did prospectively as a trial, and we have not done, we have not offered that you go for it. When patient insisted, we did this thing. And usually we were offering them 2 to 3 years after the endocrine therapy. In this study design, they had a safety criteria. Number one was duration of prior endocrine therapy, which was must. As we all know, first 2 to 3 years is a higher risk of relapse. And then the timing of pregnancy attempt and resumption of endocrine therapy. So in this, they chose a patient, premenopausal women who are willing to become pregnant. Their age is less than 42 years at study entry, at least 18 months and no more than 30 months of prior adjuvant endocrine therapy for at least stage 1 to 3 hormone receptor positive breast cancer. Actually, my presentation became very easy prior to this. The very interesting, very knowledgeable infertility, this management lecture has helped us a lot, and that we can understand that why they cut off the age and what was the reason of using the endocrine therapy. And we know that the endocrine therapy also declines that anti-Mullerian level. They allowed the prior neoadjuvant and adjuvant chemotherapy plus minus fertility preservation was allowed. No clinical evidence of recurrence at the time of study should be there. So this, you can see this timing, what they have made this thing. I don't know how can I make this. Yeah. So you can see that 18 to 30 months adjuvant endocrine therapy was must. Then within 2-year period, the 3 months washout period time, this washout period time is different than what is FDA guideline is for 8 months or 9 months of the tamoxifen. They did on the basis of 7 days is half-life of tamoxifen, and then they considered, okay, maybe about 35 days it takes completely washout time from whole body tissues, and still they gave 1 to 2 more months for complete safety reason. And then they allowed within this 24 months, 2 years time period. During that, conception, delivery, and breastfeeding all was included. So patients who have not conceived within 1 year, they allowed or strongly recommend for the fertility assessment and help. And if the patients are not pregnant within this 24 months, they should stop and start doing the hormone therapy. And then their plan was to have a long-term follow-up up to 10 years. So primary endpoint was breast cancer-free interval, time from enrollment after 18 to 30 months of endocrine therapy to first ipsilateral, locoregional, or contralateral invasive disease or distance recurrence. Secondary endpoint was pregnancy outcome, offspring outcomes, breastfeeding and all, as well as distant recurrence-free interval, which was time for enrollment to the first breast cancer recurrence. So plan and sample size was 500 women. Primary analysis plan after 1,600 patient years follow-up with less than or 46 breast cancer-free interval considered safe. A cohort of 1,499 soft text patient used as the external control because it was not double-blind or randomized trial. It was a single-arm prospective trial. And they used the boost strap matching method to compare positive versus soft text control for breast cancer-free interval and disease recurrence-free interval. They use the soft text cohort with the same mesh groups with the positive trial. In this study, they presented the primary analysis of breast cancer outcomes and secondary pregnancy and offspring outcomes. This trial will be running until 2029. It will be followed up to 2029. So this trial was international trial, and it was the effort of 116 centers across 20 countries on 4 continents. It was a very collaborative trial, which was really very successful. And we can see that how much patients are interested in this, and probably it was long waiting for this trial. This was between 2014 till 2019 cases were enrolled, and 518 patients were enrolled. Then 2 of them were excluded from the primary efficacy analysis population. 516 patients were watched for the primary efficacy analysis, and then 19 patients were excluded from the secondary endpoint population. Median time from breast cancer diagnosis to enrollment was about 29 months, and median follow-up was 41 months. You can see the key treatment patterns, and it was 42% received SERMs only, and you can see that about 52% they received the SERMs plus ovarian function suppression and AI plus ovarian function suppression. It was more tamoxifen, which was SERMs were used, than AIs. Prior neoadjuvant and adjuvant chemotherapy was present in the patients, and it was about 62% patients. Of course, you know that the early younger patients have more aggressive disease, and most of them end up getting the chemotherapy. All type of surgeries were enrolled. So I have mentioned there was I'm sorry, one slide is missing. There was in this trial at about 8.9% patients has breast cancer free interval did not meet actually. It was 46 patients, 44 events happened in positive trial. It was, but it was compared with the text and soft trial. It was almost overlapping. Statistically, was not different. Similarly, disease recurrence-free interval was also not different when it was compared with the soft and text trial. But the events in positive trial was 44 events, which was equal to about 8%. And if you go, I don't know, can I go back? And if you go for the disease recurrence-free interval, distant disease recurrence-free interval was about 4.5% in positive trial. But it was overlapping with the soft and text trial. It was not different. And you can see the 3 years breast cancer-free interval cumulative incidence was across the board. All type of things were, you can see, were positive in positive trial. It was like depending on the HER2 status. Actually, in the beginning, they mentioned that they enrolled only ER positive patients, but looks like a small percentage of HER2 positive with ER positive patients were also enrolled. You can see patients with the lymph node positive 1 to 3 and 4 to 9. They cross on the right side. And in this study, the very important part was 90% of the patients were about stage 1 and 2. Very few were stage 3. And with the size of tumor, if you look at these patients on the subgroup analysis, we know that the higher the size and more the lymph node, they have a higher the risk, right? And those patients cross on the right side. So this gives us some evidence that we should be a little bit careful looking at the patient overall condition and what their risk of relapse is in terms of advising them. So breast cancer-free interval for pregnant versus non-pregnant patient, 18-month landmark analysis. It was showing breast cancer-free interval. It was no pregnancy as well as pregnancy by 18 months. You can see the difference was pregnant versus non-pregnant by univariable, and multivariable was not different. And we can see the 368 of the 497 women in the secondary endpoint population had at least one pregnancy, for a total of 507 pregnancies. 317 had at least one live birth, 64% of all women, and 86% of those who became pregnant. 66% were vaginal delivery, and cesarean section was 34%. Pregnancy complication, 11% of the pregnancies. Most common pregnancy complications were, of course, hypertension, preeclampsia, 3%, diabetes, 2%, which was not related with the having an underlying disease with the pregnancy. And stillbirth and neonatal death was very minimum, which was not related with this. It is the average incidence we see in normal situation. And I'm sure the doctor who we have, Dr. Sorry, I forgot your name. You will be able to give us a more input how much he's a high-risk pregnancy physician, and he can give us the information that how much incidence they see in the normal other than the cancer patients. Offspring's outcome was 350 live births for the 317 women who had at least one live birth, and 335 singleton births and 15 sets of twins. 62% of 317 women reported breastfeeding. So we can see the patients who resumed the endocrine therapy, cumulative incidence at 48 months, 8% had a cancer recurrence, as we saw earlier, that in the their safety data, 8% had a cancer recurrence death before resumption of endocrine therapy. 76% resumed endocrine therapy, and 15% had not yet resumed endocrine therapy. This 8% really alarmed me, but when they compared with the soft and text trial and superimposed the data with each other, it was not different, which that was comforting. So conclusion of this positive trial is temporary interruption of endocrine therapy to attempt pregnancy among women who desire pregnancy does not impact short-term disease outcome. 74% of women had at least one pregnancy, most 70% within 2 years. Birth defects were low, 2%, not clearly associated with treatment exposure. Follow-up to 2029 plan to monitor endocrine therapy resumption and disease outcome. These data stress the need to incorporate patient-centered reproductive health care in the treatment and follow-up of younger women with breast cancer. I included some debates about this. If you allow me, I can give you some information, because this was a very interesting topic and there was a lot of questions and strengths and weaknesses were discussed. So, sorry, this is. So what they found that when this was presented, there was a debate about this, and they found that the patient inclusion age was 43% had an age 35 to 39, and 75% of those women never had a birth. So we can see those patients who were very, very interested to get pregnant. And as the women are getting more educated and the more career-oriented, they are delaying their pregnancy. And that is the real life patient population who is facing, and we are facing this challenge daily. in this. So these were the real life patient population, educated patients who are career oriented and delaying their pregnancy. 94% of the patients were stage 1 or 2, which is very important before we implement this type of trial in our patient population. This was a strength and weaknesses, or maybe the things it is not possible, weaknesses or difficulties to make it. Like a first strength, the thing which we all were facing whole our life when we are managing this, the question what patients were asking and we were avoiding really how to answer was how to tackle this question. It is a very good international collaborative effort, gives first look into the safety of a practice that was already happening, and follow up in offspring use of reproductive technologies, long-term survival plan. Weaknesses or difficulties was that, of course, we always claim that the it should be a randomized. Of course, it was not randomized, but it was a prospective trial. It was a single arm trial, and 18 to 30 months is the wide range of window before eligibility. Like some patients have received 18 months up to 30 months. But median time, what I noticed that it was almost 2 years, 24 months. It will need to tackle any inconsistency in long-term resumption and length of endocrine treatment, needs of longer follow-up for hormone receptor positive study, because we know that the hormone positive can have a recurrence even on 20 years also. There are multiple guidelines, multiple database now available, decision aids and tools. Wide risk estimates do not account for the ovarian reserve measures, comorbidities, personal fertility histories, different type of chemotherapy. We are using more and more dose-dense AC and Taxol, and we just saw prior to this study presentation how much is the suppression of ovarian function is happening. And need to move to the next step. We have to use the artificial intelligence to better identify who is at risk, use of EMRs, reproductive colleagues, etc. in our studies. So challenging of this study is to design and execute as to existing data and safety of subsequent pregnancies after diagnosis of breast cancer, and before holding 18 to 30 months. Does it require, like especially now we have a high-risk patients who are requiring abemaciclib for 2 years. So what we are going to do with these patients? Should we interrupt those, or are we going to delay it up to abemaciclib is completed? Early result promising, however, given the nature of hormone receptor positive disease, long-term follow-up is required. Fertility concerns and all, and future pregnancies, time of better assessment tools, etc. We should use it. I'm happy to answer any questions you have, please.
Thank you very much, Dr. Kausar. It was an amazing and interesting topic. I think we'll keep the question till the end of the session. If you allow us, we'll move to the next talk that will be presented by Dr. Hayat Rabia. Dr. Hayat Rabia is a consultant reproductive endocrinology fertility. She's the section head of reproductive endocrinology and infertility unit in King Abdulaziz Medical City, Ministry of National Guard in Riyadh. And she's going to talk about fertility preservation methods and timing. Join me in welcoming Dr. Hayat. Dr. Hayat, the stage is yours.
Thank you very much, Dr. Haitham. Good morning, everybody. I'm sure this morning we talked a lot about fertility preservation. I'll talk briefly about methods and timing, and a brief information about King Abdulaziz Medical City Clinic. number of patients, and the progress of the clinic itself. بسم الله الرحمن الرحيم. قال الله تعالى: ومن أحياها فكأنما أحيا الناس جميعا. Fertility preservation is becoming increasingly important to improve the quality of life in cancer survivors. Despite guidelines suggesting that discussion of fertility preservation should be done before starting cancer therapies, there is a lack of implementation in this area. A number of techniques are available for fertility preservation, and they can be used individually or together in the same patient to maximize efficiency. Treatment of malignancy, as well as some precancerous and benign condition, may necessitate surgical resection of reproductive organs or administration of gonadotoxic chemotherapy or radiation therapy. This often leads to infertility, which is a major quality of life concern. As survival rates and life expectancy of those with malignancy continue to improve, increasing numbers of youngs are referred for fertility preservation. However, often chemotherapy must be initiated immediately with no available window of opportunity for fertility consideration. Actually, in these cases, fertility preservation can only be considered after the gonads have already been exposed to chemotherapy. And that was in the past in our hospital. We as a gynae receive the patient usually after chemotherapy. Alhamdulillah, after initiating and implementation of the fertility preservation clinic, we managed to pick up the patients early before receiving chemotherapy or radiation. The need for fertility preservation has to be weighed against morbidity and mortality associated with cancer. There is thus a need for multidisciplinary collaboration between oncologists and reproductive specialists to improve awareness and availability. There are no large randomized clinical trials evaluating the majority of the interventions described, nor are there long-term follow-up studies assessing the possible impact of fertility treatment on cancer survival. Pre-treatment counseling. In 2006, the American Society of Clinical Oncology first published recommendations on fertility preservation, stating that as part of education and informed consent before cancer therapy, oncologists should address the possibility of infertility with patients treated during their reproductive years and be prepared to discuss possible fertility preservation options or refer patients to reproductive specialists. The American Society of Reproductive Medicine Practice Committee recommends that mental health professionals and genetic counselors be available to counsel the patient and help them in decision-making. Genetic counselors are required to discuss any potential risk of a transmission of the disease to the resulting offsprings and available genetic testing in the heritable diseases. Actually, fertility preservation requires individualization. The optimal approach depends upon the type of gonadotoxic treatment. Radiation versus chemotherapy depends on the time available and urgency of a treatment, patient age, the specific disease, marital status, and long-term issues, storage and use of frozen gametes or embryos. It should be a joint decision of the reproductive endocrinologist, hemato-oncologist, the patient itself, herself, and the partner. Gonadotoxic chemotherapy. Chemotherapeutic drugs act by interrupting vital cells process and arresting the normal cellular proliferation cycle. And no wonder then that they have such a damaging effect on the germ cells. They cause DNA abnormalities as well as oxidative damage in somatic and germ cells. And they result in persistent unrepaired DNA double-strand breaks, activate apoptic death in oocytes. And they produce genetic effects on the oocyte, which result in aneuploidy and early embryonic mortality. And the updated guidelines is 2018 ASCO guidelines in the fertility preservation cancer, and this is what we are following currently. We will start with adult female patient. Chemotherapy has a varying effect on ovarian function. It induces apoptosis of the primordial follicle pool, damage to the ovarian cortex, ovarian atresia, and reduce ovarian blood flow. Since chemotherapy affects proliferating cells, primordial follicles at rest during treatment may be protected. The worst reproductive consequence of chemotherapy is irreversible ovarian failure, leading to permanent sterility and early menopause. Many women have transient amenorrhea. However, even in those who resume menstruation, the primordial follicle pool may be diminished. Following chemotherapy, women may have early menopause with a period of reduced fertility and then premature ovarian failure. This may occur several years after the completion of chemotherapy. We have to have a marker to monitor the patient fertility insult, like biochemical markers, FSH, estradiol, and anti-Mullerian hormone, or by radiology, by pelvic ultrasound, measuring the antral follicle counts. Methods for fertility preservation before chemotherapy. The choice of fertility preservation technique depends on the patient's age, ovarian reserve, urgency of a treatment, marital status, disease prognosis. It requires careful counseling and guidance combined with realistic expectations of a treatment success. We'll start with the first method, GnRH agonist. Ovarian suppression with GnRH agonist before chemotherapy may reduce the insult to the ovaries. This can be combined with other fertility techniques. Currently, there is insufficiency. Unfortunately, there is insufficient evidence regarding the safety and effectiveness of gonadotropin, releasing hormone analog, and other means of ovarian suppression or fertility preservation. Women interested in this technique are encouraged to participate in clinical trials according to ASCO guidelines. Because dividing cells are known to be more sensitive to cytotoxic effects of alkylating agents than are cells at rest, it has been suggested that inhibition of the pituitary gonadal axis would reduce the rate of oogenesis and thereby render the germinal epithelium less susceptible to the effect of chemotherapy. Usually administered every 20 to 30 days by intramuscular injection starting no sooner than 4 weeks and at least 7 days before the first cycle of chemotherapy, and continued throughout chemotherapy duration. Me personally, I prefer to give another 2 cycles. If the patient receives 6 cycles, I prefer to give her another 2 cycles just for the residual effect of chemotherapy. Second method, embryo cryopreservation. And this technique, which seems to offer the most promise, is in vitro fertilization with embryo cryopreservation by vitrification. In fact, embryo cryopreservation is the only well-established method of fertility preservation. Ovarian stimulation depends on the time available before the commencement of cancer treatment. If time permits, approximately 2 weeks of ovarian stimulation with daily injection of FSH hormone is required and must be started within the first 3 days of menstrual cycle. If time does not permit, we use usually the random stimulation. Third method, oocyte cryopreservation. Women who is unmarried or does not have a partner, divorce, there's a mature oocyte cryopreservation is carried out. Oocyte cryopreservation requires the patient to go through ovarian stimulation again and ovum pickup, either transvaginal or transabdominal in single patients. In fact, data on a pregnancy and live birth rates from oocyte cryopreservation in cancer patients are few and not sufficient. Ovarian tissue cryopreservation, another investigational option for fertility preservation, which is a cryopreservation of a tissue and re-implantation at a later date. Ovarian tissue cryopreservation, though considered experimental at present, has a wider clinical application and the advantage of keeping the fertility window open for a longer time. But again, it is experimental. Adult male patient, after chemo treatment, sperm production shows, this will not talk because we are talking about female mainly, so we'll skip the adult part. For female prepubertal, also another method, but we'll not talk about it. Okay. Surgical strategies in fertility preservation, ovarian transposition. Protect ovarian function by moving the ovaries out of the field of radiation, and the ovaries are moved outside the pelvis and anchored as high as possible above the pelvic brim, either in the paracolic gutter or anterior abdominal wall. I will talk briefly about our oncofertility clinic in King Abdulaziz Medical City, National Guard Health Affairs. It is a standardized fertility preservation program, was launched at our institution in April 2018 as a part of multidisciplinary team, including oncology, reproductive medicine, and infertility initiative to improve the reproductive needs of oncology patients. After 2 years, we assess the pattern of the use of fertility preservation services. The clinic is staffed by a reproductive endocrinology and infertility consultant with the help of the team from a medical oncology. It is held on a weekly basis and receives referral from medical oncology, hematology, stem cell transplant, and radiation oncology. So when we started the clinic in 2018, we received 17 patients. Now in 2022, we saw 157 patients per year. According to fertility preservation method, we started with a 3 procedure in 2018, reached now 30 procedure per year in 2001. Conclusion, the 2 methods of fertility preservation with the highest likelihood of success are IVF, embryo-freezing, and oocyte freezing. And data are very limited, but there appear to be no detectable increased risk of disease recurrent associated with most fertility preservation methods and the pregnancy, even in hormonally sensitive tumors. Thank you.
Thank you so much, Dr. Hayat. I think we'll leave the question to the end. We have spent time discussing the risk of anti-cancer therapy and fertility and how to work on that in terms of preservation, technique, endocrine therapy, interruption, and so on. But we come across, and this is not really uncommon situation where we have to deal with pregnant women in, who have breast cancer, and instead of treating the patient, you need to take care of, I would say, both. So that's probably leading to the next topic for today. It's my pleasure to introduce Dr. Ahmed Saaduddin. Dr. Ahmed Saaduddin is well-known senior medical oncologist. He's a former consultant at National Guard. He's now the chairman of Department of Oncology as specialized medical center in Riyadh, KSA. He has quite a special interest and long experience in breast cancer management as well as prostate. I always enjoy his talk. So, Dr. Ahmed, I think he will walk us through how to optimize breast cancer treatment during pregnancy, which is something we do see right now in our practice. Thanks.
Thank you very much, Abdullah. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for the introduction. And it's always a pleasure to see friends whom we did not meet for such time. Optimizing breast cancer treatment during pregnancy is, as Dr. Abdullah mentioned, is a topic which we have to face every day, almost every now and then in our clinic. And I hope I can tell you something which you don't know, okay? It's a challenge because there is a lot of age-specific diagnostic, treatment, and survivorship issues and challenges related to treating breast cancer in young women, and pregnancy is really a very important thing. I don't want to dwell on things which has been mentioned before, but as you know, the biology is different. The interest of the lady is different. The impact of chemo and endocrine therapy is different. And psychologically, they are totally different cohort of patients compared to postmenopausal ladies. And all of this actually will lead to different treatment and care methodology for these patients. I think it's becoming a subspecialty by itself, treating breast cancer in young women. That is really moving into becoming a distinct subspecialty. We don't have it yet in our country, but I think soon we might have to develop this. As you well know, there is actually a rising trend internationally to delay childbearing. Before I say this, you know that we have a larger percentage of patients who have breast cancer who are really young. And delaying pregnancy till that age is actually making the pregnant lady with breast cancer more than we expect. So we need to keep that in mind while talking about this topic. So it's not something uncommon we might face in our clinic. The first question which will face us is what chemotherapy? Okay, so that is, as Dr. Abdullah mentioned, something we have to answer. What do we know? Nothing much, but we have some retrospective data to say, to tell us that maybe some drugs are safe, others maybe are not safe, but I don't think we have level 1 evidence for anything. But as you can see, AC has been tried in 16 patients, FAC in 57 patients, 28 and 57, weekly epirubicin in 20, and AC followed by taxanes, almost 200 patients. As you can also see, that let's start with the congenital malformation. It's all less than 5%. So if any patient have any of this, don't think a disaster is definitely coming. But in AC, for example, the congenital malformation was 0 in a small number. The incidence is 5% in FAC and 5% in weekly epirubicin. And the rest, whether it's gestational age or weighted delivery, which is an indication of fetal abnormality, were both normal. So that is sort of reassuring in a retrospective manner that chemotherapy is not that harmful. Of course, we are talking about second trimester and above. Nobody would dare giving first trimester, except, I was the first one to report the use of taxanes in the first trimester by coincidence. A patient did not tell me that she's pregnant, and we have given her taxane. She delivered the baby, and we reported that back in 1998. Doxorubicin and epirubicin are very common drugs we use in breast cancer women. And again, the concentration in the placenta and heart are not much, and they seem relatively safe in both the lady and her fetus. This is the anthracycline-based chemotherapy used during pregnancy in many retrospective data. And as you can see, comparing the child to the control, there was no clear effect on the heart of the born child, except for shortening fraction and ejection fraction, which is less than by 6%, and eventually most of them have recovered. But the rest of indicators of the child heart seems okay, and that's why, again, the penetration of the drug into placenta is not really that much. So it sounds reasonably safe to use anthracycline-based therapy. What about taxanes? Again, retrospective data, small numbers, but reassuring, whether it's paclitaxel or docetaxel. And as you can see, the fetal complications were related to the chemotherapy, basically anemia and neutropenia, and the number is very small, but the malformations were almost zero, only pyloric stenosis in one. And the fetal weight was almost 2.5 kilograms. So everything went fine with taxanes, no clear contraindication to use it. So again, we have another drug which might be good to use in a pregnant lady, which is taxane treatment. How many cycles? The important other question. Sorry, I made my lecture just go straight to the point instead of dwelling through a lot of retrospective data. That is a very good representative retrospective data to answer this question. There is no big difference between 4, 6, and 8 cycles. So push as much as you have to with no clear harm done to the baby. The fetal score was basically not related to the number of chemotherapies given. What about Herceptin? A very important question. We have a few retrospective data again. This one, if you concentrate on the first column, pregnancy on Herceptin, trastuzumab, as you can see, congenital abnormalities were zero. So is it safe? Big important questions. Pregnancy after Herceptin, we are not, discussing this, but it seems again, it seems safe. And this is the comparative arm with no Herceptin. So live birth, completed pregnancies was in almost third of patients, 5 out of 16. So no clear, again, contraindication to use trastuzumab in this retrospective, very small number of patients. Is it true? This actually study confirmed that this is not. Exposure of the baby to Herceptin during pregnancy increases fetal morbidity. This is a larger meta-analysis of many studies. And as you can see, anhydramnios and respiratory failure was actually almost a common side effects of Herceptin during pregnancy. So the conclusion that avoid Herceptin during pregnancy because of this. Again, retrospective data. Shall we induce early delivery or shall we make it full? As we know that the longer the baby stays in his mother's tummy to complete the term is better, because the complications of preterm delivery is more as the number of weeks is actually less, and it's very clear, especially cerebral palsy and mental retardation. So the message from this slide, try push the gestational age as much as you can. That was the message of this point. What about future pregnancies? Is it safe, but without using any form of assisted reproduction? Is it safe and assisted reproduction can be considered? Questions which we will go through quickly. It is not preferred in ER-positive breast cancer because it might actually stimulate recurrence. Where do we stand with this? The fact is that almost a third of patients, young patients, raises fertility concerns and it affects their decision on treatment. I'm sure all of us have met such patients in the clinic who say, anything which is going to impact on my fertility, they will be reluctant to have it. And fertility is a major issue for young women at diagnosis and beyond. That's what we need to think of when we interview them in the clinic. As you can see, between 20 and almost 40% of ladies are interested in having babies even after diagnosis. Pregnancy rates after treatment of breast cancer, as we all know, that actually it's affected. Patient with cancer has 35% reduced likelihood of subsequent pregnancies, and only 4.2% of breast cancer patients have subsequent pregnancies. And when we deal with a lot of young women, how can we balance between these two issues? Maybe this has been mentioned before. We have many ways to try and preserve the fertility for them. Oocyte cryopreservation has been accepted since 2012, and ovarian suppression, of course, have been in practice since 2018. There is a prospective study which is going on in endocrine responsive breast cancer patients, pregnancy outcome and safety of interrupting therapy for women with endocrine therapy. This study, I think, have completed its accrual, but we are still waiting for its data, which is very important. This is a prospective data which we are all waiting to see, but we have some retrospective data of prognostic impact of pregnancy after breast cancer according to ER status. This is a study which was published in the Journal of Clinical Oncology, the Blue Journal, almost 10 years ago. And as you can see, good number of patients compared to double matched control, a grade 2 and 3 in good percentage of patients. Almost 58% were HER2 ER positive, and 42% were negative. Adjuvant chemotherapy to almost 80%, and median duration of hormonal therapy 5 years were almost 70%. Very clear message. There is no impact on survival from being pregnant after breast cancer, even if you stop hormonal therapy. So pregnant after breast cancer and matched control, we're almost on top of each other all the way, even after 10 years. The secondary endpoint was in whole population, not only ER positive, and this is the same. And this is what we tell our patients in the clinic, that they can get pregnant. The question is when to start planning for pregnancy. Abortion, does it improve patients' outcome in breast cancer patients? The simple answer is no. So we don't advise for it unless we have to. Fertility preservation strategies, I'm sure this has been touched upon before, but we all know that chemotherapy induces amenorrhea, avoid CMF because it's up to 80% in young women, while AC and FEC or FAC 25 to 30%. I don't like TAC in premenopausal women because the amenorrhea rate is really high, more than 60%. Ovarian suppression is good because it gives 50% higher chance of resuming menses at 12 months if you use it or don't use it, using LHRH during chemotherapy. And the pregnancy rate is higher with LHRH as well. Are LHRH reliable preservation methods? The answer is not. You cannot tell a lady that for sure you will regain your fertility. It's something we can try, but it's not really 100% reliable. What about ovarian stimulation? Of course, we all have concern that it will increase the estrogen level. And does this increase the recurrence rate? And what about delaying starting adjuvant therapy because of a few weeks of waiting time really to have this done with? This is a study done by Dr. Azim Jr. and colleagues in Netherlands. Safety of fertility preservation by ovarian stimulation with letrozole and LHRH in patients with breast cancer. Prospective study. It was actually safe in short and long-term follow-up, while the relapse-free survival rates were almost similar. If anything, is actually better than control. and this is a retrospective data to say that is, from 9 deliveries, you get 11 children, and 6 deliveries, you get 10 children, indicating you get more twins with this one without affecting survival. So I will conclude this topic by stating that fertility and pregnancy after breast cancer are critical issues for young women. Anthracycline-based regimens and paclitaxel can be considered safely. Trastuzumab should be avoided. Full-term delivery as much as you can. Pregnancy post-therapy is safe, and assisted reproduction can be considered. Fertility preservation strategies to be considered includes concomitant administration of LHRH with chemo. Ovarian stimulation for oocyte or embryo preservation is also relatively safe, and I think we should do a lot of effort to really have better answers to these questions. Thank you very much.
Thank you so much, Dr. Ahmed, and thanks all for the speaker. So maybe we'll start with one question for you, Dr. Ahmed. You have mentioned that pregnancy in breast cancer is quite, you can have a seat, doctor, or you would like to? It's quite uncommon situation, but there's also something we do see in our practice. One of the common subtypes that mostly we do see, in fact, and especially when we deal with the pregnant women with breast cancer, is triple negative, which is something quite common histology that comes in younger. And now we are using more of immunotherapy. And we are using more of immunotherapy. And the question is, what is the safety of immunotherapy in the neoadjuvant setting for a triple negative breast cancer woman?
Thank you for, do we have another mic or? Okay. Thank you for the question. Again, a new common scenario. The simple answer is we don't know. So personally, I don't use it during pregnancy. I don't know what Dr. Kauthar is doing.
Or you mean triple negative for
negative immunotherapy. Do you need to use immunotherapy? Are you using it for pregnancy?
No. Actually, I had one question with our obstetric colleagues. As we know, the pregnancy and breast cancer, we offer the chemotherapy. What is the time period you prefer to stop the chemotherapy? 34 weeks, 35 weeks? Because usually our OB physicians say that at least 3-4 weeks needs to be disease without chemotherapy. But what time period you prefer us to stop?
I think, Doctor, 3 weeks is reasonable, and
30 weeks, you mean?
Yeah, and up to 34, 35 weeks we can go. The issue is that we face that the patient are asking for early delivery. They're pushing for early delivery sometimes, though with multiple session and discussion. The mode of delivery also may dictate also if it's vaginal or cesarean section, but our experience, we're going up to term with patients. Yeah.
If I may comment on that, I think we are trapped between our fear of giving more chemotherapy during pregnancy and, as has been mentioned, the wish of patients to have early delivery. The scientific data we have so far, although they are not level 1 evidence, that we can give as much chemotherapy cycles as you can, between 6 and 8 you can give, and full-term delivery is better. So I think even my practice have changed in the last 5 years. I try to push to the full term,
yes,
before delivery, and it is actually feasible and safe. Again, from all the data, we don't have any data to say that this is contraindicated, although we have no level 1 evidence.
Yes, I will touch quite sensitive topic that's we might come across as oncologists, as also gynecologists, is we always try to avoid termination of pregnancy, but sometimes this is something we have to do at some point, whether a patient in first trimester or someone with metastatic breast cancer, where it's quite difficult to get through the treatment as well as the pregnancy at the same time. And it's really, I always wonder whether it's is it the patient decision, or is it oncologist who look at the risk, or gynecologist who also look at the risk of pregnancy, or it's a committee? How to look in this and from a legal point of view, ethical, religious, and who make those decisions?
Again, thank you for raising this. We have faced this actually in the clinic. You know, I'll give you a specific example of a nurse actually with us in the hospital. She was 42, newly married, have her first baby, and she said, listen, she came, almost at the end of the first, 2 weeks to the full term. She said, listen, Dr. Sandy, forget about abortion. She was advised for abortion by gynae because first trimester, I want my baby. So what I've done, I've actually waited for 1 week, divided the risk in between, waited for 1 week and started her on chemotherapy. We started easy chemotherapy. Her baby now is 8 years of age, doing very well at school. So you are absolutely right. We have to listen to the patients. This is not our decision. So we can tell her, listen, this is what we know. This is what we don't know. And she should take the risk with us. And I think we should try and bend to their wishes as well, as much as we think it's appropriately safe. If you agree with me.
Yeah. I completely agree with you. This is easier when we are dealing with the early stage. I have 2 patients, stage 4, they chose to continue therapy. One was HER2 positive, failed 3 lines, came from USA, with the PET scan was showing pregnancy. She chose to continue in second trimester. I gave her chemo, and after delivery, she died.
Yeah. Again, we have this scenario. There is a religious issue to this point. Is it religiously okay to abort a baby because his mother is going to die? Yeah. The answer is no. We went to the clerks and we have asked the question, Sheikh Ibn Uthaymeen Allah yarhamu, shakhsiyan. Yes, it's not allowed. This is a life and this is a life. We don't know what's going to happen to the mother, but we cannot kill the baby. So if it is safe to give chemotherapy during pregnancy, you give it, but you should not really terminate. We have many scenarios like this in my practice. So religiously, it's not actually okay to terminate a life because his mother is not going to live.
Wow.
Can we hear from a gynae perspective?
And they allowed us to terminate, but in first trimester.
In the first time.
We go with if we think that it is going to save her life, and we're still in the early stages, قبل نفخ الروح, which is the 19 weeks.
Yes.
We do have the option, but after that, it's it needs a lot of discussion and agreement. And we had a good experience with our colleague from oncology and the surgeon, the high-risk pregnancy doctor. When we meet together, we had our board, and we sit as a multidisciplinary with the patient. We tell them what we know, as Dr. Saadin mentioned, and a good number of them, we continue the pregnancy. We had a good number of success stories, but we do have a Dr. Nafisa can make comment also.
Yeah. But let me stress it. In the second trimester and above, in metastatic breast cancer lady with liver mets, let's say, whom you know that she's not going to survive to raise her child, maybe. Allahu A'lam, like, and this is our medical knowledge. And her baby can be saved, of course, after Nafkhul Ruh, I'm talking about second trimester and above. It is not allowed to do abortion religiously, because you are killing a baby because his mother is not going to live. That concept is okay in Western world, but in our religion, it's not allowed.
We usually
Okay, I'd like to make this very clear.
yeah. We usually don't do it.
Yeah, first chemistry.
Yeah.
Okay, yeah.
Yes.
You can do ultrasound, for example, and the ultrasound showed liver met.
I had a case that she came to me in the clinic, pregnant. She had lung cancer, not breast cancer, with meds, and she's pregnant. And she was telling me, doctor, I want to keep this pregnancy. He told me 8 years back that I'm going to die, okay, and I'm still alive, and I want to continue this pregnancy. So the matter of saving their lives, still we don't know very well when they will die.
But even if she comes to you and say, please abort my baby, you should not listen. You are
Yeah,
not
sure.
allowed to religiously.
Sure, doctor.
It's different issue.
Yeah. We do it through the comment. Yeah.
It is the same for non-pregnant fertility preservation. If we receive the case from breast cancer clinics for breast cancer case with meds for a reproductive age female, do we have to do fertility preservation or not? We received for stage 4, let's say.
I mean, stage 4, what's the point? We are talking a baby who is already خلق ونفخت فيه الروح. We are not talking about, okay, for metastatic, I will strongly advise against having a baby.
Yes.
Okay, we are not talking strongly advise. Even if she insists, I will do all the tricks for her not to get pregnant. You don't want, we all don't want a baby to be raised without a mother.
Correct.
But if we have to face one, you know, you don't kill him because his mother is going to go. That's my opinion.
I agree. We have to have an agreement for the referral of oncofertility clinic for the fertility preservation cases for the advanced stage, like stage 3 or stage 4. Stage 3 should be fine. We're not thinking stage 4. Preservation that we have but on stage 3, yes, stage 3 should be.
Stage 3 should be that.
Yeah.
So it's always depend on the intent of therapy. If you are treating for cure, definitely those patients you are looking for cryopreservation. So that's leading to the point of cryopreservation. Do you have a question, Dr. Sadel? Yeah.
And she was members of Justice Amount in that house. She's 39, okay? She's married, a very married. Okay? She was in 16, okay? To get her child and have the treatment and to get pregnant. It's not right, it's a debate. I cannot say, what do you remember that? And her CP, she had nothing, no answer to do with it.
Thank you, Sadel, for raising this real scenario in life. Okay, we all face this. First, I think HER2 positive breast cancer. There is some patients who are cured even in stage 4. We have to admit this. I have patients who are off therapy for 7 years after liver mets with no recurrence. So I think the definition of cure in breast cancer does not apply to all the triple negative, HER2 enriched, and luminal. So if a lady has HER2 positive in CR for a long time, yes, and she wants to have a baby, I will do exactly the same. I will discuss with her that stopping HER2 is, we are stopping it for even non-pregnant, after 5 years, 7 years, if they don't want, if they have any heart issues. So I'll stop it for 3 months. I say, try and get pregnant. If you don't, go back on therapy for 6 months and then retry in 3 months later. And if she gets pregnant, we will carry on with pregnancy. Because, as I said, we don't know the definition of fecunding HER2 positive. And we have to be human sometimes, and we need to listen to patients.
That's also page 4.
I was going to say actually.
It is a standard of care, like stage 4 with palliative intent. But I look it up that you mentioned it is stage 5 here. So whenever it says she HER2 positive, she's on remission for 5-7 years, yes, we send out for reservation. But this is not a guideline, because this is not a standard of care. This is stage 5 care.
Thank you so much, Doctor. We have a very short period of time. So I have just one question. I need just short answer because we have discussed the fertility preservation and how important this collaboration between the oncologist and the gynae, and sometimes the time frame is really critical, especially if you send those patients. Speaking about younger triple negative, I have to start chemo within 2 weeks. So what is the time frame that you need to do all ovarian stimulation in a way to do those cryopreservation?
2 weeks.
Putting the fact that also there is a time of referral and time patient to be seen in the clinic. So it's more than 2 weeks, in fact.
Really sure in clinic. Okay. They say 2 weeks, it might take up to 1 month. It depends how busy your center is and what sort of collaboration between you and the people, patients who are doing IVF. We have set a committee and we are achieving this in 2 weeks. But you need really good preparation for that.
Yes.
They need to have priority. They need to be seen the same day. They need to be started on the same day and so on. But if you give an appointment, she come in 2 weeks later.
Of the oncologist, how urgent it is. Usually, we do random stimulation for the cycle for the follicular phase. So we start as soon as possible. Like you call me today, I start with tomorrow. And the maternal response is not good. I advise not to continue. That's why sometimes it's more than 2 weeks. But if it is optimal response, and 2 weeks it will be fine because it is only a good reason or a very good reason. We don't want for a transfer and so on.
And how much we can wait as an oncologist actually depends on the type of patient.
Yes.
Some patients I can wait for a month, but others 1 day makes a difference.
That's why case by case, I cannot
Yeah.
say for.
Yeah. Thank you so much. I always advise the surgeon because the surgeon usually the gatekeeper, and we discuss this in tumor board and ask the surgeon to make a referral before patient come to my clinics, and that's maybe helping the time frame. Yeah. So just last question for you, Dr. Kausar, because we only have 1 minute. You have discussed an important trial, which is the positive trial, looking at the interruption, which is quite challenging trial to start with. I was wondering about the time frame, the follow-up. It's just a 41 month, I believe, if I code that. And how confident you make those decisions in terms of interruption of endocrine therapy for patient with breast cancer? And would you think the follow-up is enough, or in hormone positive, maybe it's not enough? What's your thought on that?
I will be very careful about choosing the first of all patients, because 90% of the patients were stage 1 and 2. When I treated their cases were very, very small. Tumor used to be node negative, and really Oncotype DX results really help. So I will be choosing very selectively the patients. And also, we all know the ER positive tumor, you cannot depend on the short interval. The long-term data will be very important. And mainly patients who are really, really motivated and pushing to get the pregnant, I will choose those patients. But with this response, I have one Islamic question. I see that the patients, we have a woman who is delaying their marriages and due to career and everything. So we have very many single female who are have a breast cancer and things, and they want to preserve the ovaries. Is it Islamically allowed to preserve that or not? Because in our institute, they're not offering patients who are single.
We have the fatwa.
Oh, you do?
We
Okay.
have the fatwa recent, the 2018.
And King Abdulaziz Medical City considered the first governmental hospital offering this service. And we started 2018. It's almost 5 weeks now, 5 years.
It used to be not allowed, but for the last 5 years it has been changed.
Thank you very much for all the distinguished speaker. It was an amazing session. Thank you very much. Thank you for the audience.
Okay, can we start? Yeah. طيب. بسم الله الرحمن الرحيم. السلام عليكم. So we'll start our next session. My name is Mohammed Al-Garni. I'm a consultant medical oncologist. I will be chairing this session with Dr. Monira Al-Majid. She's a consultant medical oncologist at Prince Sultan Military Hospital. And the theme of this session will be breast cancer in male and elderly, whether it should be treated differently or not. And I would invite Dr. Monira to introduce our first speaker. Please, Dr. Monira.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Al-Garni, for your nice introduction. And I would like to thank the organizing committee for inviting me to participate in this symposium. Dr. Ahmed Al-Jazairi is an assistant professor of cardiology at King Saud bin Abdulaziz University for health science and consultant cardiologist and cardiac images at King Abdulaziz Cardiac Center. He is at King Abdulaziz City at Riyadh. He's also the chairman of the Cardiac Images Working Group of the Saudi Heart Association, and he is a numerous peer review publications and many invented lectures and at local, regional, and international meeting. He will give us lectures about
Good morning, everybody. I would like first to congratulate the organizing committee for yet putting another successful program. These kind of programs has to be encouraged, quite honestly, because as we see more and more of this special group of population that would need more care, that we probably more specialized care than we think. Again, thank you again for inviting me again. Since last time we talked about the subject, a lot has changed, and I learned a lot preparing this talk myself. I have no disclosures. So why do we care about cardiovascular health in general when it comes to breast cancer patients? We know that breast cancer is the most or second most common primary malignancy in women. And the diagnosis in itself is increasing annually as 0.5%. And again, breast cancer mainly occurred in middle and elderly women, exactly the same age that we have more higher risk of having cardiovascular diseases. In addition, breast cancer and cardiovascular diseases have common pathway when it comes to risk factors. Both is more common in smoking, both more common in obesity, and both more common in sedentary lifestyle. In addition, many therapies are associated with cardiotoxicity. And if we put all this together with the fact that cardiovascular diseases are the leading cause of death in breast cancer, you could imagine the magnitude of care that we need to give to breast cancer survivors and breast cancers patients when it comes to cardiovascular care. Now, instead of talking about cardiotoxicity, we should probably talk about something like cardiovascular health in general. And this is a continuum when we should talk about lifestyle modification to improve the lifestyle in general, control medical risk factors, probably treat cardiotoxicity and prevent it if we can, then probably will result in improved survival overall rather than survival from breast cancer. Now, whenever an oncologist sees a patient, when it comes to cardiotoxicity, I do believe that there are three pertinent questions. First question, can we predict cardiotoxicity? Second question, what is the best surveillance strategy to detect cardiotoxicity? And then finally, prevent cardiotoxicity. Now, let's start with the first question. Can we predict cardiotoxicity? Unfortunately, the answer is not easy. There are 6 risk prediction models out there, but unfortunately, none of them is quite robust enough. They have high risk bias. They have small population size, loss of follow-up, low event rate in general when it comes to cardiotoxicity. And guess what? I think 2 of them have only validation, and not all of the study consider chemotherapeutic dose when it predict cardiotoxicity. Now, the most recently, Heart Failure Association of the European Society of Cardiology and International Cardio-Oncology Society had come up with a new risk model that was proposed in 2020. It's quite extensive if you look at it. Actually, I could not crop that risk in one page, and this is how extensive it is. But I think the idea that it is more extensive, although it is not appealing for us in clinical use, may tell us that this may be the risk model that we should use. It is a very comprehensive assessment. It looked at each individual chemotherapeutic agent, 7 classes of cancer therapy in oncology and hemato-oncology, and does not look only to LV systolic dysfunction, but all the cardiovascular adverse outcome, looking at myocarditis, looking at arrhythmia, prolonged QT, and valvular heart disease. So how does the model work? It looks at basics such as age, gender, and genetics. It looks at medical cardiovascular risk factor, look at lifestyle risk factors, previous cardiotoxic therapy and previous cardiovascular disease, and it adds some baseline tests as electrocardiogram, transthoracic echocardiographic cardiac biomarkers, and if there is any abnormality. So basically, we look at the cancer treatment, cardiovascular history, cardiovascular risk factor, physical examination, and vital sign measurement. But we also do complementary tests that should be probably done on a baseline, such as BNP, cardiac troponin, ECG, and hemoglobin A1C, kidney function, and lipid profile, and as well as transthoracic echocardiography. And as you can see, this is probably the usual care that we do for every single patient that come across us. I'm sure every cancer patient will have hemoglobin A1C, will have kidney function, lipid profile. I'm not sure how frequent you guys order BNP, but I think this is a test that can be done. Was that a reaction? Yes, a lot, or yes, little? Okay. Oh yeah, so this is the AR checklist. So the risk factor, the risk model put your patient in one of 3 categories: low risk, moderate risk, and high risk or intermediate risk, probably. And this is the risk model for everybody who wants to look at it. As I told you, I was trying to crop the page to put it in one page. It would be tiny and nobody could read it. But again, it is very simple. So once we get a patient with the first encounter with a cancer patient, we should start with cardiovascular risk stratification before we start chemotherapy. Now, there are a few, as I said. This is the most comprehensive one, but once you get the result, you will get a low-risk patient in whom you only need a routine follow-up. And cardiology follow-up will be indicated only if there is cardiovascular abnormality. Now, if the patient has intermediate risk, then this patient will need closer follow-up and probably cardiology referral when symptoms happen, but maybe it is advisable to do cardiology referral at the baseline, so that the patient will have, when it comes to make a decision-making, the cardiologist has an overwhelming understanding of the patient care. And probably it's better to get a cardio-oncology if you have one available in your institution. If it is high risk, then it is indicated to refer the patient immediately before you start chemotherapy. Again, preferably to cardio-oncologist, because I can tell you, I'm a cardiologist, and unless you have that interest to deal with oncology patients and that understanding, you will have to go through 1,000 doors to convince your colleagues to do one step further to do these patients. And sometimes you're successful, sometimes you are not. What's that? And again, cardio-oncology, I cannot stress enough that any tertiary care center should have a cardio-oncologist on board. And I've been advocating for this in each time I speak to a group of oncologists. And hopefully one day we will have a society within our Heart Association meeting to Heart Association, Saudi Heart Association, to go over these cases. Okay, now, once we decide the risk, the second pertinent question will be, what is the best surveillance strategy? And again, we get into trouble finding out what is the strategy, because should we look at symptomatic patient versus asymptomatic LV dysfunction? what kind of modality we use? Nowadays, you have an armamentarium of modalities available in most of the hospitals. Should I do echocardiography? Should do a strain and strain rate evaluation? Should I do a cardiac MRI? Or should we do our old friend MUGA scan? And how frequent should we do this? And should we go ahead and do it routinely with the risk that sometimes we may withhold the treatment for the patient that is needed, waiting for the risk? Because I'm not sure how easy for that patient to get into a cardiology evaluation. Minimum, at least in our hospital, we're talking about 4 weeks to 6 weeks before we can see a cardiologist. Just imagine doing a test that is not indicated and then withhold the treatment for 6 weeks before the patient can get his therapy. Okay, so let's take a look at this. If we look, when we look at in breast cancer, we have the HER2 target therapy and anthracycline. If we look at anthracycline, if the patient is high risk, maybe we should do that. Okay. Sorry, I thought there is a pointer here. Okay, sure. Okay, if the patient has high risk, then probably you should have a thoracic echocardiography, BMP, and cardiac troponin at baseline. Intermediate to low risk, it may be helpful to get the troponin and cardiac BMP, but transthoracic echocardiography is indicated. When you look at HER2 targeted therapy, again, in high-risk group, you will have all the three. You will have the biomarkers of cardiac dysfunction, cardiac injury, as well as echocardiography. And in intermediate risk, it's class 2B, so you may go without it. Now, when we look at how frequent should we do that, again, the risk helps you a lot to decide which patient. And this is the beauty of this, combined with electronic medical record, is actually you can have a pop-out or pop-up program that tells you that it is time to do the test, and this could be automatically done. So ECG, we will do in low-risk patient, we'll do an ECG at baseline. We'll do transthoracic echocardiography in the baseline, and cardiac biomarkers in form of cardiac troponin and beta natriuretic polypeptide may be indicated. And then what we need in the low-risk patient is a 12-month after therapy to repeat echocardiography. All the others may be helpful, and they are considered as class 2P. Now, if we look at intermediate risk, again, we will have the ECG, and the echocardiography at baseline and 12 months post-therapy. But now, the surveillance in the middle of the therapy after the 4th cycle and repeated cardiac biomarkers become class 2A, which means it may be helpful. Once we identify high-risk patients, then we will do all the ECG, echocardiography, and cardiac biomarker at the baseline. We will repeat transthoracic echocardiography at cycle 2, cycle 4, cycle 6, 3 months post-therapy, and 1 year post-therapy. And we will do cardiac biomarker after each cycle, because cardiac biomarker can be, or can at least guide you to whether we should do further testing or not. When it comes in HER2 targeted therapy, again, we will do probably in low and intermediate risk, we'll do an ECG, but nowadays, since the likelihood of LV dysfunction is higher, we'll do echocardiography every 3 months and 12 months after therapy. And likewise, again, with high risk, the only difference that in cardiac biomarkers, you should probably do it more frequently with patients who are high risk. Now, and when it comes to radiotherapy, again, we will divide patient into low risk, intermediate risk, and high risk. And again, probably you should do more surveillance in those patients with high risk. And I'm not the expert here, Dr. Mohammed is the expert, and he will hopefully guide us during the discussion. Now, what happened thereafter is as important as what we do in the beginning of the treatment. Don't forget about cancer survivals. These patients have kind of won the first battle, but don't make them lose the battle that everybody can win by controlling their cardiovascular diseases. And this is why in those patients, how frequent do you guys see these patients after they reach remission? So at least you will see them once a year, right? So don't forget your annual cardiovascular risk assessment. We are cardiologists, we are not smart. Our memory are bad, so we put everything in an app. An app is available for you guys. You just go on and look at it and assess your risk of cardiovascular disease. Consider cardiovascular follow-up or referral if the patient has abnormality, and then cardiovascular toxicity risk every 5 years. But I cannot stress enough, your patient has won the first battle. Don't make him lose the battle that we can all win together. Hopefully, we'll see. Okay, now what about imaging modality? And again, there is a debate. Now, what we do usually, we go transthoracic echocardiography. It is available, it is affordable, it doesn't cost a lot. But the problem that it has a lot of limitation. Strain assessment by echocardiography is one step ahead. Now we take the subjectivity of looking at ejection fraction, and it may help us a lot to decide what should we do. Now, cardiac magnetic resonance imaging now is the gold standard. Unfortunately, it is not available in every hospital, or some of the hospitals do not have a dedicated magnet to cardiovascular care, which make it more difficult to get it. But again, if you have an ejection fraction, which tells you that the ejection fraction is 35 to 40 or 35 to 45 to 40, remember that inter-observer variability, saying that if you have two expert readers, the same echo, the difference will be 10%. So your patient may be actually normal. And therefore, maybe we should do cardiac magnetic resonance imaging in those patients. Magascan is available in most of the hospital. Unfortunately, we're risking some radiation with each time we do that scan. So what do we need to do with each modality? I need now not only to look at ejection fraction visually, but I look at systematic ejection fraction done objectively by Simpson method. We should always measure the volume because the volume can change. And I'll give you an example. We know that ejection fraction equals LV in diastolic volume minus LV systolic volume divided by LV in diastolic volume. Okay. So if a patient has a heart of 160 and an ejection fraction, an in diastolic volume of 160, in systolic volume of 100, that's 60 divided by 160, that's 60%. But if an ejection fraction of in diastolic volume of a patient is 100, which is a normal heart, and in systolic is 40, that's again 60% ejection fraction. So ejection fraction does not tell you the whole story. Because ejection fraction is a function of volume. And as your heart gets bigger, now we know that bigger heart is good, but not in cardiology. So as your heart gets bigger, your ejection fraction may be maintained without getting a drop in ejection fraction. Now, bigger heart, I mean, good heart is always good. عشان لا تقول احنا الكارديولوجيست عندنا مشكلة. Okay. MRI is again probably maybe, and in my opinion, it will take over in the next few years. It's the only reason why the scientific committee do not make it class 1 is because it's not available everywhere. And I'll give you an example. In 2014, when we started our program, we pushed for every single patient who cardiomyopathy to have cardiac MRI, and we have a lot of resistance, saying that we're abusing the surface, but luckily we have our own dedicated magnet. 2020, 6 years after what we have established, the European Society of Cardiology make it class 1 for cardiac MRI to be done in heart failure patients. So sometimes maybe you need to work earlier than the guidelines because the guidelines is meant for everybody. And when it's meant for everybody, the writer of those guidelines have to be careful not to incriminate other people who are on the surface. Okay, can we prevent cardiotoxicity? Again, question that is difficult to answer, but the easy answer is no, unfortunately, except for controlling the risk factor. We have BRADA, which looked at ARB and beta blocker. We look at Manticore, which looked again at bisoprolol and printopril, which is ACE inhibitor. And we have CISI, which looked again to beta blocker. And unfortunately, look at the numbers, 294, 130. This is in the cardiology life is nothing. We look at 5,000 and 10,000 patients when we draw a conclusion. Unfortunately, none of them actually made it there to say that I would start my patient before starting therapy. Now, this is hot out of the oven. This is stop CA, with this was just announced in the New Orleans 3 days ago. They looked at 300 patients with median age of 52, 50% female, good representation, with lymphoma, who received anthracycline. They received atorvastatin versus placebo, and there was actually a higher incidence of LV systolic dysfunction among the patients who received the placebo, threefolds. Again, there was no differences in rates of adverse event, including muscle pain, elevated transaminases, myositis, and renal failure. But again, this paper is not published yet. So we don't know what would happen in the peer review process. But again, something promising that maybe statin will help us somehow in this group of patients. So in conclusion, the care of cardiotoxicity in patients with breast cancer require a close collaboration with baseline cardiotoxic risk assessment, diligent and appropriate imaging surveillance. Keep in mind that we should do it diligently but appropriately. There should be optimal care and collaboration between oncologists and cardiologists, preferably cardio-oncologists. And there is a desperate need to fill the knowledge gap in the risk assessment, because as you can see, there isn't enough data there in the world, let alone in our population, in which I believe we have a special population. You will tell me more about our population in terms of their age and presentation. But when it comes to our cardiovascular risk is way higher than our European counterpart. We have cardiovascular diseases presenting 10 years earlier, more adverse heart failure, more admission with heart failure. And this probably need a further care and more research studies concentrating on our population. And I hope I didn't bother you enough with our cardiology talk today. Thank you, guys.
Thank you very much, Dr. Ahmed. That was very informative, and I'm sure we have many questions. We'll keep it till the end. Now we'll move to the second presentation about update in breast cancer management for elderly patients, to be presented by Dr. Nafisa Abdelhafiz. She's a consultant medical oncologist at King Abdulaziz Medical City. Please, Dr. Nafisa.
Assalamu alaikum. Good morning. Thank you, Mohammed. So my talk will be about treating breast cancer in elderly patients. And I know this is very challenging, especially when we face elderly patients in the clinic with multiple comorbidities and poor performance status. So we know that one of the risk factors for breast cancer is getting older and older. So if we are talking about US, and this is because I don't have solid data from Saudi Arabia, maybe Mohammed knows, but for now I don't have. But annually here, we do have, in US, sorry, they are seeing around 2,050 patients annually. 50% of those patients, they are elderly, i.e. their age is 65 years old and above. The pathology actually is the same between ductal carcinoma followed by lobular carcinoma, and 70% of those patients are hormonal positive. So, but what are the challenges in treating patients with breast cancer once she is old, like 70 or above? So there are many challenges. The most important thing, they group them together. So they lump them together, although they are a spectrum. So we see sometimes 8 years old lady with multiple comorbidities. So you cannot touch her even sometimes with hormonal therapy. Sometimes you see a 90 years old lady with no comorbidities, excellent performance status, while 65-year-old again might be very sick. So, but still in the clinical trial, they lump them together and they say elderly patients. So very difficult to conclude and to have a guidelines from their involvement in the clinical trial. So what are the other challenges? Most of the time, they are not enrolled in the clinical trials. Why? Because they are not meeting the criteria for enrollment, either because of their age or their comorbidities. So most of the time, they are out of the clinical trial because their age is not suitable, their general condition, their performance status is not allowing them. So this is another challenge. And sometimes they are treated in a hospital where they don't have clinical trial in that hospital. So this is the second problem. So the result of that, we don't have a strong evidence-based guideline to inform us about treatment of those patients in this age, because of, you cannot treat breast cancer in this age properly. There's a group of trials looked at those patients. The number of trials is not large, not big, and the number of patients is not big, but we have some guidelines, and this is what we are following now, but still a lot of work needs to be done. So what about prognosis of breast cancer in general? So generally, in spite of very good and vigorous treatment for breast cancer patients, giving adjuvant, giving neoadjuvant, chemotherapy, radiation therapy, doing surgery and giving targeted therapy now and giving immunotherapy, in spite of all these things, still a good number of patients will have disease recurrence. So what about patients who are elderly, even they did not get the minimum type, kind of treatment, or they did not have their treatment fully? Definitely the incidence of recurrence will be higher on those patients. Plus, we see sometimes patients with de novo metastatic disease. So 1 in 5 will come with stage 4 breast cancer as initial presentation. So treating patients with metastatic disease in the 90s, definitely, it's not like now in 2000, definitely now the new medication, we do have the immunotherapy, we have the ADCs, we have a new generation of immunotherapy, we have the targeted therapy. So many medications change the paradigm of treating breast cancer and change actually the roadmap of the management. And of course, this medication improves the PFS and improves the overall survival. But the problem that we don't know the effect of this new medication on elderly patients. For example, immunotherapy is very effective in young, triple negative. The addition of immunotherapy improves their PFS in the metastatic setting, improve the overall survival, but we don't know how good is this immunotherapy for elderly patients, because actually we don't know their immune system, how it will react. The ADCs, for example, very good, gave a very promising result, but still it came with new side effect, new toxicity. So especially when we are talking about treating the patient for not for curative intent, we are talking about metastatic disease. So your treatment is palliative, so you need a good quality of life. So definitely, we're not sure how effective is this treatment, and we don't know how this medication will affect the quality of life, and how are our patients gonna tolerate this new medication. But still, those elderly should be offered the same type of treatment, and then you decide accordingly. By the end, you need to tailor your treatment depending on the patient general condition, performance status, comorbidities, and the goal of your treatment. So here, they looked at the elderly patient with triple negative disease. This trial the analysis was done in 2021. This is a systematic review that they look at 5 trials. They look at a patient who are 70 years old and above, triple negative patient. They enrolled around 2,000 patients, and all of them were 70 years old and more. So they put all categories of treatment, like adjuvant, they look at the adjuvant and neoadjuvant and radiation and the surgery. So they noticed there was a big difference in treatment. So the patients who are 70 and above, they did not all of them reach the point of surgery. So they were not able to perform surgery for all patients. A good number of patients were not able to go for surgery. Again, adjuvant treatment was also not given fully. Some of the patients received radiation while others not, because of the cardiac toxicity, because of their general condition. When adjuvant treatment was required, not all of the triple negative patients were able to tolerate the adjuvant treatment. And this interruption of treatment led to again, we reach a point that we cannot give conclusion. We cannot endorse a good conclusion because the de-escalation happened. Now we don't know how effective, what is good for the patient. Shall we omit for this age group? Shall we omit chemotherapy and give radiation? Shall we omit radiation and give chemotherapy? So we don't know the proper treatment. We know the proper for the rest of the patient, for the young patient, is to go by standard. You give chemo and then you give radiation. But here, because there was many interruptions, so we cannot say the best for them. So what about HER2 positive disease? For HER2 positive disease, there were 5 trials looked at the Herceptin in the adjuvant setting. So a group of, so these trials were not dedicated for elderly patients. They just look at the patient who are 70 years and above. They just collected an elderly patient from the 5 trials, and then they make an analysis. So this trial was conducted between 2008 and 2015. Okay, they grouped the patient into, they put the patient into 2 groups, 70 to 74, and patients who are 74 and above. And between the 2 arms, the criteria were well balanced in terms of tumor size, lymph node, and ER and PR positivity. So just I need to draw your attention. You notice that the time of the trial was like 8 years, but still the number of patients was around 200, less than 100 patients when they reached analysis. I don't know what happened. Something went wrong.
Which page?
So they look at the patients who received trastuzumab. They completed like 1 year of trastuzumab, and those who were not able to complete trastuzumab. So 115 patients were collected. Few of them had disease progression during the adjuvant treatment, so they have been excluded from the final analysis. They just the analysis was done for around 97 patients. So as I mentioned before, few patients were able, some patients were not able, not a few of them. Actually, the good thing that the majority of patients were able to complete 1 year of trastuzumab. So again, at the time of recurrence or at the time of disease progression, it was the same like HER2 positive disease in young. The brain was the commonest site of metastasis. So what is new about treatment of breast cancer in elderly? In San Antonio last year, a group from Spain looked at the management and factor associated with the outcome of metastatic breast cancer among elderly patients. So in this trial, around 460 patients, all patients were having metastatic disease. It was a single center trial. So the subtypes, like the majority were luminal A patients, like 72% were having hormonal positive disease, 14% triple negative, and 11% were HER2 positive disease. As I mentioned, most of them were having, like 70% were having de novo metastatic disease. And performance status, unfortunately, the majority were having poor performance status between 3 to 4. Around 70%, their performance was not great. And Gleason index score was also of 7 or lower. We know that Gleason score look at the comorbidities. So they found that approximately 10% of the patients were not able to receive the first line in the metastatic setting. So 10% of the patients were not able to touch them even with the first line, although they are having metastatic disease. So among those subtypes, who were not able to receive the first line? 34% of those patients were having triple negative disease. 6% only of the patients were HER2 positive, and 5%, were hormonal positive, and 6% HER2 positive. So the highest patients who were not able to get the first line treatment for the metastatic setting were triple negative. And this is very easy to understand because we know the treatment option for those patients is chemotherapy. And now what is new for triple negative is immunotherapy. But we know we cannot give immunotherapy unless we have positive PD-L1. Again, even if they do have positive PD-L1, you cannot give immunotherapy as a single agent. So still you need chemotherapy. That is why those patients is very difficult to treat. While in hormonal positive patient, a single tablet with minimal side effect can be given for elderly patient, of course, for patient even with performance status 4, there is no harm to give immunotherapy, hormonal therapy. So this is very, very clear that patients with triple negative, when they come with advanced disease, very challenging and very difficult to treat them. So among patients, what about discontinuation for those who were able to receive the first line? So this discontinuation happened in only 2% of the patients who received hormonal therapy, while it happened in 18% of patients who received chemotherapy as a first line treatment. At the time of the analysis, 75% of the patients died, and actually 94% of them died because of breast cancer. So what did they find? They found that, as mentioned, the triple negative were the highest patients who were not able to receive first line therapy. Again, what are other risk factors? So pathology is a risk factor for not receiving the first line of therapy. The other factor was the age. Patients between 80 and 90, also the percentage, a good number of them were not able to receive the first line in the metastatic setting. The other risk factor was the performance status. So when they looked at the patient who received performance between 3 and 4, large number of them did not receive first line, and the number was better in patients who were having performance between 0 and 2. So what about the overall survival in the patient who received and those who did not receive treatment? Overall survival in the patient who received treatment was 29 months, while it was only 2 months in the patient who were not touched with systemic treatment. So by the end, they said that the majority, all of the patients, almost like 95% of the patient, the elderly patient, died because of breast cancer. Age is a risk factor, performance is a risk factor, the pathology is a risk factor, but a lot of data is missing, and we need to have more trial to look at the elderly patient with breast cancer. Thank you.
Thank you, Dr. Nafisa, for your nice presentation. And I do agree with you that treating geriatric patients is difficult in oncology, especially in adjuvant setting when you are thinking that the patient can tolerate the chemotherapy. Once you start your first cycle of chemotherapy, gentle, reduced dose, you knock them down and you feel bad. And you don't know what to do. Every case, you are thinking that you are doing your job, but still we didn't figure it out to evaluate the tolerance of the elderly patient for the chemotherapy or targeted therapy. And we are thinking by doing an echocardiogram and other investigation might help us, which could, but it is not totally telling us how to treat oncology, geriatric oncology patients. We will move for the next session, which will be presented by Dr. Mohammed Al-Shehri, and it's Dr. Al-Shehri is a consultant medical oncology at Aramco, John Hopkins Aramco Healthcare Center, and he is director of oncology fellowship program, and he will give us lectures about the safety and efficacy of CDK4/6 inhibitor in older patients with advanced breast cancer in real world setting. Dr. Al-Shehri, welcome, and you might start your session.
Assalamu alaikum. Sabah al-khair jami'an. Thank you so much, Dr. Munira, for the introduction. Thank you, Mohammed and Nafisa, for the invitation. I'll try just to share my presentation.
Would you like us to put from here?
Yes, please, Mohammed, because this is MacBook and it seemed to be, I don't know how to deal with it. If you don't mind, I think I just sent an email. If you can share it from your side.
Noted.
Thank you so much. So I enjoyed really the talk by Dr. Al-Jazeera and Dr. Nafisa, because I just have an old patient with the heart problems and it's very challenging to treat those patients. This is why really we are talking about them, and this is why we think this is a special situation. So we are not making this up, but actually in the clinic, we face all the time these questions, and it's very critical questions, because if you don't treat cancer, it's a problem, and if you treat it and cause side effects, it's also another problem. So we need really to balance that. The problem with the elderly patients and even patients with heart disease, the data is not that abundant. We don't have much data to base our decision on it. And this is sometimes why we need to rely on real world data to collect more patients. Next, please. صوت واضح?
Yes.
Okay, so I will start with this example. This is a 76-year-old woman. She's the patient that we see, all of us in the clinic. So she is 76, she is old. She was diagnosed with de novo breast cancer, metastatic. And she had the most common type of breast cancer, ER/PR positive, HER2 negative. She had this borderline liver function, and she had multiple liver, lung, and bone metastases. And we want to start her on the first line treatment. We have 6 treatment approved if we go to the NCCN guideline or even any other guidelines. Any of these treatments or combination of treatment can be used. And honestly, if we have 6 different oncologists, some of them will argue about any of these choice, and they might have a good argument about it. Of course, in 2023, most of us would use combination treatment with CDK4/6 inhibitor and aromatase inhibitor. But also other options, some people will argue about it. At any rate, if we think the CDK4/6 inhibitor combined with endocrine treatment is the best treatment for those patients, and it's the established treatment. So what about our specific topic today. What about the elderly patient? Are they safe? Is it effective on them? Is it tolerable and not toxic? We depend next, please. We depend to answer these questions and the clinical trials that approved CDK4/6 inhibitor for use. We have many of them, and we know for sure it's consistent, it's solid data, and it's reproducible in each one of the compounds that approved for the treatment: palbociclib, ribo, and abemaciclib. So there is no big questions on the efficacy in the clinical trials. Next, please. About toxicity, we have the 3 compounds. It's different chemically, and there is some difference also in side effects. But there is no contraindication to use any of them in certain age group. So even the side effects is different. We still use any of these drug combination in elderly patients. But this information is also important for us to choose when we have our clinical decision. Next, please. So the question now, how do these drugs do in the real world? And is their performance and toxicity match the clinical trial data? And how are they being used in elderly specifically? Because our topic now is elderly patient and real world data. So I'm going to focus specifically on that. Next, please. So in general, why do we need real world data and real world evidence? The obvious answer for that is because of limitation of clinical trial data. And limitation of clinical trial data came from the highly selected cohort of patients. Sometimes there is a huge group of patients that's not included at all in the clinical trial for cancer treatment. And good example for that is elderly patient and sometimes CNS metastatic patients. Usually they are excluded from most of the clinical trials. The other thing, there's sometimes a barrier to access to the clinical trial. Even if they are eligible for the clinical trial, they are not represented in the clinical trial because basically of lack of access. And of course, the comorbidities and performance status, most of these factors would exclude elderly patients from clinical trials. This is why real-world evidence, in particular in this group of patients, is important. Next, please. Next.
Disconnected.
Should we go next?
It's disconnected, I guess.
Dr. Shahri, can you hear us? I think he is trying to rejoin. We'll be waiting for 1 minute maximum.
Hello? 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 تسمعوني؟
أيوة عبد الرحمن, we can hear you.
I'm sorry, it got disconnected. Should I continue or?
Yeah, please continue. Yes.
Okay, so, all right. So I'm sorry for that. So now this is about the introduction from the two clinical trials that we have, Paloma 1 and Paloma 3, and Paloma 2. I'm sorry, Paloma 2 and Paloma 3. Paloma 2 was the registration trial. It was the first trial that CDK4/6 inhibitor was approved for it. It was published in 2015, and the first CDK4/6 inhibitor, palbociclib, got approved at that time. If you look to the age in this phase 3 clinical trial, the median age 62 in the combination arm, and the endocrine therapy arm is 61. So they included older age. Next, please. In the subsequent line of treatment, also Paloma 3, they have a younger population, and maybe this is also the bias to use for the patient who is treated with the cancer or pre-treated cancer. They try to include younger age in those clinical trials. Next, please. So in 2017, it was published the first pooled analysis of all the clinical trials, the registrational trial for CDK4/6 inhibitor, for the Monarch and for Mona Lisa and for Paloma. And it was done in retrospective fashion for the prospective data. So they were going retrospectively for the phase 3 clinical trials, and they pooled all of the data, and then they analyzed them. And they depend on the US FDA database. Next, please. And they have two questions, basically. The efficacy and the toxicity that was in the clinical trial, specifically for older age. So they stratified the patient into 3 groups, more than 70, more than 65, and less than 65. And they looked into, and the number of the patient was about 1,900, so good number of the patient. And they look into the efficacy and tolerability. Next, please. So they looked specifically into efficacy in the 2 groups of the patient who is above 70 and patient who is below 70 in the clinical trial, in the 3 registrational clinical trial for abemaciclib, for palbociclib, and for ribociclib. And they did not find any difference in the clinical trial data between the patient who is older, above 70-year-old, and the patient who is under 70-year-old. If anything, the patient who is over 70-year-old, who is treated with combination treatment, has even a superior progression-free survival for the patient less than 70 years old. So the question of efficacy, there was no question about efficacy and the effective treatment for older patient. It's as effective as younger patient. When it comes to the side effect and adverse events profile, actually they found the patient who is older have more side effect, more dose reduction, and more interruption of the treatment, more discontinuation of the treatment, and even more serious adverse events. So this is clearly, there is a very clear distinction between the patient who is less than 65 and the patient who is above 70 when it comes to tolerability and side effects. And again, this is a pooled analysis from all the phase 3 clinical trials for CDK4/6 inhibitor. Next, please. So what about the real world data? Real world data is less controlled environment. They will look into everyone. They will look to a patient who is maybe resemble the clinic patient that we see. So IRIS was one of the first real world data that look into palbociclib use in the community. Next, please. So they collect retrospectively the data of 652 patients, and it was reported by physician. So it was reported by 65 physicians from different 65 practice. And basically, they were looking into the treatment pattern for palbociclib plus aromatase inhibitor as a first-line treatment, and palbociclib fulvestrant as a second-line treatment. Next, please. And because we are specifically talking about the age in this talk, so the median age for this real-world data was about 65. And 66 in the first-line treatment and 63-year-old in the second-line treatment. Next, please. So what they did, they stratify patient into two different groups. One of the group was patient age. So they stratified the patient into two groups, patient who is less than 65 and patient who is more than 65. And they look into efficacy of palbociclib and aromatase inhibitor as first-line treatment. Next, please. And what they found in the progression-free survival in the 12 months mark and 24 months mark, there is really no big difference between the patient who is more than 65 and less than 65 in terms of progression-free survival and efficacy of this first-line treatment. And also they looked into survival rate. And remember, this is a retrospective review, so it's not that accurate, but they are just looking into the data. And also they look into the two group, the patient who is less than 65 and the patient who is above 65. They look into 1 year mark and 2 years mark. And there is no big difference except for the 2 years marks for the overall survival. There was more patients in the younger group who has survived in 2 years mark rather than the patient who is older, more than 65-year-old. There is like 10% difference between the survival rate between those two groups. Next, please. The same also happened into subsequent line of treatment with palbociclib and fulvestrant. They stratify the patient in two groups retrospectively, and they look into the data, more than 65 and less than 65. Next, please. Also, they look into progression-free survival and survival rate. For the progression-free survival, there is only slight difference between the patient who is older and the patient who is younger than 65. The survival rate, also the same thing. There is a slight difference in the patient who is older than the patient who is younger, meaning that the patient who is older have less survival rate, less progression-free survival rate. However, it's not that big and it's not that distinct. And for retrospective review, this is acceptable. Next, please. So in IRIS study, it seemed to be it's representing the same efficacy that we saw in the clinical trial with no big difference. One thing that they noticed in the IRIS study, that frequency of palbociclib dose reduction was lower in the clinical trials, was lower than the real data. So in the community, people were not dose reducing like in the clinical trial, which is really strange because you thought the patients maybe will dose reduce more in the community rather than clinical trials. But maybe this is a bias because in the community, you don't have that restriction. So when you have older patient, you might start with lower dose from the beginning, assuming that the patient will have some toxicity. So the patient will start on lower dose. And this is really not a good practice. And it was noticed in this real world data in the 652 patient. Next, please. Okay, so this is also another study. It's a bigger study. They also looked into palbociclib real world evidence using Flatron health record database in US. They used a huge number of database, and they resemble the two arms of the Palomas, patient endocrine therapy and palbociclib in one arm, and the other arm is aromatase inhibitor by itself. Next, please. And they were basically looking into overall survival in these two arms and efficacy of the treatment. Next, please. So So they included 1,400 patients, 700 in the 772 in the palbociclib letrozole arm, and 658 in the letrozole arm. Next, please. They were looking basically into progression-free survival and overall survival data. Next, please. They included, in this database, they included a good number of older patients. So at least a third of the sample that they review, they were above age of 65, and about a quarter of the sample is above the age of 75. So this is really resembling what we are talking about, that use of the CDK4 in older patients. So they focus also on elderly patients in this review. Next, please. So if you look into the efficacy data, the overall survival data, what they found, it's consistent in many subgroups. It's consistent with combination treatment, and also it's consistent with clinical trials data. There was no big distinction from the clinical trial data. If we focus here on the age, we will find that patients above age of 70, they have the same benefit from the treatment. Patient in younger age, in the age group between 50 and 69, they have the same benefit. And even younger patients, they have the same benefit. Hazard ratio were almost the same in all the three groups. So really, from this review of the data, there was also no questions about efficacy of the combination treatment in the older population. Next, please. This is another study that was presented in San Antonio in 2019. Very interesting questions. What was, in the real world, what was the predictor for the physician to use first-line treatment? Next, please. And they included three kinds of treatment: endocrine treatment, single agent, CDK4/6 inhibitor, and endocrine therapy combination, and chemotherapy. And they looked into factors that make the physician choose this treatment or that treatment. This review, a very large number of patients, more than 5,000 patients. Also, they used the same Flatiron Health database in the United States. And they ran the review between 2015 and 2018. So that timeline is also important for us to understand the data. Next, please. All right. So this is what they found. 41% of the patients received CDK4/6 inhibitor and endocrine therapy. So most of the patients received the combination treatment with CDK4/6. And 30% received endocrine therapy, and the minority 19% received the chemotherapy. If you look into the age in those categories, you will find the older age, which is the median age 71, is with the patient who used endocrine therapy single agent. The patient who used combination treatment is younger. The median age is 64. And the patient who used chemotherapy, even younger, the median age is 60. And this is really tell you a trend that physicians in the community and the real world data, they tend to use single agent in older patients. So that was one of the predictor to use endocrine therapy by itself is age. And this is what they found in this review. Of course, they were also looking for other things, but our focus here on age. Next, please. All right. So this is the analysis that they do, and they found that patients were less likely to receive CDK4/6 inhibitor plus endocrine therapy, the combination treatment, versus endocrine therapy single agent, if they were older, and if they were having a higher ECOG performance status, meaning their performance status is not good. So this is the decision of the physician. This is a clinical decision that, because just of the age, the patient is using single agent rather than combination treatment. Is this right? Is this based on phase 3 clinical trials? Is this based on the experience that people have? Of course not. This was something that physicians feel more comfortable not to use the combination treatment because of the age. And again, this review happened between 2015 and 2018. I'm sure if this review, if they run it again during the next 5 years between 2018 and now, they will find different results. Next, please. And the time correlation is really very important. If you look into this graph, this is the first line treatment category over time. So they start in 2015, Q1 2015. And if you remember, CDK4/6 inhibitor was not even existing outside clinical trials at that time. And they end by Q2 in 2019. And if you look here, the endocrine therapy was the main treatment that used at that time. And there was no CDK4/6 inhibitor. With the time, in about 6 months, 18 months period, CDK4/6 inhibitor start to be the main treatment that used as a first line treatment. And now there is much difference between the patient who is using endocrine therapy, single agent, and combination treatment. So clearly, just by passing of the time, 3-4 years, the whole practice and the paradigm was shift to use CDK4/6 inhibitor and endocrine therapy rather than endocrine therapy single agent. But again, age was a big predictor not to give the patient combination treatment. Next, please.
1 minute, Abdurrahman.
I'm done. This is a complement 1 study. It's for ribociclib. It's extended phase 3 trial. They were trying to include more patients. It's more inclusive than the MONALEESA trial, basically to capture that real world data difference and to test the efficacy and also safety and tolerability for the patient in wider population and more inclusive population. So they included more than 3,000 patients, and they do prospective single arm study of ribociclib and letrozole as a first line treatment with no prior endocrine therapy, and 1 prior chemotherapy was allowed. Next, please. In the complement, they included more older patients. There was about 10% older than 75, and there was almost a third of the patients were older than 65. Next, please. So in the complement, patient ranged from 20 to 92. The median age was 52. As I said, there was more than 1,000 patients with that was treated in this, that was reviewed in this trials. They were more than 65-year-old. Next, please. There was no difference in the efficacy between the complement, MONALEESA-2 and MONALEESA-7. The same progression-free survival. So efficacy was the same. There was no big difference. For the adverse events profile, also it was manageable, and there was no new safety signal were identified. So age basically and more inclusive population did not really change the data much. Next, please. So in summary, CDK4/6 inhibitor now is essential part of the standard of care. There was before a concern regarding the efficacy and potential increased toxicity in the older patient in the community. But actually this has not been proven in randomized clinical trial as well as in real world data. There was no signal that showed us less efficacy or more toxicity for older patients. So I think what we need to do, because we have this data, I don't think we need to be more conservative with older patients unless we have a good clinical judgment that there is a contraindication or there is a comorbidity that will prevent us from using CDK4/6 inhibitor. Thank you so much.
Thank you very much, Abdurrahman, for this nice presentation. Now we'll move to the last presentation. It's my pleasure to invite Dr. Lulu Rais. She is a consultant breast surgery at King Abdulaziz Medical City in Riyadh, and she is going to talk to us about the role of surgery in male with breast cancer. Please, Dr. Lulu.
Yes, it's a PDF. You PDF or okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Jami'an, good morning. I'd like to thank the organizing committee for inviting me and take apology for taking the privilege of changing my subject into case 45. So what is case 45? And then we'll talk about my experience in case 45, then about the epidemiology and the surgical decision and some ASCO guidelines. Case 45 is the first case to be reported in the 16,000s BC in the surgical Edwin Smith surgical papers. They reference it as case 45, and it was the first case to be reported in male with breast cancer. So moving in time, I had my case number 1, Mr. F. He's a 63-year-old gentleman with multiple comorbidity, wheelchair bound, presenting to our clinic with right breast malignant looking radiologically and clinically mass. We did the pathology for him, and it was IDC grade 2 ERPR positive, HER2 neuronegative, and the Ki67 was about 20%. And the staging showed only non-functional adenoma or adrenal mass. So the gene testing was done and it was positive. What do you think we should do with this patient? Yani, I'm trying to make it interactive. Okay, so surgery, what would be the surgical option?
What gene?
التحدي يا دكتور، حنا حدنا جين positive. BRCA BRCA2 positive. I don't know the locus. Okay, so this patient, we treated him with bilateral simple mastectomy, sentinel lymph node biopsy. It was a T3N0M0. It's worth to mention that the patient, for some social reason, wanted to delay the surgery. So this is what gave us the time to get the result of the gene testing, and we bridged him with a neoadjuvant hormonal treatment at that time. So this is our experience. It's a qualitative study led by Ms. Ahmed. I wish she was here in person with us, with my colleague, Dr. Amin, Dr. Carmen. It was a qualitative study. We described 6 male patients who were diagnosed with breast cancer between age of 45 to 70 years old. And the symptoms varied between breast mass to nipple discharge and skin ulceration. The timing to diagnosis was between 1 week to 4 years. Half of our patient was early stage. 3 of them were locally advanced or metastatic. Majority underwent MRM. And hormonal therapy was given to all patients. In those patients, when we asked them about their experience, they were all embarrassed. They did not like the disfigurement. They were ashamed of coming to a women clinic. They were ashamed of sitting beside the mammogram. And it was like, even though I'm a breast surgeon for a long time, but I never considered this. I never considered the stigmatization that arises from this. So next, especially the concave feeling, and when the men wear wear thobe and they are big size and they have asymmetry, they have gynecomastia on one side, and on the other side, the concave looked, they did not like it. So when the next case came, I thought about it. So he's a Mr. S. He's a 59-year-old lovely gentleman presented to our clinic with left breast mass. It was radiologically by RAD4. And when we did the biopsy, it had an atypical papillary lesion. So we took him to excisional biopsy. Unfortunately, during the excision, because part of the lesion is cystic, it ruptured on us. So the excision showed an encapsulated papillary carcinoma. Because of the rupture and the fragmentation that happened, they were not able to determine the invasive, if there is any invasive or non-invasive or only DCIS. So what is next in this case? Okay. So we did the staging for this gentleman. He had a renal mass. We did consult our colleague from Uro-Oncology. It was very suspicious. We discussed it in our tumor board. We decided to proceed with managing the renal mass and then the breast. Because the breast is, even if it's an invasive, it's a low-grade cancer. So, and we had time to do the gene testing. He was negative. He was an obese belt guy, and he had the gynecomastia, pseudogynecomastia. So we decided to offer him central lumpectomy and sentinel lymph node biopsy. He accepted the offer, and we proceeded with central lumpectomy. The pathology was DCIS only. There was no invasive. He completed his radiation therapy, and now he's on adjuvant tamoxifen treatment. Both of patients are alive and well. So this is what we are doing at National Guard Hospital. So what are other parts of the world is doing? So in the International Male Breast Cancer Group, they described, they published it in 2018. It's an international group. They have the data of about 1,400, of just about 1,400 patients with 8 years follow-up. Even though majority or half of the patients, almost half, had a T1 disease, only 4% were offered breast conserving therapy. So we weren't doing so bad. There was, even though node negative, only 18% underwent sentinel lymph node biopsy. Radiation, neoadjuvant chemo was not offered for all patients, and only 70% were offered adjuvant hormonal treatment. So they're kind of over-treated in some aspect and under-treated in the other. Okay, the median overall was 10 years for node-negative disease. It was 8 years for node-positive, and it was comparable with female for metastatic, in the metastatic setting. So now we talk about male breast cancer. What do we know from all over the literature? It's a rare disease. It's about 1% of the overall breast cancer cases. However, the incidence is increasing. Maybe this number will change. The risk, the lifetime risk, is 1 to 1,000 in male and 1 to 8 in women. And the average age is usually older than women. It's about 67 years old.
The risk factor, the family history is very important risk factor. It increased the relative risk of about 2.5. Black ethnicity, radiation to exposure, germline mutation, exogenous estrogen, and condition that is associated with hyperestrogenemia like Klinefelter syndrome are well-known risk factor. It increases it increases the risk up to 50% of general population. The BRCA gene mutation, 4 to A16 to up to 16% of male with breast cancer are associated with BRCA2 mutation carrier. The BRCA2 is BRCA1 is much less. The cumulative risk of breast cancer in men with the gene mutation is about 1.2 to 6.8. So in a male with breast cancer, gene testing is a must. Most of the patient is IDC. Less of them is 10%. The incidence of hormonal positivity is much higher, which indicate it's related to hormonal imbalance. HER2 incidence is less, or HER2 positivity is less noticed in male patients. Triple negative and ILC are extremely rare, and the androgen receptor is positive in almost 95% of the patients. So what about the symptoms? How do they present? Most of the because there is no regular screening or screening guideline for such patient, except when they are diagnosed with the gene mutation identified as mutation carrier. Usually patient present with symptoms. The symptoms is mass or nipple discharge. The delay has been reported up to 12 months, and it ranged between 1 to 120 months. In our case report, it was up to 4 years, the delay. Mammogram and breast ultrasound are the gold standard. MRI has no role in the diagnosis of male breast cancer, even if they are gene positive, and it's not routinely required. Now we diagnose them. How do we approach them? It's again, and as in any cancer, it's a multidisciplinary plan. It's derived from all the data that we have about male breast cancer. We have it from the literature and the clinical trial that was done on ladies. There are very minimal number of male patients that were included in the clinical trial, which make the decision harder. Are we talking about similar disease or different disease, two different entities? Usually the surgical treatment is mastectomy, which is related to higher stage, location of and the size of the tumor in comparison to the breast. Axilla, everybody agrees that you treat them as you treat women with axillary sentinel lymph node biopsy when they are clinically N0, when they are node positive axillary lymph node dissection. But what about managing locally the breast? So I will just talk about neoadjuvant therapy in those patients. There are no clinical trials indicating a benefit or safety, and we know that most of them are ARPR positive, which even if they receive neoadjuvant, the response is not that well to downstage the tumor to allow breast conservation. Add to this that they are small breast with a larger tumor, so obtaining a negative margin with acceptable cosmesis is a challenge. A neoadjuvant hormonal trial, they are minimal to allow for breast conservation. However, it's never. We can always try it based on multidisciplinary discussion. So I will just jump to adjuvant therapy. The adjuvant therapy in female, we know it depends on the menopausal status. How about in male? Usually, the survival, the tamoxifen is superior to aromatase inhibitor in a case control study that was done for ER positive tumor, and they compared them with female. They received, there is one arm one population with men and women. They were matched 2-to-1, received tamoxifen, and another group who received aromatase inhibitor. So that the tamoxifen treatment arm, when they compared them with the women who received tamoxifen, they did both well, and they had an equal or similar overall survival. However, if male patients receive AI, they did worse than their female counterpart, which indicate from this we extrapolate that if we are giving any new adjuvant hormonal, it should be tamoxifen, but we never know. Are we talking about two different diseases? Because we know in women, breast cancer is a heterogeneous disease. So is the gender and the outcome different related to real biological changes, or it's only to stage? So again, new adjuvant chemo and anti-HER2 is extrapolated from trial that was done in women and should follow the guidelines. And if we need new adjuvant hormonal, then it should be tamoxifen. Now, we come back to our main talk of the day, which is BCT versus mastectomy. Historically, it's been mastectomy. Nobody thought it's like important. I remember when I was a fellow at Princess Margaret Hospital, they presented a case and everybody was like surprised. He was a model and who was asking for breast conservation because he's a model. So it's like everybody in the podium was, but he's a male. But now the incidence, the use and the utility of breast cancer in male patients is becoming more and more patients are asking for it. And actually it has some psychological impact that we cannot omit. So the BCT, again, influenced by the location, tumor size to breast size. But the most important question, when you talk about breast conservation and surgery for the breast, oncological outcome is first, followed by cosmesis. We care about cosmesis and reconstruction. However, the safety comes first. We know that there is no prospective or clinical trial. However, from retrospective data, this one was published in 2013, I think, by Jordan Cloyd and his colleagues. It was from the the SEER database, and the rate of lumpectomy was 13, and it was increasing over time. And the 10 years specific survival was higher for lumpectomy versus mastectomy. And this needs to be further explored. They did not compare it with the women. However, from this, we can see that breast conservation is a safe option when feasible. Another trial. Please. Hello. Another data that was published by Patin in the Annals of Surgical Oncology in 2019. His data is about over 8,000 patients. We can see that the rate of mastectomy, because their data is more recent now. So people are more trending toward conserving the breast in male patients. And we can see the survival data that the breast conservation did well and better than patients with mastectomy. Is this related? Because patients who can undergo breast conservation are
less high grade, small tumor, smaller stage, or there is a difference that radiation therapy provide that we don't know. Okay, now what about the surgical decision? What guides other than the tumor location? What guide the surgical decision? In this trial, they included, or in this qualitative data, they included 63 patients. Only 7% of the patients underwent breast-conserving therapy. And the decision was mainly guided by the physician. The patient did not ask or request BCT. And only a third of the patients were comfortable with the decision and with the outcome. What was the responses when it comes? Why they were not comfortable? It's similar to our patient population, even though our patients were small, but they were unhappy with the flat chest, the imbalance and asymmetry, and looking abnormal, concerns about the scars, altered sensation, and the lack of the nipple all did affect the comfort level of those group of patients. Okay, now we talk about the prognosis. When you read in textbooks, they will tell you if you compare men breast cancer does worse. However, if you compare them to women or to female, they do stage by stage, they do the same. In the more recent data, this is the largest published data on breast cancer in 2020 in male breast cancer epidemiology. It included about 20,000 patients. The incidence of breast cancer in male is rising, and the women did better. They had a better survival. In another data that included less number of patients, male to female ratio, I'm not sure, but it's maybe 1%. And in this group, the male were older. We can see that these are the factors that affected the survival. The fact they differ. So we know that women with HER2 positive disease does worse than patients with who are negative. However, this was not a factor in male breast cancer. The tumor location has no effect in women with breast cancer, and this has been proven several times and reproduced several times. However, the location of the tumor plays a role in patients diagnosed with a male breast cancer. And this is the survival curves, and we see that women, when they adjust for the risk factors, the women did better in the survival, breast cancer survival mortality. So in a more, another trial, limited number of patients, when they matched the group did well. So the data about the prognosis and is it worse disease or no are conflicting. However, we have when you tell the patient, when you talk to the patient, we know limited, the data are conflicting, and we have to continue with the treatment. I don't think it should be part of the discussion. Now we come to reconstruction. Do we reconstruct? What we found, there is this systematic review published very recent.
2 minutes, huh?
Okay, I'm done almost. In 2020, it's a post-mastectomy reconstruction. It included 11 articles. 7 of them were prospective. 1 of them were, the remaining were retrospective. The method of reconstruction varied between fat grafting, silicone implants, autologous chest wall. The complication rate was low and similar to female, but it is a valid option for the patient population who are interested and ask for it. and can see Dr. Carmen is cheering in the podium. Okay. Now, the surveillance, like any cancer, by clinical breast exam, annual mammogram is part of the follow-up. In 2018, ASCO guidelines published their management guideline of breast cancer. It talked about mainly the systemic therapy and the gene testing and the surveillance. They did not, there was no mention. And I think because of the limited of data, and I don't think we should change our criteria or manage male breast cancer any differently than female breast cancer as per the guidelines we have. And the summary that they all should receive gene testing, the surveillance by mammogram, ultrasound, MRI is not needed regularly, even if the patient is gene positive and they decline mastectomy or prophylactic mastectomy. Okay, so in summary, it's a rare disease. It should be managed delicately. The data we have are limited, and it's mostly derived from different patient population. Be honest, multidisciplinary team involve the clinical nurse and involve the psychologist, and be considerate to your patient feeling, and give them a chance to have breast conservation and reconstruction if they are fit, even though sounds weird, but it's an option. And by this, I conclude my talk. Thank you very much.
Thank you very much for all the speakers for these great talks. I would like to invite our speaker to the podium for the question. Dr. Munira, do you have any question?
Yes, I do. I have one question and one request. The request for Dr. Ahmed, the cardiologist. As an oncologist, I wish that I have a cardiology clinic beside my clinic where I to facilitate the evaluation of my patient by cardiologists, but we know that it is not feasible. Keeping in mind that the cardiology clinic is crowded with serious, complicated, pure cardiac cases, and usually they get an oncology referral where there is no clear evidence of cardiac disease. They don't take it seriously, and sometimes you have weeks to be seen by a cardiologist in a cardiology screening clinic. And my request here, I wish in one day that we will have guidelines from Saudi Cardiac Association for the risk stratification and evaluation of cardiac toxicity in oncology patients before starting the chemotherapy, where we can, all of us as an oncologist will follow it. I hope that they will work on that. My question to Dr. Shehri, that we frequently seeing an elderly patient where we think that CDK4/6 is beneficial for them, but after the clinical judgment, always we sometimes lies in gray area. Where shall I give the patient because there is a benefit, or I shouldn't because the general condition and performance status of the patient? So I'm asking you, Dr. Shehri, in your daily practice, when you are in that area, do you feel comfortable to start the patient on full dose, or you start with the reduced dose and escalate it according to the patient tolerance?
It's challenging treating older patient. Older patient does not mean they will do worse, either in side effects or in the response to the treatment. I would say we should focus more in the comorbidities and performance status. And CDK4/6 inhibitor is tolerable. It's not that toxic. Based on clinical trial data and based on real world data, really there is no big evidence that tell us there is a specific contraindication not to use it, other than the thing that we know. Doing AKG, if we were going to use ribociclib, make sure about liver enzyme, it's okay. doing workup initially every 2 weeks and then maybe every month for elderly patient. We know what's the big side effects of CDK4/6 inhibitor, neutropenia. And we know it's more, the neutropenic fever is not really a problem. Neutropenia is more, but neutropenic fever is very extremely rare for the patient. So I would not really exclude any patients, even if they are old, unless there is a specific clear contraindication or there is a big comorbidities or very performance status is really very limited. And after talking to the patient, maybe then you can use endocrine therapy by itself. But the benefit of combination treatment should not be avoided. It's something that will benefit the patient. So more recently, I'm using CDK4/6 inhibitor for most of the patients. I mean, even the patient who came in a wheelchair, because sometimes this helps them, help their symptoms.
Thank you, Dr. Abdurrahman. Now back to you, Dr. Ahmed, regarding the survivorship and cardiotoxicity related to chemotherapy, and in continuation to the point by Dr. Munira. So I think I learned to listen from this presentation. One thing is the awareness from both sides, from the oncologist and from the cardiologist. And the other thing is the access. So from your presentation, most of the patients, they should have assessment for their cardiovascular assessment. And I can tell you this never happened in our clinic in daily practice. We just order echo if we think this is a high risk medication, but the follow-ups and how to get easy access with the cardiologist is the issue. So how we can improve this?
Well, thank you so much for the question. I think the interest in cardio-oncology has grown significantly higher over the past few years. The fact that actually the American College of Cardiology have a dedicated journal called JACC Cardio-Oncology tells you how much interest there is. It's 3 years back, one of my friends actually was the first graduate of the first ever cardio-oncology program from Cleveland Clinic. And this tells you that the interest has increased, the awareness is there. The issue is twofold. Not the cardiologists who should take care of these patients should be also aware of all the nature of the disease. And unfortunately, I have to admit, several times in our meeting, the first question that comes out when a patient comes with quote unquote cancer is, what's his survival? Should we do anything? And this is frustrating for me as a cardiologist, and I'm sure for you 10 times as an oncologist. And at least in the way I present these cases, I say, let's change the word from lifespan to health span. Yeah. When it comes to cancer patient, I'm not worried about his lifespan. His lifespan may be 3 months, his lifespan may be 10 years. I want him to have that span in good cardiovascular health. And that change, the concept change with the change of terminology. We should change the fact that we should not talk about a lifespan in a patient of cancer, although they already had the worst battle in their life. Now it's up to us to make sure that this span is healthy. That's number one. Now, I agree that we should call probably to a combined collaboration between the Saudi Heart Association and the Oncology Association to come up with guidelines. Myself, I spoke to our chairman 3 or 4 times that we need a cardio-oncologist on board. And this may be actually a good idea to start a clinic in which we have an oncologist beside a cardiologist in the same setting, where the patient can be seen immediately. This is feasible. All what we need is probably to put a proposal for each hospital, to put a proposal that we need this service. And I can assure you, the minute we have a better understanding of the disease, the more care and interest we have, and the more referral we have. For instance, Dr. Abdullah bin Saleh, I sat with him once and we talked about amyloidosis. And he said, well, I don't have anybody to accept them. I said, oh, fine. Send them to my clinic. I'll be happy to see them on a weekly basis. It started though thinking I'll be seeing only 1 or 2. Now, every week I have 3 or 4 referrals to see. But again, it has to have somebody that has interest towards these patients. And this will not happen if we don't have somebody who's specialized in the service. And I agree that the guidelines from both society will help, but we have as a community who take care of these patients to raise awareness by asking our administration to have somebody trained in that. And it will be your issue, Mohammed, I think.
Okay, I promise you I will get you the proposal for that. Yeah. Okay.
So, Dr. Ahmed, you are already invited to our clinic, survival clinic, and I think you are accepted our invitation.
I hope so.
Done.
Okay. So just a question to Dr. Nafisa and Dr. Abdurrahman. Now, since we are talking about elderly population, now sometimes you encounter patient with borderline functional status coming in wheelchair in the clinic, and again they have locally advanced disease. They are non-metastatic. So do you consider out of the box the CDK4/6 inhibitor in those patients in addition to conventional hormonal therapy as a neoadjuvant therapy or not?
Thank you, Mohammed. We need to assess the patient fully first, and we need to know exactly why she is on wheelchair. Is it because of her current disease, or there are other comorbidities that limit the use of CDK4/6 inhibitor? Usually what I do is to start with hormonal therapy. If definitely she's not metastatic, I will start with hormonal therapy and then bring the patient and evaluate. I will not rush for CDK4/6 inhibitor, honestly. And for example, after 3 months, if the patient is doing well, I will continue and extend the hormonal therapy, sometimes up to 1 year. If she had good response, then we can send her for surgery. Rarely actually, this is not like by guidelines, but in my practice, I'm not pushing toward giving neoadjuvant CDK4/6 inhibitor, even for patients who are having poor performance status or locally advanced, they're not amenable for surgery. Usually I start with hormonal therapy, otherwise chemotherapy if the general condition is allowing me.
Rahman, can you comment?
In neoadjuvant and adjuvant setting is totally different from metastatic disease. Metastatic disease, we have very, very clear data about overall survival. The whole setting is different. So I agree with Nafisa. In the adjuvant setting and in the neoadjuvant setting, the treatment is totally, the concept of treatment is totally different, because here we have surgery, and the adjuvant treatment is just to decrease the recurrence rate and to control the systemic disease. I wouldn't rush for adjuvant and neoadjuvant CDK4/6 inhibitor or aggressive treatment if the patient performance status is not that good.
Okay, thank you. So, Dr. Lulwa, just a question. So now for patient with BRCA2 mutation related, let's say male breast cancer. So usually for women, sometimes you can go at the same time with contralateral mastectomy. So how you approach this for patient with male with breast cancer?
Regardless, as I told you, the data on prophylactic is limited in whether in female or male. We do it because we think it will help in survival, especially if the patient is diagnosed. Maybe if it's done early, yes, it will improve the survival. However, I give the patient the option that you want it later on, or you don't want it. It's their right. It's their right to decide. This is how I look at it.
Okay. Dr. Munira, do you have any question or comment?
No, thank you. I just want to thank all the speakers for this interesting and informative lectures. It's really opened my eyes to many things, which I hope that we can utilize it in our daily practice.
Okay, thank you very much for our speakers. Thank you, Dr. Munira. And now we'll move to the satellite symposium.
Bismillahirrahmanirrahim. So first,
Assalamu alaikum. It's my pleasure now to go for second session and start the satellite symposium. Thank you, Novartis, for sponsoring this satellite symposium, and it's my pleasure and honor to introduce the speaker, Dr. Mud'ab Al-Fahedi. Dr. Mud'ab is a consultant of adult medical oncology. He is the head section of Princess Noor Medical Cancer Center at Jeddah. Dr. Mud'ab will talk about the update of CDK4/6 inhibitor, NCCN guideline update regarding CDK4/6 inhibitor. He will mainly talk about MONALEESA 2, 3, and 7 in treating advanced breast cancer. He will also give us an update from the new promising and very encouraging data, right choice data, which actually changed our idea about treating patients in visceral crisis and advanced disease or rapidly progressing. So, Dr. Mud'ab, please, we are waiting for your talk.
Bismillah ar-Rahman ar-Rahim. So first of all, I would like to thank you for your kind invitation. So this is a Novartis Satellite Symposium. So I have been tasked over the next 25 minutes to discuss with you the latest guideline update in regard to the hormone receptor positive HER2 negative advanced breast cancer, and to review the latest MONALEESA trials. So this is the final protocol specified overall survival result in patient treated with CDK4/6 inhibitor. So we have multiple clinical trial, the Monarch 3, the Paloma 2, the MONALEESA 2, MONALEESA 7, MONALEESA 3, Monarch 2, and Paloma 3. And when we look at the results, so we can see that the Paloma 2 and MONALEESA 2, as well as Monarch 3, they actually were associated with significant improvement in progression-free survival. But the MONALEESA 2 was associated with overall survival benefit, as you can see. And we know from the Monarch 3, which actually was reported and was associated with a trend toward improvement in the overall survival, but not statistically significant. And in regard to the Paloma 2, unfortunately, was not associated with overall survival benefit. In regard to MONALEESA 7, which was tested in pre-menopausal patient, was associated with both progression-free survival and overall survival. The MONALEESA-3, which actually looked at fulvestrant plus ribociclib in both first and second line setting, was again associated with significant improvement in both progression-free survival and overall survival. The MONARCH 2 and PALOMA-3 in a later line, or what we call endocrine resistant, tested abemaciclib and palbociclib plus the fulvestrant respectively, and the MONARCH 2 was associated with significant improvement in both progression-free survival and overall survival, while the PALOMA-3 was associated with significant improvement in progression-free survival and not in the overall survival. But when the investigator looked at those patients who has endocrine sensitive versus endocrine resistant, was associated with a statistical significant improvement in the overall survival in the endocrine sensitive patient population. So the ribociclib, which is the topic of this satellite, has demonstrated a consistent, significant improvement in the overall survival across all phase 3 clinical trial. So as we mentioned, in the first line therapy in MONALEESA-2 and in MONALEESA-7 in pre-menopausal patient population, and in MONALEESA-3, but with different endocrine partner here, the Faslodex. And this clinical trial, as I mentioned, was performed in both first and second line setting. So positive overall survival and progression overall survival in the MONALEESA trials. So here another look at the reported exploratory ad hoc long-term follow-up of the overall survival. So we can see the hazard ratio of MONALEESA-7 0.76 and in MONALEESA-3 0.73, while in the PALOMA-3 0.81. And we can see now that our patient with hormone receptor positive, HER2 negative advanced breast cancer, they can actually live up to 60 months. As you can see in MONALEESA-7, it's almost 59, and in MONALEESA-3, 53. And remember that in MONALEESA-3, almost half of the patient received this treatment regimen in the second line setting. So this is the new NCCN guideline version, which was released February 2023. And you can see for the patient who has hormone receptor positive, HER2 negative advanced breast cancer, the preferred first line regimen to use is the aromatase inhibitor plus CDK4/6 inhibitor. And it has been added that the aromatase inhibitor plus ribociclib as category 1 in yellow. Also aromatase inhibitor plus abemaciclib was there, and the aromatase inhibitor plus palbociclib was also mentioned. In the second line setting, you can use fulvestrant plus CDK4/6 inhibitor, and under that fulvestrant plus ribociclib was category 1, and the fulvestrant abemaciclib was category 1. And what does it mean? It means that in phase 3 randomized control trial, ribociclib plus endocrine therapy, whether it was aromatase inhibitor or fulvestrant, demonstrated overall survival benefit in both first line and second line setting. And this is to look at the magnitude, the clinical benefit score of the ESMO, which, as you know, has been divided or categorized into 1, 2, 3, 4, 5, where 4 and 5 represent the substantial benefit from and intervention. 3 represent a moderate benefit, while 1 and 2 represent a negligible benefit. And as you can see, the ESMO MCBS score, ribociclib as per MONALEESA-7 was scored 5, and ribociclib plus AI was also representing 4 according to this scale. The palbociclib with letrozole as well as abemaciclib with AI in postmenopausal patient were 3, and we have 4 score for the ribociclib, palbociclib, abemaciclib plus fulvestrant as shown on this table. So first line treatment, we have the MONALEESA-7 and we have MONALEESA-2, which represent the highest 5 and 4 respectively. And in the second line setting, we have ribociclib, palbociclib, and abemaciclib with a 4 score. This is the German guidelines. So as you can see that the LHRH plus AI plus ribociclib was 1B level of evidence, while the other CDK4/6 inhibitor had a 2B level and some 3B/5. So let us now review the overall survival result from the MONALEESA, from the different MONALEESA trial. So this is the MONALEESA-2 trial, which was conducted in postmenopausal patient with hormone receptor positive, HER2 negative advanced breast cancer, a phase 3 where patients were treated with endocrine therapy plus minus ribociclib. So this is the study design you are all aware of. So no prior therapy for the advanced disease. Patients were randomized in 1-to-1 to receive ribociclib at 600 milligram per day, 3 weeks on, 1 week off, plus letrozole versus placebo letrozole. And the primary endpoint was PFS, and the secondary endpoint was overall survival. And this is the patient disposition. So the treatment was actually going in approximately 9% compared to 5% in the placebo arm. So 91 of the patients, they completed their treatment in the ribociclib arm versus 93. And as you know, the most common reason to end the protocol treatment was progressive disease in approximately 78.7% in the placebo arm compared to 61.1%. And when we look also at the adverse event, we can see that approximately 11% they discontinue their treatment due to adverse event in the ribociclib arm versus 2.7, almost 3%. So this is the overall survival. So as you are aware, after a median follow-up, the improvement was observed with the combination of ribociclib and letrozole. So the median overall survival was actually beyond the 60-month or beyond the 5 years, so almost 64 months versus 51.4 with the hazard ratio of 0.76 with a 12.5 month and absolute benefit. So this is actually a remarkable improvement in the treatment of our patient, that they can live beyond 5 years. And most importantly, that the overall survival benefit was actually increased over time. So when you look at 4 years, 5 years, and 6 years, you can see that the absolute benefit start to increase from approximately 6% to 8% to 12.2%. And when we look at the subgroup analysis, we can see that we cannot identify a subgroup who actually benefit less from the combination. So most of the subgroup actually benefit from the ribociclib and letrozole combination. And this is just to show you the subsequent therapy after discontinuation. So you can see that some patients, they actually used other CDK4/6 inhibitors. So the palbociclib was used in approximately 16% in the ribociclib arm and was 31.5% in the placebo arm. In regard to the safety, the regimen was actually very well tolerated, and we know that the ribociclib was associated with neutropenia, hepatobiliary toxicity, and prolonged QT interval, which was actually 4.5% versus 2.1% in the placebo arm. And as with other CDK4/6 inhibitor, the interstitial lung disease was actually observed in 0.6% in the ribociclib arm and nil in the placebo arm. The updated overall survival of the MONALEESA-7, which was conducted in pre or perimenopausal patient with hormone receptor positive, HER2 negative advanced breast cancer patient who were treated with the same regimen as MONALEESA-2, so ribociclib plus endocrine therapy plus LHRH. So this is the study design. So patients were not allowed to have a line of chemotherapy. Actually, it was the only clinical trial in the first line setting where patients were allowed to have at least one line of endocrine therapy, but there was no prior endocrine therapy for advanced breast cancer. Randomization again was 1:1 to ribociclib, 3 weeks on, 1 week off, plus endocrine treatment, including TAM and gozerline versus placebo and endocrine treatment plus gozerline. And again, the primary endpoint was PFS and overall survival, as well as other selected secondary endpoint. So again, we can see that the treatment was still ongoing in approximately 20% of the patient in the ribociclib arm. So approximately 80% they completed their treatment compared to 9% who was still on treatment in the placebo arm, with 90% completed their treatment. And the main reason was progressive disease, so which was higher in the placebo with approximately 74% versus 63%. And this is the overall survival in the intent to treat population. So the combination of ribo and endocrine treatment was associated again with statistical significant improvement in the overall survival. So the hazard ratio was 0.76. So we are talking about approximately 24% absolute reduction in death, and the median overall survival was increased from 48 months with the placebo arm to 58.7 months, so approximately 11 month absolute benefit. Again, when the investigator looked at the subgroup analysis, you can see from this slide that most of the subtype benefited from the combination of ribociclib, including those patients who has lung or liver metastasis, including those patients who has bone metastasis only. And also when they look at the different number of the metastatic site, whether it is less than 3 or more than 3. And this is to look at the subsequent treatment. And you can see that in patients who were treated with ribociclib and letrozole, when they used the subsequent CDK4/6 inhibitor, the palbociclib was the most common with 9.5, followed by 1.5 different CDK4/6 inhibitor with abemaciclib. What about the adverse event? As we mentioned earlier, the CDK4/6 of ribociclib is associated with bone marrow suppression of neutropenia, leukopenia, anemia, but it was infrequently associated with febrile neutropenia. It is also associated with rising in the liver function enzymes. The QT prolongation was seen in 1.8% in grade 3, 0 grade 4, and in total was 12.8 compared to 6.5 in the placebo arm, with less than 1% grade 3 and actually 1 patient or 0.3 grade 4. This is the MONALEESA-3, which actually a unique clinical trial because, as we mentioned, included both patients in first and second line settings. So the updated overall survival of the first line population in this clinical trial was updated. So the MONALEESA, as you can see, they have no prior chemotherapy for advanced disease and less than 1 line of prior endocrine therapy for the advanced setting. So it is in the first line setting. So patients in this clinical trial were randomized into 2:1 with ribociclib plus fulvestrant versus placebo and fulvestrant. And they actually included patients in the first line setting where we are going to present. So those patients who has treatment naive for advanced breast cancer, either they presented with de novo advanced breast cancer or they had more than 12 months of treatment-free interval, or what they call late relapse. So the primary endpoint was PFS and the secondary endpoint was overall survival. And this is the median overall survival with the first line ribociclib, which was 67.6 months compared to 51.8 months with the placebo. So this is actually statistically significant with a hazard ratio of 0.67. So we are talking about really a significant number and a clinically meaningful of 33% risk reduction in death. And this is the subsequent treatment. So some patients used chemotherapy and it was more in the placebo arm. And again, some patients also, they were treated with different CDK4/6 inhibitor. So this is the Right Choice trial, so which was presented lately at the San Antonio Breast Cancer Symposium. And actually, we are really proud of having some of our colleagues on this clinical trial. As shown, Dr. Hamdi Abdelazim and Dr. Naji Al-Saghir. And we have also some colleagues who participated in this clinical trial from the kingdom. So this is the background of this clinical trial, where the chemotherapy is the standard of care in the advanced breast cancer with the clinically aggressive disease. And the clinically aggressive disease actually was defined as rapidly progressive or highly symptomatic disease and life-threatening visceral crisis. Those patients usually require rapid disease control, and usually we use the combination chemotherapy trying to have a rapid response rate and to control the disease. And the ribociclib plus endocrine therapy, as we know, demonstrated the statistical significance in both PFS and overall survival over the endocrine therapy in 3 clinical trials of Mona Lisa 2 and 3 and 7. And so this was actually the phase 2 right choice trial, where the primary analysis of PFS and the important secondary endpoint from this open label randomized multinational trial was presented at San Antonio Breast Cancer Meeting. So menopausal women with hormone receptor positive, HER2 negative advanced breast cancer, and in here they define the estrogen receptor positivity more than 10% with no prior systemic therapy for the advanced disease. Those patients has aggressive disease, as we mentioned, symptomatic visceral metastasis, rapid disease progression, or impending visceral compromise, and patient who also has markedly symptomatic non-visceral disease with good performance status, and the total bilirubin was less than or equal to 1.5 upper limit. 200 patients were randomized in 1-to-1 to receive ribociclib plus letrozole or anastrozole plus gozerline versus the treatment of physician choice chemotherapy, so either docetaxel with capecitabine, paclitaxel with gemcitabine, or capecitabine with fludarabine. Tumor imaging evaluation was done first weekly for the first every 6 weeks. For the first 12 weeks, then every 8 weeks for the next 32 weeks, then every 3 months. And the primary endpoint was PFS, and the secondary endpoint was multiple, including overall survival. So I will skip the statistical method. So as you can see that the median age was approximately 44, and we have also 71 who has more than age 40, 53 were Asian, and grade 3 was 1/3. Grade 2 was most commonly approximately 60%, and more than 50% estrogen receptor positivity was 85% in the ribo compared to 86. Progesterone receptor positivity was 88 versus 92. Patient who presented with de novo was 63 versus 66, and we can see that liver metastasis and lung metastasis on individual was common, 50% and 56% in the ribociclib arm, and almost 80% of the enrolled patient has either liver or lung metastasis. So according to the aggressive disease characteristic, 20% had rapid disease progression, 13% had symptomatic but non-visceral disease, and 66% had symptomatic and symptomatic visceral disease. And the visceral crisis was 54 versus 50%. And the treatment is ongoing in approximately 46% of the patient in the ribociclib plus endocrine treatment arm, compared to only 23.6% in the placebo arm. 44 of the patient in the ribo developed disease progression compared to 52.7. And this is the result. So the first line ribociclib plus endocrine treatment was associated with a statistical significant PFS benefit of approximately 1 year over the combination chemotherapy in the aggressive hormone receptor positive HER2 negative advanced breast cancer. So you can see that the hazard ratio was 0.54 with a significant p-value of 0.0007. When the investigator looked at the subgroup analysis, so the PFS benefit was actually consistent over different subgroup, especially the disease-free interval of more than 2 years. And the median time to treatment failure was actually longer with the ribociclib plus endocrine treatment compared to the combination chemotherapy. So it was 18.6 versus 8.5. So we are talking almost 10 months in median time to treatment failure with a hazard ratio of 0.45. And this is the objective response rate and the clinical benefit rate, which were similar between the ribociclib and endocrine treatment compared to the combination chemotherapy. So from this slide, we know that the combination is not doing any better in regard to the rapid control to the disease. So you can see the objective response rate was 65% with the ribo, 60% with the chemo, and the clinical benefit rate was 80.4 with the ribo and 72.7 with the chemotherapy. What about time to onset of response, which is really another important endpoint, and actually was similar between the two treatment arms. So was 4.9 with the ribociclib, so almost 5 a month versus 3 months with a hazard ratio of 0.78. And what about the dose reduction? And when the investigator looked, they actually found that a fewer dose reduction was performed in the ribociclib treatment arm in compared to the combination chemotherapy. So the median duration of exposure to the study treatment was 15 months in the ribo and was only 8.6 a month. And this is actually reflecting the tolerability as well as the efficacy. And the side effect, as we mentioned it, there is no actually new signal. The treatment related serious adverse event of all grade was approximately 2% in the ribo and 8% in the combination chemotherapy. The side effect which led to discontinuation was 7% in the ribociclib arm and the 23% in the combination chemotherapy. So in conclusion, the right choice is the first prospective study which compared the CDK4/6 inhibitor plus endocrine therapy with the combination chemotherapy and actually demonstrated PFS superiority of ribociclib plus endocrine treatment over the combination chemotherapy in patients with aggressive clinical feature of rapidly progressive or highly symptomatic disease, including visceral crisis. So the statistical significant PFS benefit was almost 1 year with a hazard ratio of 0.54. So it was 24 months versus a 12.3 month PFS benefit. So again, the combination of ribo and endocrine treatment showed longer TTF than the combination or treatment to failure in regard to the combination with similar clinical benefit rate and objective response rate. And there was no new safety signal observed in the ribociclib and endocrine treatment. And when compared to ribo, the combination chemotherapy was actually associated with more treatment-related adverse event, which actually impact the quality of life. So in conclusion, the first-line ribociclib and endocrine treatment offer an efficacious, clinically meaningful treatment option for patients with aggressive hormone receptor positive, HER2 negative advanced breast cancer, obviating the need for the combination chemotherapy and its related toxicity. And with that, I would like to thank you all for your kind attention, and I will be happy to answer your question. Thank you.
Thank you so much, Dr. Mudeb, for this comprehensive review.
You are welcome.
Do you have any questions? So I have question, Dr. Mudeb. In real life scenario in the clinic, with this data from Right Choice in the clinic, how can you decide between chemotherapy and CDK4/6 inhibitor in combination with hormonal therapy? Who is the right candidate for the Right Choice, and who is the not candidate for the Right Choice and should have go for chemotherapy?
Thank you so much, Dr. Nafisa, for your question. So actually, the Right Choice really is very interesting phase 2 clinical trials, which, as you heard, is looking at some patient who presented with a very aggressive disease. So I asked this question to the investigator, what is the definition of aggressive disease? And what they actually mentioned, they mentioned that the sub-investigator enrolled a patient who otherwise will need chemotherapy if they were not enrolled in this clinical trial. So just imagine that when you decide to give a patient a palliative chemotherapy, and that's why they said a rapid disease progression, or they mentioned that if the patient is having symptomatic non-visceral, so patient who has bony metastasis, not responding to pain medication and maybe radiation treatment, as well as the patient who might present with symptomatic visceral disease. So in that case, they enroll that kind of patient to either treatment option. And as we can see from the Right Choice, that there was no actually difference in the objective response rate and the clinical benefit rate, but actually there was a statistically significant improvement in PFS, in the time to treatment failure. And in the and this is actually very important, because always when we think about chemotherapy, we always think about rapid response and rapid control. So I think patient now we have evidence that you can use the CDK4/6 inhibitor for such a patient, but really it's very important that we follow those patients very closely. So just in case if you will change your treatment option, remember that they follow this patient every 6 weeks. So like you can say 1.5 months they did imaging just to make sure that those patients are receiving and responding to the treatment.
Do you think we really need that, Dr. Mudaib? Do you think we need to image the patient every 1.5 months? Or sometimes the clinical picture or the blood test might tell you what is going on?
Yeah, absolutely. You are right. But you know, when you are doing a clinical trial, you have to show that there is a difference between the two treatment interventions. So we have to have objective response. So, but to be honest, like usually in my patient, like in the prior patient who has visceral crisis, when I start them on chemotherapy, I can sense the response from the clinical judgment. So, for example, if there is improving in the liver enzymes, there is improving in the shortness of breath or respiratory symptoms, in the abdominal pain, I know that those patients are responding to the current treatment.
Do you have any other question? Thank you, Dr. Mudaib. Thank you so much. I think by this we can conclude the session. Thank you.
Thank you.
So we'll take a break for 40 minutes. We will be back, inshallah, 1:50. 1:50, inshallah. See you, inshallah. Thank you.
السلام عليكم.
وعليكم السلام، اهلا شادي، كيف حالك؟
أهلا مروان، كيف حالك؟ شو أخبارك؟
الحمد لله. انا بيرسلوا لي اونلاين بس شكلهم لسه في البريك. ماني شايف احد معنا.
أنا موجود.
طيب اوكي.
عبد العزيز كيف حالك؟ خير، شو أخبارك؟ بشرنا عنك.
حبيبي طيب، اخبارك مبسوطين؟
الحمد لله.
معنا اونلاين ولا فيزيكال كمان؟
لا أنا أونلاين، أنا برا السعودية.
ما شاء الله، ما شاء الله. اوكي، انا وانت، امين العمير، وسالم الشهري، عبد العزيز المودريتور، وامين التيجاني.
يس.
At least we tested our voices that we can hear each other. يعني. And I think they also can hear us because I see in the question and answer box. تمام.
Assalamu alaikum. We will be starting in 3 or 5 minutes maximum.
Can you hear? I think we cannot hear you. Make sure you are close to the microphone, please.
Marwan, he said they will be starting in 5 minutes.
Okay.
We are connected.
كيف حالك يا عبد العزيز؟
خير بشرنا عنك.
الله يبارك فيك يا رب. ايش اخبارك؟ منور.
منورك الله يسلمك.
ايش يا عبد العزيز في الامريكان يورولوجي ولا فين؟
لا والله
يوروبيان يورولوجي.
لا والله ماني في اي ميتنج انا مع الفاميلي جاذرينج في تايلاند.
This is more important than anything else.
السلام عليكم. Let us start. So now start the session 5. I will moderate this session with Dr. Abdulaziz Al-Hamid. Dr. Abdulaziz Al-Hamid is a consultant radiation oncology at Prince Sultan Military Hospital. So the session will be about treating breast cancer patients with brain metastasis and oligometastasis. So I will introduce the first presenter, who is Dr. Marwan Al-Hijali. Dr. Marwan Al-Hijali is Associate Professor, Head of Oncology Division, Head of Clinical Trials at University of King Abdulaziz in Jeddah, Saudi Arabia. Dr. Marwan will speak about the sequencing therapy in HER2-positive breast cancer with brain metastasis. So, Dr. Marwan, please, the floor is yours.
Thank you. Thank you, Dr. Amin. And thank you for the invitation, Dr. Nafis, and everyone. It's my pleasure to be here with you. And I'm just have a small task about the discussion of sequencing therapy in HER2-positive metastatic breast cancer with brain mets in particular. All right. In general, HER2 disease is well known actually for brain mets, and most reaching up to 50% of patients will develop brain mets. It's a very significant number, and it's affecting actually their outcome. As we all know that over the last 25 years, we discovered a targeted therapy and started treating HER2-positive disease, switch from the worst prognosis to almost one of the best actually prognostic marker in breast cancer since we discovered the anti-HER2. However, we're still struggling with dealing with brain metastasis, and we have many tactics actually to deal with the brain mets. However, we're still behind, and we hope for more better treatment. This is just to give you an idea. It takes about 40 or 50% of the patients will develop actually brain mets and death from brain mets within 5 years, regardless whether they took trastuzumab or adjuvant Herceptin or not. The numbers are variant, and it depends on which was the cause of the brain mets or no brain mets. TDM1 is another treatment that we have, and we use it for high-risk patients who did not achieve complete response. However, if you see in the circle in front of you, we're still having a high number of CNS relapse, reaching up to 6% for those patients during their follow-up. So really, even TDM1, strong medication, but yet is not dealing or tackling the CNS metastasis. How do we treat CNS disease? Surgery is one of the options, stereotactic surgery or whole brain radiation, and also systemic therapy. In general, we have some guidelines about how to deal actually with patients who we think that they might have some sort of brain disease. Imaging is important.
Do something good.
Imaging is very important whenever the patient has any symptoms, headache, visual changes, seizure, or whatever. We have very low threshold to do brain imaging for any patient who has any new onset of symptoms. And I think that's a very important message, especially for our trainees who are still learning about oncology. That's one of the things. Most of my patients actually, they present with some sort of vertigo or dizziness, and it turns out to be a brain met. So really, having low threshold is very important to deal with this problem as soon as possible. The best imaging is, of course, MRI of the brain using contrast to define all the lesions. Some of the initial approaches that recommended by ASCO is to do biopsy if possible or needed, especially if we have some discrepancy in terms of the behavior of disease. Surgical optional removal of the tumor is recommended if it's possible and if it's just one local area. Doing another histological testing in terms of biomarkers and molecular profiling is recommended if it can be done. But we all have to remember that radiation is a must after resection, and 50% recurrence occur within 1 to 2 years after radiotherapy. So still, even with treatment with surgery and with aggressive intervention, there is a higher chance of recurrence of the brain. We have the radioactive surgery and we have whole brain radiation. And if you think about it, of course, if you do stereotactic, is better than whole brain in terms of symptoms, declining memory and other cognitive symptoms that can occur to the patient. That's for cognitive deterioration. However, in terms of overall survival, there is no difference between the two approaches. And if we look for patients with limited brain disease, it looks like having SRS is better than adding whole brain radiation to smaller lesions or limited lesions in the brain. As we see here, there is no difference between just doing SRS or doing SRS plus whole brain radiation if we have 1 to 3 brain metastases. What about systemic therapy? We have some data from the past using small molecule anti-HER2, lapatinib plus capecitabine. And if you look here in the CNS overall response rate, it's ranging from 18 to 66%, which is a very huge percent. However, that's just reported or demonstrated in very small data collection. In terms of median PFS, there is not that much difference, but anyway, just to know that we can reach up to 66% in terms of response rate. However, there was a trial that done after that using lapatinib plus capecitabine versus trastuzumab plus capecitabine, looking for patients in terms of just recurrent CNS recurrence. However, the trial was stopped because there was a large number of futility in the lapatinib arm. So it was the end of that study, actually. But if we look at the numbers, CNS first site of progression, I don't think the numbers are too small to come up with any conclusion. Another study similar to the lapatinib, they used naratinib in a single arm study. And they use it for both patients who had lapatinib before or who are lapatinib naive. And they saw that the CNS overall response was around 50% in the lapatinib naive arm. It was less than that in the patient who received lapatinib in the past. However, it shows that there is some response in the CNS. It means that the drug is reaching there and causing some activity. And of course, another study also for naratinib, but this time it was compared to trastuzumab plus paclitaxel. So naratinib plus paclitaxel versus trastuzumab plus paclitaxel. It looks like there was some actually disease control in terms of CNS event. And as you see here, about 10% difference in CNS recurrence at 2 years. And it was significant with a p-value of 0.002. So that was also, which looks like another option for those patients. Then there was the NALA study, which is the combination of naratinib capecitabine versus lapatinib capecitabine. And this study actually was in favor of the use of naratinib capecitabine. median PFS 9 months compared to almost 7 months with a significant p-value. And the hazard ratio in terms of overall survival is 0.88. However, if you look at the overall survival, it didn't look like it's much different. The p-value was not significant. So PFS benefit, but no overall survival benefit. But this is just a comparison between using two anti-HER2 small molecule inhibitor. This is the CNS specific outcome, which again, I don't think there was like much difference. There was almost like 3 or 4 months difference in here, but the p-value was not significant. We have also the TDM1, the Camilla exploratory analysis for patients with brain metastasis. And if you see here, the response of brain lesion, the partial overall response rate was around 21% for a patient who were placed on TDM1 as a treatment for their HER2 positive disease. So there is some CNS activity, but it's only around 21%. The clinical benefit rate is about 42%. Then come to the most important study in metastatic HER2 positive disease, the HER2 CLIMB study, although it's a phase 2 study, but it's a very important study in our field. The study was designed just to look at the benefit of the disease overall. However, brain mets was allowed, and part of the patient had some brain mets. And if you look here, brain metastasis was in 291 patients. The active brain metastasis was in 174, and stable brain metastasis was in 117. So a good portion of the patient had some brain metastasis. Some of them had active lesions, others had stable lesions. This is just the patient characteristics in terms of patients with brain metastasis in particular. If we look here, some of them actually also had ER or PR positive disease. Most of them ended up with a local therapy, whether surgery or whole brain radiation or target radiation. If you look here in terms of benefit, the addition of tucatinib to trastuzumab and capecitabine was better than the combination of trastuzumab and capecitabine. Here we can see clearly the separation between the two curves in terms of CNS progression-free survival. As you see here, hazard ratio 0.32, very significant p-value. So 68 reduction risk of CNS progression or death, which is very significant. If we look also at the overall survival, there was some overall survival advantage for those patients. Hazard ratio is 0.58, and p-value is 0.005. So it looks like this combination is active with a good brain activity. So when they separate the two patient population into active brain lesion, we see here that patients with active brain lesion, again, the progression-free survival as well as the overall survival showed benefit for the addition of tucatinib. And when they looked at this patient with stable brain metastasis, actually there was a benefit in the PFS. However, the overall survival rate, it didn't show any benefit, or I wouldn't say it was not significant. The numerical benefit was not significant statistic. In terms of response, we're reaching 50% response rate with the addition of tucatinib to trastuzumab and capecitabine. In terms of adverse event, tucatinib, it's caused very significant diarrhea and Hatfield syndrome. Also other side effects, but I think that's a major side effects that we saw in the study with the addition of tucatinib. Another drug, which is the deruxtecan, which is TDX or Enhertu now, Enhertu medication. The DESTINY Breast 01 actually was an exploratory study, but in particular, they looked at patient with in terms of CNS progression-free survival. And if you see here, it looks like the median overall progression-free survival for CNS was 18.1 months, which is a good number actually, if you look at it compared to all other numbers in terms of PFS. So for that, they did the DESTINY Breast 3, and part of the population, they allowed actually patients with brain mets, and some of the patient has had actually brain mets at the time of the study, around 20% of the patient. And when they look at the subgroup analysis, they found actually for patients who end up with deruxtecan, they did better than patients who end up with TDM1. If you look at the median progression-free survival, it was 15 compared to 3. And at 1 year, it was 72% compared to 20%. The hazard ratio was 0.25. So really, numerically, these numbers looks very great. The overall response rate in brain mets was almost 70%. That's a number that we haven't heard before. And there were actually some intracranial complete response around 30%. So if you look at all the data that we presented, we have the combination of tucatinib with trastuzumab and capecitabine, the overall response rate reaching 50%. The median PFS is around 9 months, and the overall survival 21 months. Whether they have active brain lesion or stable brain lesion, yes, there was some discrepancy, but if you look at the median overall survival, it's all perfect for that group. If we look at the small molecule inhibitor in combination with capecitabine, we have overall response rate around 30%, less than the addition of tucatinib, and we have overall survival reaching around 14 months. Similarly, which is the TBCRC study showing similar numbers, not that different, although we have a better overall response rate. However, the survival was similar. We have then the DESTINY studies. In the DESTINY Breast 01, we had higher number in terms of PFS. When we did the DESTINY Breast 03, the number in terms of PFS was actually less, or the duration was less. And in terms of overall response rate, with the DESTINY 1, we have 60%. With the DESTINY 03, we have 67%, close to 70%, which is very, very significant. The TDM1, I think now we can predict that only 20% response rate because we have two data to support that. So looking into all of this, the best numbers we have is actually maybe between the deruxtecan and the addition of tucatinib. All right. These are some actually novel agents that's being tested for use in metastatic HER2-positive disease. And this is the ESMO guidelines when you look at it in the second-line setting with brain metastasis. If the patient has active lesion, we have to decide whether local intervention can be done or not. If local intervention can be done, the patient should go there. Otherwise, if local intervention is not indicated, the two options they listed is tucatinib, capecitabine, trastuzumab, and then trastuzumab deruxtecan. Those are the two options with the preference for tucatinib. If the patient had stable brain mets, deruxtecan will be the agent of choice. Also, TDM1 will be the agent of choice for those patients since they have stable disease or treated disease that doesn't require extra intervention. So whenever there is an active lesion in the brain, maybe tucatinib is the way to go. I think in the future, we might have some support for the use of trastuzumab deruxtecan. However, so far we have just the phase 2 trials. So really no randomized phase 3 trial. So in my conclusion, with brain disease, apply local therapy whenever possible, change systemic therapy if there is a systemic progression. So don't consider changing systemic therapy if there is no systemic progression. We see that all the time. We cannot change that. It's better to treat the brain as a different organ and don't change systemic therapy unless you have a systemic progression. Tucatinib, trastuzumab, and capecitabine is the preferred option. TDXD is another option. Neratinib plus capecitabine can be used if other treatment is not available. TDM1 also can be used if other medication is not available. With that, I thank you.
Thank you very much, Dr. Marwan, for this richful and interesting speech. It's my pleasure now to present Dr. Shadi Al-Khayyat, who is Associated Professor in King Abdulaziz University in Medical Oncology. He obtained his degree in, he is American board certified as well as Canadian board certified in both internal medicine and medical oncology. Dr. Shadi will give us talk about HER2-low as a separate entity, again, for in the oligometastasis setup. Dr. Shadi, تفضل.
Thank you, Dr. Abdulaziz, for this nice introduction. Thank you, Dr. Amin, for chairing this session. First, I'd like to thank Dr. Nafisa for arranging this is as an interesting entity, why we have special discussion, and we had a very interesting discussion about common question that we face in the clinic about the fertility in the last day, and that was a great knowledge, I believe, for everyone. So thank you for this invitation to this great meeting. So over the next 15 or 20 minutes, I'll be discussing about the HER2 low disease, and the topic was this a separate entity or not. The main reason why I believe there's a little bit deviation from the session itself, because they're focused about brain metastasis, but this is a special type of cancer that we're going to be seeing more and more, and I believe treating them with the special consideration will make a difference in patient characteristic. So quickly, I'll be focusing about the data for what is the HER2 low breast cancer and the impact of being a HER2 low. And this is, I think, it's very important as their data is growing there. And then the general role about the directed therapy, where these the combination of the targeted plus traditional chemotherapy. And then the DESTINY-4, which is the main data, has kind of putting a light in the HER2 low breast cancer. So HER2 low breast cancer, this is a separate entity where we have the patient with the breast cancer get diagnosed, and pathologically the discussion or the labeling the patient as HER2 low, it's either if the patient is having HER2 of immunohistochemistry +1, so this is a clear criteria, or if the patient is +2, however, the FISH is showing negative for being positive. So it's where we call it to be an intermediate before or a low expressor for the HER2. And why this is has been selected, because if the patient is having FISH positive or HER2 +3 from the beginning, this will be falling through the algorithm of the HER2 overexpressing disease. So this is why this is a special entity. How frequent we see that, it's unfortunately, it has been a common percentage of patient population. However, it hasn't been taken specifically as a group before, despite that they have a different prognosis. And they might be accounting for 40% to 50% of all breast cancer patients. And it's common, in patient with the HER2 positive, that's the majority of patients that we see, that the 60% of them, they're HER2 low expression. And in patient with triple negative, and I believe this is one of the interesting part, because we know triple negative is has been treated based if it +1, and we have been considering this triple negative. So 1/3 of these population, they might fit to be a HER2 low by definition, and this is open a lot of option for treatment, because we know that triple negative is one of the big killer in our breast cancer patients. Unfortunately, one of the diseases that has a poor prognosis. However, we might be able to add some treatment option for these population here based on being a HER2 low rather than being a HER2 negative disease. So is this disease is the HER2 low breast cancer is similar to HER2 positive or they're different? So biologically, it looks there's a growing data that's showing that these are different. And why is that? Because the level of the BRCA mutations that has been there is is different. And at the same time, further, we know now we have to talk about targeted treatment. So PIK3CA and the P53 is one of the known mutations where we start to have a targeted medication for such patients with these mutations. And this they have a different levels in those two type of patients. So HER2 negative and HER2 positive and HER2 low, they have completely 3 different type of disease. And as we say, there is a transformation. So we know, classically, we used to say, 10% of patients from ER/PR positive initially, once they metastasize, they become ER/PR negative. And also the HER2, almost 7%. But now, there was a retrospective data on collected tissue diagnosis about, patient who, develop a transformation where the recurrent disease, 33%, they become as a HER2 low disease. So, this is just enhancing the role of, rebiopsy is very important. So please consider the rebiopsy whenever it's possible. I know, this is one of the debatable data where, when to consider the rebiopsy. Some people, they say 1 year, some people say 3 years. But again, data is more showing that the development or the cellular transformation will make a change in the cellular biomarkers, and that might change the selection criteria for the treatment for such a patient, or maybe open a window for a new treatment that we consider. So I personally was not aware about this changing soon. So I used in my practice before to consider rebiopsying every 2 to 3 years if there's a separate from the initial biopsy. But more recently, now we have more molecular testing, so we're considering almost rebiopsy whenever it's possible. So have that part of your discussion with the patient, especially when the site of metastasis is applicable for a biopsy. As we know, we had a challenge for biopsying bone all the time. So visceral disease, they might be accessible for rebiopsy all the time. So for HER2-low treatment, so is this a patient who would benefit from her usual Herceptin treatment? The answer is no. The data support, that was studied in this patient, the use of trastuzumab alone or trastuzumab plus Herceptin alone would not be a good option for this population. However, for these special, receptors and pathways, they have been found, that these patients, they might have, benefit from the PIK3CA as the HER2-low. They have a higher expression of that. So always think about, alpelisib that we have been using in breast cancer patient. AKT inhibitors might be a good idea because, the AKT pathway is involved in this patient, and there is multiple study is going right now on the apatecertib and also in the capivasertib ongoing right now in a clinical trial. Does that lead to a different change in the signal for the hormone for immunogenicity? This is again, it's ongoing clinical trials because such a tumor may be more immunogenic than the regular normal breast cancer that HER2 negative or positive. So this is maybe a special disease where immunotherapy can be combined with the other tyrosine kinase inhibitor to generate a very aggressive treatment against such an aggressive disease. So this is the treatment that has been right now under the as a combination treatment. So we know that the TDX1 or the Enhertu has been already approved in the multiple lines. However, still we have multiple other treatments that's coming already there in the clinical trial. So it's expected that the changing maybe the carrier or the antibody and then changing the conjugate might have a different effect on the profile. So we know that the TDX1 that we're using now, it has a topoisomerase 1 inhibitor, but if you see the other combination, they have a different conjugate added to the antibody, and that might enhance the activity against cancer cells. So we know that we have been treating right now, or at least patient has been treated before if they have +1 HER2 as negative. So this patient has been included in the trials where CDK4/6 inhibitor has been involved heavily in the treatment for metastatic hormonal positive disease. However, it might be one of the reasons why we see resistance in this patient, that there might be a HER2-low disease. So this is it's very interesting finding. And there was a big study has been done in the retrospective data from specimen samples in the ATAC trial and Big Eye 98 trial on the letrozole in the adjuvant setting. They found big population of these patients, they have a different survival. So they found a patient who's having a HER2-low disease. Okay, the progression-free survival in metastatic disease is different. It's almost a half of the patient who does not have the HER2-low disease. So this is another still despite it being a retrospective data, however, still it's significantly put a light on the role of the HER2-low disease being a negative prognostic factor. However, still because as the data is not well mature enough, so we cannot say it's clearly a negative prognostic factor despite the behavior of this disease biologically is very aggressive. Why or how this has been translated in a more advanced clinical trial. So we have this patient who was treated post progression, and the deruxtecan has been published in the New England Journals saying that these patients who has been showing the disease progression after at least one treatment. So regardless whether they're hormonal positive or negative. So patient with the HER2 low disease by definition, so either immunohistochemistry +1 or +2 with a negative FISH. And this patient, at least progressed on 1 or 2 lines, even that's a hormonal treatment. They randomized to chemotherapy, what's usually we're doing for them, or they randomized to the deruxtecan, trastuzumab deruxtecan. And that's was 1 to 2 randomization with the progression-free survival as the major or the main endpoint. However, overall survival also has been reported in this trial. So this is the Destiny 04 that Dr. Marwan has put some light on the brain metastasis in his discussion too. So it's clearly these patients, they are the classical patient who presented. So we see here that these patients they're hormonal positive and hormone negative for ER, PR. They have brain metastases, visceral metastases, and lung metastases. However, majority of patients in this study was stable brain disease. So that's why it's quite important. And they put the patients two populations. So one population including all patients, and then the other population in hormonal positive. So we expect triple negative to have more analysis. So that's why they did 2 analysis in this population. And this is quickly the previous treatment. So there's patients who received up to 3 lines of treatment before, which means that this treatment could be very efficient in patient heavily pre-treated before. So that's was the first hallmark findings with the progression-free survival. And if we see here that this is in all patients, there was almost a doubling of the progression-free survival from chemotherapy arm was 5 months, and almost 10 months in the deruxtecan arm. And also when they take the hormonal positive disease, and this is where it's very interesting, it's telling that there's population here would benefit from that treatment as they're HER2 low. So the doubling time was the progression-free survival has been doubled in this population. And when they come to overall survival, so it was a big difference, almost doubling of the data with adding 6.5 months in both population, dictating that this is the deruxtecan trastuzumab would be an excellent medication for this population. And when you see the different group, it's almost all the group they benefited from the deruxtecan arm in comparison to the chemotherapy arm, especially as we say that this patient has been heavily pre-treated, so some of them would not tolerate the chemotherapy side effect. And then here, when we see about the HER2 negative, so this is that patient was labeled before as a triple negative disease. So still these patients now, because they're HER2 low, the patient, so at that time you can see clearly here that there's a difference that was statistically significant between the use of deruxtecan and the chemotherapy in both progression-free survival and overall survival group. And if you see the response, compared to the chemotherapy, significantly the response is better, and at least doubling of the response supporting the use of deruxtecan. And the interesting part when we come to talk about side effects, as this is in comparison to chemotherapy, so majority of patients had a little bit more increase in the chemotherapy side effect in compared to the deruxtecan, apart from the interstitial lung disease and pneumonitis, which is very important. So this data was mainly from the breast group, but we know that this medication has been tried also in lung cancer patients where the risk of pneumonitis is being higher there too. So this is something we need to watch. The treatment, the development of interstitial lung disease in this population might be staying a little bit more longer in duration with the slower response. So we need to be very vigilant when we use such a treatment because of this toxicity. There's actually some guideline has been already published for the management of this population. And they decide depending on the time of recovery, if it takes 28 days or more than 28 days, the dose of the medication could be adjusted based on that. So in conclusion, the Destiny 4 in this patient with the metastatic HER2 low after disease progression has been showing to double the progression-free survival and of almost increasing the overall survival by 40 to 50%. And all population has benefited regardless even of the use of the CD4/6 inhibitor. And this is there is no big safety apart from the interstitial lung disease that we need to look for once we start a patient on such treatment. So with this has established that this medication as a new standard of care for patients who progressed on 1 or 2 line of chemotherapy. So I think this is open a big door for these patients, especially triple negative patients where we have a limited options for them. So I think this will make a big difference. Is this the end of the line? I believe still the answer is no, because we have more and more studies are coming, more antibody drug conjugates, more immunotherapy also involved in this population. And I believe this will be changing the map of the treatment of a big section of a big group of patients that we were labeling them as HER2 negative before. So they will be now HER2 low, and they will receive an additional treatment that could work. So in summary, HER2 low breast cancer is a distinct disease. Yes, so this is something we need to identify. Our pathologists now, they are active in reporting that. HER2 low has a better response to ADC compared to the usual chemotherapy. So this is where we believe now we have 4 additional ADCs coming in the pipeline. So we'll see a difference whether they may be better than the trastuzumab deruxtecan. Only the clinical trial will show that. The trastuzumab deruxtecan is standard of care in patient with the HER2 low who progress on previous therapy, including hormonal therapy. Always look for interstitial lung disease, and specifically this could be very serious toxicity. So it's very important to be tracked in this patient. And the impact of this of HER2 low disease in the early breast cancer, this is under big study, and I believe it's going to be showing more data that this population need to be taken in consideration, and additional treatment might be added to their algorithm as in early breast cancer setting. So with that, I come to the end of my presentation. Thank you all. Back to you, Dr. Abdulaziz and Dr. Amin.
Thank you so much, Dr. Khayat, for this excellent review for HER2 low breast cancer. So we will leave the question to the end. The next speaker will be Dr. Amin Al-Umair. He's a consultant radiation oncology at King Faisal Specialist Hospital. Dr. Amin will speak about brain metastasis and radiation doses. Does the biology affect the radiation technique? It is an interesting question, so let us see.
Thank you very much. Thank you, Dr. Amin. Also, I'd like to thank the organizing and scientific committee, in particular, Dr. Nafisa and Dr. Mohammed Al-Garni, for this great opportunity. So I'll start off these topics. It make my life easy to talk about this presentation after the previous 2 co-speakers, Dr. Marwan and Dr. Shadi. I enjoyed very much their presentation. So I'll start off with this case, and this case actually was from the publication that I did when I reviewed the experience of Toronto. It's a lady, 42 years old, female, with triple negative breast carcinoma. This is in old days. We don't know about HER2 low. As you can see, this published in 2013, and patient was treated way before that. So basically, she had initially locally advanced triple negative breast carcinoma, treated with the standard trimodality treatment. And 1.5 years later, unfortunately, she developed this brain metastasis, very large, right cerebellar mass, complex mass, cystic, and you see some solid component, significant mass effect on the cerebellum, brainstem, and distortion of the fourth ventricle. So definitely, she needs surgery, which was done, craniotomy and gross total resection. I guess the question is, what will be the best treatment after complete resection? So here listed the treatment option. One of them is just maybe surgical resection alone, because if Dr. Salim Shehri will talk about oligometastasis. He's one of the experts in Saudi Arabia in oligometastatic disease. He had special clinic for that. So can we do same analogy here? Can we, when we do lung or liver metastasectomy, we don't need to do anything else. So the option B is patient was treated with gross total resection. So maybe you don't need to do anything else. I was planning to comment a little bit on systemic therapy, but this was already been discussed extensively by previous co-speakers. So we know that in triple negative, She does not have any systemic disease now, only single brain metastasis. Local therapy may be preferred, if any. So let's go through the other treatment option. And by the way, I think they uploaded the old presentation. I updated this presentation today, but it doesn't really matter. So surgical resection alone is one of the options. I guess the most important treatment option here is observation, since patient was completely treated, again, like oligometastasis in lung or liver. Other options give whole brain radiation therapy, like, for instance, this patient. A third option is not to treat the whole brain, just treat the high-risk area for local recurrence, which is the surgical cavity. So let me walk you through the different options. We have randomized trial address this question. So starting with a very well-known Patchel trial, where actually you can see if you do surgery alone, the chance of local recurrence in the surgical cavity area is high, almost 50-50, and also the distant relapse. Chance of having new brain metastasis down the road is high. This is a Patchel trial in the 90s. You can argue that it's old surgical technique, old CT brain versus MRI brain. So we are lucky to have, apart from this American trial, we have European trial, ERTC did the same thing. So they start with the local therapy, surgery or radiosurgery, then randomized patient observation versus whole brain radiation therapy. Observation associated with high chance of relapse, either locally or distantly. So almost 50-50%. So bottom line from at least 3 randomized trials is that you have high chance of local and distant brain relapse at 1 year. To minimize this, we need to give whole brain radiation therapy. And again, same randomized trial, just to show you how much there is decrease in local recurrence when you give whole brain radiation therapy. This is also was seen on the European trial as well. The ERTC also showed the same, but there is no difference in survival. So giving whole brain radiation therapy versus observation, there is no difference in survival. Also, the primary endpoint for the European trial was the functional independence defined by median time to progression of performance status, and there was not statistically significant between the two arms. So bottom line is that with whole brain radiation therapy, we reduce the local recurrence from 50 to 60% all the way to 10 to 30%. Also distant brain relapse from 50% to around 20%. But the problem of whole brain radiation therapy is the toxicity. So a lot of neurotoxicity when you treat the whole brain. So the other option is just treat the surgical cavity with radiosurgery. And again, we are comparing observation in this randomized controlled trial from Mayo Clinic, observation versus radiosurgery to the boost to the surgical cavity. Again, if you do observation, and this paper was published a few years ago, in new modern era, single institute, Mayo Clinic still, if you do gross total resection as evident post-operative MRI, there is no residual disease, you still have local recurrence almost 55%. So the local control is 45%. And this was decreased significantly with radiosurgery. So now we have 2 options. We are comparing observation. Observation is not adequate. You need to do something else. Whole brain was compared with observation. Radiosurgery was compared with observation. So how about comparing these 2 together? What will be the best treatment option? And this was done in this randomized controlled trial, multi-center, multinational, Dr. Paul Brown trial, where basically they include patients with limited brain metastasis, 1 to 3 brain metastases, had surgical resection, gross total resection. Then one arm is getting whole brain radiation therapy, the dose is listed here, and the other arm is giving radiosurgery. The primary endpoint is not a single, it's a co-primary endpoint, overall survival plus cognitive function assessment. So no different than overall survival. So what drives the decision is what give you the better cognitive function, least cognitive toxicity with stereotactic radiosurgery, as you can see in the green, compared with whole brain radiation therapy. And when you talk about cognitive toxicity from whole brain radiation therapy, they tested 6 different domains. The one significant was the early, late memory, processing speed, and executive function. So worse cognitive function with whole brain radiation therapy. So in the first case, I would recommend radiosurgery to the surgical cavity. So let's switch gear and talk about other lady with breast cancer, but this time had 4 brain metastases. The brain metastasis here does not need surgery because it's small size. This is 1 MITS. This is the second lesion. And this is lesion number 3 and 4. Doesn't even need steroid because patient does not have edema. In those cases, what will be the recommended treatment? So starting patient, so this is a summary of the case. And starting systemic treatment for brain metastasis is still not the treatment, not the best treatment option. I'll talk about biology in my last slide. Doesn't need surgical resection, so likely it needs radiation. So shall we go with whole brain radiation therapy or with radiosurgery alone? So I'll walk you through the problem of whole brain radiation therapy is the fact that it's more toxic. So more acute side effect, which is not a major deal because it's reversible. Alopecia might be concerned for breast cancer patients, but it's also reversible. Take few months for them to have their hair back. What's our concern is the fact that you can see this patient treated with whole brain radiation therapy prophylactically. You can see with time, there's evidence of radiation-induced leukoencephalopathy, which is basically more signal change around the ventricle, flare, signal change, the ventricle enlargement, and you can see there's significant atrophy of the cortex. If this is only radiographic, we call it radiation-induced leukoencephalopathy. But if the patient had a neurological symptom, then we call it radiation-induced. In the old days, we used to call it radiation-induced dementia. And the incidence is 5% on this trial, but in some trial, they reported even higher, like, up to 11 or 12% on the Memorial trial. So 11% of severe dementia, but they're giving high dose of whole brain radiation therapy. So other problem of, so now we know historically we used to call it radiation-induced dementia, but in the most recent publication, we start calling it more of radiation-induced cognitive impairment, and we test different domain for cognitive, as I just show you in a minute. There are at least 4 randomized trials address the question of omitting whole brain radiation therapy and just focusing on focal radiation or so-called radiosurgery. This is the first trial by Dr. Eric Chang from MD Anderson. He tested all the 6 domains of neurocognitive function. And the randomization is exactly the case I show you. Limited number of brain metastases, 1 to 3, randomized to radiosurgery alone. So we are omitting whole brain radiation therapy versus radiosurgery plus whole brain radiation therapy. And the primary endpoint is cognitive function. And the trial was stopped early because of, as you can see, there is high probability of significant decline in learning and memory function in patients with whole brain radiation therapy compared with radiosurgery alone. So this was stopped early, small number of patients, 58, but there is other confirmatory trials. So this is a multi-center trial led by Paul Brown. Again, exactly similar to the previous trial, limited number of brain metastases, radiosurgery alone versus whole brain plus radiosurgery. And you can see there's worsening cognitive function with radiosurgery plus whole brain radiation therapy in different domain. And there is no difference in survival. So adding whole brain radiation therapy does not improve survival. So other endpoint that was tested here is functional independence. So whole brain radiation therapy is not improving functional independence. In fact, it worsened the quality of life, which was one of the secondary endpoint of this trial. So do we have trial addressing the quality of life, comparing whole brain versus radiosurgery alone? And the answer is yes. I show you the URTC trial. They did a separate publication in the same cohort of patient analyzing 6 domain of the quality of life listed here. And they find that whole brain radiation therapy has worse quality of life overall score overall, but in particular in this 4 domain of quality of life: global health, physical functioning, cognitive, and fatigue. So whole brain is associated with worse quality of life. So let's summarize everything. What we learned from all the randomized trial that I show you is the fact that the good thing about whole brain radiation therapy, it's reduced local and distant brain relapse. But this was not translated into improvement in functional independence, overall survival, or CNS death. In fact, it has also negative impact in cognitive function, quality of life, and also had more acute and late toxicity. So we think about alternative to whole brain radiation therapy. As I told you, we like to treat patient focally with radiosurgery. So back to the case that I show you. Here, I told you I wouldn't recommend surgical resection or whole brain radiation therapy. Likely, this case, I'll treat with radiosurgery. And supporting my evidence is at least 4 randomized trials listed here. So we talk about Paul Brown multicentral trial. I talk about the URTC and Eric Chang MD Anderson trial, but also the Japanese Aoyama trial was the first randomized trial to omit whole brain radiation therapy. So for interest of time, I wouldn't talk about this. And back to the question, does the biology affect the radiation technique? I guess the question here, does the biology lead to omission of radiation therapy? And I think it's yes, not in breast cancer, but most of you know in lung cancer, if they have ALK rearrangement, we start with alectinib or lorlatinib. They have excellent CNS penetration, and you can hit 2 birds with 1 stone. So you can treat the systemic disease, extracranial metastasis, as well as brain metastasis with those drugs. Exactly similar analogy to EGFR mutant non-small cell lung cancer. We give osimertinib, Tagrisso, and we don't go with upfront local therapy unless in special situation. But in breast cancer, as my co-speaker mentioned, Dr. Shadi and Dr. Marwan, still tucatinib and others drugs they mentioned is promising, but still they prefer local therapy. So this is the first question. Does it lead to omission of radiation? Probably in the future, yes, if we have good drug for breast cancer, like ALK rearrangement, non-small cell lung cancer, like Tagrisso and EGFR mutant. The second question is, does the biology affect the radiation technique? I think what drives the radiation technique is different factors listed here. So patient factors is age, performance status, comorbidity, treatment factors, and tumor-related factor listed here include the molecular, but the main driven things is the discussion that we had with the patient in the clinic about toxicity of whole brain. My concern about whole brain radiation therapy is patient now is living long. So maybe breast cancer, especially if they have good molecular biology, they live long. You don't want to give them whole brain and affect their cognitive function. We start stretching the number of metastases treated with radiosurgery, and I guess my colleague, Dr. Salam, will present some cases. We treat up to 15, 20 legion brain metastases with focal radiosurgery, if it's doable, to avoid the cognitive impairment. The main factor that driven our treatment is the concern about toxicity or neurotoxicity of whole brain radiation therapy, but also we take all this factor into consideration. I guess this was my last slide, and thank you very much for your attention.
Thank you very much, Dr. Amin, for this interesting and very rich speech. It's my honor to present the next speaker, Dr. Salim Shehri, as a colleague and friend. Dr. Salim is a head of radiotherapy unit in King Abdulaziz Hospital, National Guard. He's also the director of the radiosurgery program over there. Dr. Salim obtained his degree in radiation oncology as well as fellowship from Canada. He's also obtained a master's degree in Saudi Arabia. Dr. Salim will give us talk about the oligometastasis, breast cancer, the current status, and treatment option from the perspective of radiation oncology. Dr. Salim, the podium for you.
Assalamu alaikum. Hello, everyone. I would like to thank the organizing committee, specifically Dr. Nafisa and Dr. Gerni for their efforts in updating the field of treatment in breast cancer. So I will talk about the oligometastases in breast cancer, the current status and treatment options, future direction. Oligometastases. If we go with this category or entity of disease, interestingly, it's the theory of this disease has established since 1894 by this pilot paper talking about the oligometastasis entity in breast cancer. So the main and the basis of oligometastasis was initiated from breast cancer. This is in 1894. if you see in this slide on the right side, the biology and the treatment for oligometastatic cancer, and this was published in 2015. And the entity was broadened, evolving, and being more specific. This is about the clinical significance of the state of oligometastasis disease. And this is back in 1894 when I just took a capture of that pilot paper. So what is the definition of oligometastatic disease to start with? We can broadly state that oligometastatic disease, when you have a limited metastases disease, generally talking, and what we are talking now about, and what is the base of evidence is less than 5 metastatic disease. And European way and the European definition by ESMO, they went with the maximum 5 metastatic disease as internationally, but they went more specific, talking about in less than 2 organs. So you have 5 metastatic disease, but within the 5 metastatic disease, you have less than 2 organs. So we still, till to date, we have, I wouldn't say, we don't have a consensus on defining the oligometastatic disease. Interestingly, last year, a paper was published in breast oligometastatic disease, talking about even more details about oligometastases. So if we go by the definition of oligometastatic disease of less than 5 metastatic sites, then we have a de novo breast cancer disease that they presented with oligometastatic disease. And we have a disease, a metachronous oligometastatic disease. So they present with a local primary, not metastasis, but with time they develop metastasis, and we can call it metachronous. And this paper, they specify the duration and breast oligometastatic disease, which usually in as a literature of oligometastatic disease, they still not specifying the duration when you call it as de novo, synchronous, or metachronous disease. They specify it here in breast cancer being 6 months. And very interestingly, they even adopted the induced oligometastatic disease. So the patient presented with polymetastatic disease, more than 5 metastatic sites. But when you started them on systemic chemotherapy, they eventually develop oligometastatic disease, which we call it induced oligometastases. And this is the first paper, up to my knowledge, defining these specifically in site-specific disease, breast cancer. What is the incidence of oligometastatic disease in breast cancer? It is 20% of these patients, according to this paper published in 2020. This is an interesting one about oligometastatic breast cancer disease, published in 2020 again. They talk about the prognosis of patients with oligometastatic disease, and they found that 20 or 50% of these patients, they have less than 5 metastases. The patient with synchronous who presented with oligo, they are 15%. Metachronous, which they will develop oligometastatic disease, 85%. 75 of them are luminal disease of breast cancer. Only 16.7% HER2 positive. 7% of them only triple negative disease. This 5 years overall survival was 78%. This is our local paper. We just we published it in October 2020, and we went over the prevalence of oligometastasis disease. 17 of them, they were breast primary. We did publish this year about the outcome even, and hopefully it will be accepted soon. This is a long-term survival about oligometastatic disease, breast cancer disease. 1998. So this paper by Coleman, he identified the patient with oligometastatic disease specified to bone and bone-only disease. And he noticed that these patients, they live longer with a median survival over 72 months. And he did specify that these patients, they do better and live longer than the patient who have visceral metastases, 1998. This is another paper who reported the outcome of oligometastatic disease in 2021, just 2 years ago. And they found that's an observational cohort study, and they found over 3,000 patients that the 10-year survival can be reached up to 14 years if the patient had 3 oligometastatic disease. So now they are trying to define who will live longer. So if you have a patient with metastases less than 3 sites or 3 sites, you would expect them to live longer. This evolving evidence makes the field shifted toward curative intent, even if we call them palliative treatment. In SBRT or SABR, we do have a SABR with curative intent, palliative with curative intent. Also, the basis of SABR when it's established was for palliative treatment. And now we have a terminology just evolving 2 years talking about and putting it under the category of metastatic directed radiotherapy, MDRT. This is one of the landmark trials of oligometastatic disease in general, SABR COMET trial. And it is the first prospective randomized phase 2 trial, which I remember in 2016, we were recruiting for these patients. They have any palliative disease, metastatic disease, but you have the primary control, and then you just randomize them either to go with SBRT or no SBRT, and then you compare the quality of life and survival. All of them, the criteria of them, if we have less than 5 metachronous metastases, and then we achieved a very marvelous local control reaching more than 70%. SBRT proved to be safe. Updated outcome of this trial showed that the primaries, 18% of them were breast, and we reached 5 years overall survival of 42% with the arm receiving SABR in comparison with the patient who didn't, 17.7%. So SABR, oligometastatic disease of all solid tumor. Now we will talk about oligometastatic breast cancer, site-specific SABR. This paper was by Trovo in 2017. They treated 54 patients with SBRT, and you can see the bone lesions, 60, lymph nodes, lung, and liver. Interestingly, if you just see on this population, they exclude CNS disease or CNS involvements. They reach 2 years progression-free survival, 53%, 2 years local control, 97%, 2 years overall survival, 95%. So if you dig in this trial, 80% of these patients having ER-positive disease, 85 of them will have 1 to 2 metastases. Number of metastatic lesions was not associated with progression-free survival, and that's what we even noticed in our local practice and published paper. They didn't find any difference between induced versus de novo oligometastatic disease. There was no difference between synchronous versus metachronous oligometastatic disease. Although this is a very interesting finding when you compare it with lung primary. Lung primary, for example, you will find a significant difference between patients with synchronous or metachronous disease. And based on them, we can decide on clinical decisions. This is another paper of site-specific oligometastatic breast cancer disease by David et al., published in 2019. They treated 15 patients, median age of 63, HER2 hormonal receptor positive in 86%. They reached 2 years progression-free survival, 100%. That means every lesion they treated, they kept it under control for 2 years, but the progression-free survival was 67%. So what we are trying now to say now that oligometastatic breast cancer disease is recognized and evolving. And now we are talking about recruiting trial on oligometastatic breast cancer disease, site-specific, apart from several recruiting trials talking about oligometastatic solid tumors. And interesting of them now, if you see the Avatar trial, they're talking about oligometastatic disease in ER positive, but HER2 negative disease, as well as in CLEAR study as well, talking about ER positive,
HER2-negative disease, where they're trying to prove that there are a specific population and target population of oligometastatic breast cancer. They will do better and they will have better outcome. So what is the future direction of oligometastatic breast cancer disease? More specific towards subgrouping breast cancer disease. SABR and immunotherapy now. Do they have the better outcome as lung? And we will see. And there's a trial ongoing with the SABR plus anti-BD for 6 months. There is oligometastatic disease versus polymetastatic disease breast cancer. All we know about Oncotype DX testing for early breast cancer and the benefit. Now there's a similar genomic testing, hopefully evolving for oligometastatic disease, and then who will benefit from SABR and local treatment or metastatic directed therapy. Avatar trial, for example, now is maximizing the benefit of systemic therapy in favorable oligometastatic disease. They use them for the patient with metastatic disease. They are an aromatase inhibitor. And then they try to maximize the treatments between SBRT and systemic treatments. So what is stereotactic ablative body radiotherapy? We try to deliver a highly ablative radiotherapy dose precisely to the lesion itself, either moving target or fixed targets, and try to save the normal structure around it. This one is about a patient we are adopting, and we can just see how we can deliver a precise treatment to the lung lesion and preserving the normal tissue. And practically cases in our daily life. This is a patient in our institution. We all know our colleague as medical oncologist and myself. This is a 32 years old lady presented in October 2018. With synchronous metastatic disease. And initially, she presented with spine metastases, 3 consecutive vertebrae, as Dr. Amin Al-Amer know how far we can cross the borders and treating how many spine lesions consecutively. So this patient, we treated her with stereotactic ablative radiotherapy on 3 consecutive lesions as she presented. And she had a complete response to SABR. And then we treated the primary breast cancer with local radiotherapy in conjunction with systemic chemotherapy. Later on, she presented with, as you see here, the spine lesion in T5, and we treated again with this PRT. Our colleague in medical oncology, they shifted her from systemic chemo to immunotherapy, and she's still with us till January 2020. And later on, she developed in February 2021 a lung lesion, which we treated with SBRT using LINAC-based SBRT. And she responded very well. Later on, she developed a bone lesions on the right, as you see, pelvic bone, which we treated with radiotherapy. This is the actual treatment of her lung primary disease, treated with SABR. Patient is defined as no evidence of disease, NAD, by April 2021. Later on, and unfortunately, she died in 2023, just last month. So she lived from 2018 till 2023, and you can see she didn't have any CNS disease involvement, and this is why might be a factor why she lived longer, beside the systemic treatment and SBRT. This is another patient, 50 years old, who failed on the brain, and we know that there are a category of patients who relapse on brain and fail on brain. We treated these lesions with SABR in 2018, and later on she developed a spine metastasis, which we treated with SABR and C3 lesions and T9 lesions, and she lived a very decent quality of life. And I remember her in the clinic. She was a single, independent woman. And all what she was concerning about is to be independent and fully functioning. ongoing treatment with a 35 years old female patients who had the bone and brain HER2 positive disease, as my colleague presented the nice attracting talks, Dr. Marwan, Dr. Shadi, about the HER2 positive disease. We know these patients, they do fail in the brain, and sometimes that's been a challenging treatment for brain relapse. This patient presented in November 2021. She was treated in an institution in the region with 2 lesions with CyberKnife treatment, right cerebellum and left parietal lesion. Later on, she failed with 6 lesions and she was referred to our local hospital institution. So we treated her with, again, with stereotactic radiosurgery for 6 brain metastatic lesions. After the 2 lesions she received, and she completed the 6 brain lesions in March 2022, last year. Later on, she failed again with the 3 more lesions. So we elected to proceed with whole brain radiotherapy. We tried to boost the whole brain radiotherapy using VMAT technique, avoiding the hippocampus. Later on, she developed another 7 lesions on the brain, which we treated with stereotactic radiosurgery again in January 2023. The last MRI she had in 5th of March 2023, she had a complete response. She's a 35, fully functioning, a mother of 3 kids. Take-home message. Oligometastatic breast cancer disease is a field that it's evolving. We need to better identify these target population who will benefit from systemic treatment and metastatic-directed treatment, metastatic-directed radiotherapy. We should clarify visceral versus non-visceral disease. I do believe personally that patients who had visceral metastasis, they do, and their outcome is inferior to non-visceral. Bone metastatic disease and limited to skeleton, they should have the maximum effort of treatment. CNS involvement is a dismal sign, and they do have a significant morbidity and inferior outcome in comparison to non-CNS involvement. These patients should have a multidisciplinary team decision and individual case management. Thank you so much.
Shukran jazilan, Dr. Salim. Very interesting speech. I would like to give the mic to my colleague, Dr. Amin, to lead the discussion.
Yes, thank you, Dr. Abdulaziz. Can I ask Dr. Amin and Dr. Salim to come here to the stage, and Dr. Shadi and Dr. Marwan there?
Yes, Dr. Amin, with you.
Yes, so we will open the floor for the discussion if there is any question. So maybe I will start. It's not working. So maybe I will start, Dr. Marwan, with regard to this multiple excellent therapies for the HER2 positive metastatic disease, especially in the brain. So do you think this medication now can substitute, or at least, or can we say delay, or it is like complementary to the local therapy?
I think the way we should look at it is what's the problem with our local therapy or like a direct treatment to the brain. I think we have a problem with the whole brain radiation because of the side effects and toxicity in terms of cognitive dysfunction. Maybe in the future, if we want to know if we can substitute that and delete the option of whole brain radiation with using a systemic therapy, that will be a nice idea to have. However, so far, we don't know if this is the right track to do, or whether the studies that were designed, they are not designed to look at, to answer this question. So at the moment, I don't think we can replace local therapy. I still believe that local therapy is a must, and unless there is a contraindication, a clear contraindication. So that will be my answer to this.
Okay, thank you.
I have concern, Dr. Amin.
Yes.
Dr.
Yes, go ahead.
Shadi and Dr. Marwan emphasized the need for rebiopsy, especially when you consider transformation. This is mainly possible when we talk about visceral, like lung or bone. But when you have patient who had relapse again in the brain, I think a lot of neurosurgeons back off and they don't want to intervene after the second relapse. So would you consider rebiopsying is impossible or chase it, or there is another option, go just with the diagram as the previous tissue?
So that was a recommendation by the ASCO, but to tell you the truth, it depends on the case. In some cases, you would think that this patient might need a biopsy, possible transformation, which is not like the thing that I care about the most in those kind of patients, especially in HER2 positive disease. But maybe the time intervals between the disease initial diagnosis and the presence of the brain metastasis, maybe that will guide you toward like doing a biopsy. But if it's within the same context, or the same time range, I wouldn't like bother about doing a biopsy. In terms of systemic therapy and having a transformation, we know that most of our systemic therapy, at least in the past, they did not cross the blood-brain barrier. So I'm not suspecting much of transformation. However, that might be considered in the future when we have more than one line or more than one treatment option that can affect the brain. Maybe we will consider that in the future.
Yeah, just Dr. Abdulaziz, I think what you have been mentioning is quite important. Like, you know, for local therapy, I don't think it make a big difference for the brain. So that's why I don't believe, like, you know, the neurosurgeon would be, you know, for quite interest, like, you know, to know, especially like, you know, as Dr. Marwan has pointed, like, you know, in the beginning of his discussion, that HER2 overexpression disease, usually patient would have a brain only metastasis, like, you know, failure rather than the systemic failure. So this was part of his, like, you know, discussion that these patient, like, you know, it doesn't mean to have an isolated brain metastasis that there's a systemic failure. So that's why, like, you know, biopsying the, like, you know, doing a rebiopsy for the brain might be not the most interesting point that we discuss with a neurosurgeon all the time. In the systemic metastasis, like, you know, as Dr. Marwan said, like, you know, the HER2, like, you know, conversion is not, like, you know, big, and we're talking about only about, like, you know, 6% or 7%. In the HER2 negative disease, this is, like, you know, because of the tumorigenesis happening. So this is, like, you know, where we look more in these patients rather than the HER2 disease. But in general, like, you know, if we have, like, you know, a good gap of time between the initial and the metastasis, we would rather, like, you know, do the biopsy.
Okay, thank you. I have a question from my colleagues, Dr. Amin and Dr. Salim. Actually, this is a two-part question, if they allow me. Within seeing more and more young patient, we talk about like now 20 years old, 25 years old, who had breast cancer present to the clinic with the brain metastasis. You knowing that, according to the personalized medicine, they have poor outcome, whatever we do with them. Would you consider going with stereotactic radiotherapy for these single lesions or not? This is in the part one. Part two, for Dr. Salim mainly, in the body metastasis, we can go with the PET CT scan between every treatment to decide to go SBRT or not. But for the brain, would you consider functional MRI before deciding for SBRT, or was just rely on the regular MRI?
A great question, Abdulaziz. Thanks for asking. Sorry, can you repeat the first part of the question for the young lady with brain?
When you deal with young patient, lady who's younger than 40 years old with brain metastasis, single or two, or one lesion, let's say, and you know that she has poor outcome compared to the other breast cancer patient, would you consider giving SBRT or stereotactic radiotherapy, or just try to be nice and try to give her more time interval between the next relapse with the whole brain radiotherapy?
Very good question. Excellent question. So typically, the simple thing here is to treat her with radiosurgery. Especially that I know the prognosis is not great. So say she had triple negative, that's why, although she's young, but biology is not good. So I would recommend radiosurgery alone for the reason that I mentioned in my presentation. This is my bias. Easy treatment. Most of the time, the brain metastasis for breast cancer is small size. She had only 2 lesions. So you can get away with very minimum or no toxicity. So I would recommend radiosurgery. So for the second part, Dr. Salim will be commenting on this.
Thank you, Dr. Abdulaziz. Excellent question. PET-CT is crucial for going with this SBRT for body saver. I'm accelerating even from one of the lung trial. They found even survival benefit doing PET versus not doing PET-CT to define oligometastatic disease.
What about the brain? When you have brain lesion, single brain lesion, do you consider functional MRIs or rely on the regular MRI?
We actually we don't use it in practice.
Okay.
So saber knife or saber knife MRI or brain MRI is enough. You just do it frequently when you do stereotactic surgery every 2 months. When you go with whole brain radiotherapy, you just extend the interval. And Dr. Amin will have more extensive answer for this.
Yeah, I agree with Salim, totally agree. But also your question is good, Abdulaziz. We use functional MRI maybe in the follow-up to differentiate between radiation necrosis versus true progression. This is the time where maybe functional has a, but in the future we might use functional more. But now I agree with Dr. Salim. For body PET scan, which is functional imaging, it's very crucial. And the brain, we don't use any functional imaging to decide or at the time of diagnosis or before the treatment. But you are absolutely right. Maybe we use it if we have doubt whether this is radiation necrosis or tumor progression. And thanks for your great question, Abdulaziz.
Thank you. I have one question, Dr. Shadi, for the HER2 low. How and hormonal positive on the same time? How you approach the management in this case? You will give the hormonal first, and then after exhausted, then you will go for the TDXD or.
So thank you, Dr. Amin, for this. So we know from the Destiny 04 that the patient who was included in that patient who already progressed on systemic treatment. So either they progressed on hormonal treatment or they progressed 1 to 2 lines, at least one of them is hormonal treatment. So that's why these patients already would have been exhausting the hormonal line. We know that there's other studies now is going on, with adding the fulvestrant plus the the trastuzumab deruxtecan, and it's still is still binding. So I think we're going to have a lot of advances in this line, but at this time for the practice, we start with the hormonal treatment first line at least, and then in the second line we might consider the deruxtecan as a HER2 low disease.
Okay, thank you. Any more questions? So if there is no any more questions, so we will close this session. Thank you for all the speakers.
Thank you, everyone.
Thank you so much. So we'll move to the next session. So we will start the last session in this meeting. So it will be a tumor board discussing We have three interested cases. So the first case will be from the surgery side. It will be presented by Dr. Mi'ad Al-Rumayhi. Dr. Mi'ad is a general surgery Saudi board certified, who is now working as assistant consultant in breast surgery unit at King Abdulaziz Medical City, National Guard Hospital. So Dr. Mi'ad will present surgery and immunotherapy-induced toxicity. So please, Dr. Mi'ad.
This is what? Okay. Okay, good afternoon. In coming 15 minutes, I'm going to present an unusual case of a breast cancer, aiming to find out how aggressive can we be. Firstly, let me walk you through the patient's journey. First encounter with this patient, it was on January 2021. She was a 54-year-old female with multiple comorbidities, ECOG1. She's postmenopausal with average risk of a breast cancer. She was presented with 1-year history of right axillary mass. On a clinical examination, it shows that there is a right axillary mass, 10 centimeters with thin skin above the mass and pending ulceration associated with the right axillary, with the right breast, skin thickening and edema, occupying the lower half of the breast, which is most likely due to the obstructive mass effect, more than it's a pathology for the breast. So patients underwent for radiological local assessment. Mammogram revealed the breast parenchyma are clear, and there is just only a right axillary, large right axillary mass with skin thickening. Biopsy taking, and it is infiltrating ductal carcinoma with ER weakly positive 20%, PR HER2 it's negative with Ki67 of 50%. So moving to the systemic staging, abdomen and pelvis was negative. Chest, it was indeterminate lung nodule for follow-up, and bone scan was negative. So in the multidisciplinary tumor board, this patient treated as will be treated as a triple negative breast cancer with radiological and clinical staging of TX into M0. Then after neoadjuvants to be followed by local control modified radical mastectomy. Unfortunately, patients disappear, declined treatment and disappear. 7 months later, she, which was on September 2021, she back in our institution. Back there in international institution, she was treated with Taxotere. Unfortunately, she's only received 1 cycle as her stay complicated by badly infected diabetic ulcer, and the treatment was held. So for clinical assessment at that time, the mass, it's increased in size. It has become 14 centimeters with ulcerative skin, and there is exophytic mass. So local control, also again, it's revealed there is increase in the mass. Systemic staging, it was negative for the abdomen and pelvis and for any bone metastasis. And regarding the chest CT, the lung nodules remain stable, and there is encasement of right axillary vein by the tumor. So started again in a neoadjuvant chemotherapy, completed her 4 cycles of AC, completed on November 2021, and received 1 hemostatic dose of radiation to control the axillary ulcer bleeding, then shifted to Taxol weekly.
On February 2022, unfortunately, after the 7th dose of the Taxol patients, she developed bad nasal vestibulitis, which is required long hospitalization, multiple incision anti-drainage, and at that time, systemic treatment was held. During these events, actually, the consultation have been made to breast oncology surgery for possible local control by radiation. Just to be on the same page, patients clinically show these pictures, which is there is significant decrease in the mass size, but barely by palpation, you can feel there is deep-seated lymph node on the apical, and actually the skin that covering the mass, it's in really bad quality, which is cannot be expressed by this imaging. To elaborate more on the surgical anatomy, as it appears in this CT chest, the red arrow it's indicate for the artery, and the yellow and the blue it's indicated for the vein. Actually, it shows there is the vein, as we know before, it is already invaded by the tumor, and the artery, there is no clear plane between the mass and between the artery, and there is a questionable involvement for the brachial plexus. So cards on table, the patients she was an ECOG4 patient. She is very fragile, chair-bound with extensive neurovascular involvement, axillary vein already encased, and the questionable artery with an plus brachial plexus. And with the extensive surgery in form of debulking, it's difficult to achieve R0, R1 resection. And extensive tissue loss, which is patients will require coverage, either skin grafting or myocutaneous flap, which mean more extensive surgery. And this is all it's occupying high morbidity. So at that time, there is no rule for surgery. The surgery team sign patients as she is inoperable at that stage. So patient's case, again, brought it to the multidisciplinary tumor board, and the board agreed to resume the medical treatment and to add the immunotherapy pembro. Unfortunately, on August 2022, after the third dose of immunotherapy, patient had a really bad skin reaction, skin rash, which is diagnosed later on as a bullous drug eruption secondary to immunotherapy. And at that time, the treatment again was held. So what is next for this patient? In summary, she is a 56-year-old lady, ECOG4, with an inoperable axillary mass, good response to systemic therapy despite the interruptions, and there is no change in M status. So again, what is the next? It's worth to mention any rule of surgery for the patients that already in August, the question for surgery, the question raising regarding any role for surgery, and again, same limitation was listed. And the second question is any role for radiation. And the third one is any role for hormonal therapy. And it's worth to mention that patient started on letrozole by oncologist starting from January 2023. So what is the next? Please, now floor, it's open for discussion.
Thank you, Dr. So we have the discussant. We have Dr. Mariam Lostberg. She's the Chief of Breast Medical Oncology Division, Yale Cancer Center from New Haven, USA. We have also Dr. Mera Golshan. He's a professor of surgery, Department of Surgery, Yale School of Medicine. And also we have Dr. Athar Sayed. He's a consultant medical oncology at King Faisal Specialist Hospital. So we will open the floor for discussion for this interested case. So maybe I will start with the surgeon, if Dr. Mera, if any input from your side.
Yeah. Good afternoon. Thank you so much for the kind invitation, and inshallah everyone is there is healthy and well. We wish we were there in person with you, and appreciate the invitation, and thank you for this thorough presentation of this case of a really advanced disease. And I'm actually, for all the bumps and hiccups she's had a really nice response. In terms of surgery, yes, it is there are risks associated with anesthesia and things along those lines. In the setting of, this advanced disease with this form of response, and if the feeling is that the risk of anesthesia and surgery is too high, we certainly could consider radiation in this patient. And I've had some patients that have had a fair amount of success. I do think that even if you can get to surgery, that it would not be a definitive resection, and certainly the encasement of the vasculature is something that I would not want to pursue with our vascular colleagues in terms of resection and reconstruction. Doing a kind of a salvage, or what we often call toilet or palliative mastectomy of just the breast and the low axilla, and being able to maybe close it without a major flap. Sometimes we could do that either with skin graft, or some of our reconstructive surgeons do this reverse abdominoplasty, or basically bring some of the lower abdominal skin and fat and tissue up by undermining and primarily closing it. That may be an option to consider. But if it's felt by both the surgical and anesthesia team that it is not safe to operate, and right now there are no local wound issues that are in play, which when I saw that second slide after she had refused or was lost to follow up, that I was very impressed and worried about. But she's had a really nice response to the breast, and I would then talk to our radiation oncology colleagues. I'd be curious to see what this other surgical folks on the panel's thoughts are, and certainly our medical oncology colleagues as well.
Okay, thank you. Interesting, she had a very huge disease with this biology, and she's not metastatic. It looks like more towards triple negative, although she had, I think, AR positive 20%. So, Dr. Mariam, can you comment on that?
Yes, thank you everyone for having me. Good day. Yeah, she's had an incredible response, but as we have seen, her course has been complicated by her medical comorbidities, as well as serious adverse reactions to immunotherapy, as well as other agents. Yes, with her low estrogen receptor positivity, I think the addition of letrozole in the setting of just how limited her comorbid status is right now, I think it's not unreasonable, although I would expect, given that low estrogen receptor positivity, that her response to this therapy would not be tremendous. We could argue for the addition of any of the 3 CDK4/6 inhibitors as well in this setting. Unfortunately, I think the biology of her disease and how she has responded does make me see her more as behaving like more of a triple negative like type tumor. So if she did not have all these comorbid status issues, I think this is the type of patient that we would consider antibody drug conjugate therapy. Given her grade 4 bullous skin reaction, we cannot re-challenge with immunotherapy, but she is, if she was able to tolerate more therapy, I think a more beneficial treatment for her would be an anti-TROP antibody drug conjugate, such as sacituzumab. And as we saw, she has that HER2 low signal at 1+. So given that she's unresectable, we can follow the algorithm as we would for metastatic disease, and she would be a candidate for anti-HER2 ADC therapy as well, based on DESTINY-04. However, in this setting, I agree with the presentation that given that she's wheelchair bound, has had multiple complications, I think the safest thing for her would be endocrine therapy at this point, plus or minus a CDK4/6 inhibitor, and continued discussion of goals of care and kind of how she would like to proceed.
Okay, thank you. Thank you so much, Dr. Azhar. Any comment?
My comment will be as follows. Triple negative in the trial of immunotherapy was defined as ER, PR almost zero. And although we know up to 10% are treated as zero, 20% is a ER positive, although weakly positive. So this is one. So all the trials of CDK included metastatic as well as inoperable breast cancer. So definitely I will agree with my colleague that CDK4/6 here is a reasonable option to be added with careful monitoring. The other thing I would do, because of frequent interruption of her therapy, is to do a restaging. This lady, I think, qualified. The Taxol was interrupted, the docetaxel was interrupted, then she had the Pembro, which was interrupted. And I hope, I would recommend a restaging study for this lady to really see what has this interruption may have impacted on her. And I think if the CDK fails, then we should consider the antibody drug conjugates. Although PS4 is not qualifying for ADC in most of the guidelines, but we always have clinical cases that are not falling into the guidelines. And hopefully this performance status will improve after her extensive bullous lesion would recover from the immunotherapy toxicity. These are my comments.
Doctor?
Thank you all for your input about this case. Actually, she just underwent the stage workup and was negative. Nothing was outside. The only thing that left is a small, very small, and didn't reason but causing very big effect in case of middle toxicity. So this is the reason that pushed me to give letrozole. Regarding the immunogenicity toxicity, she had complete response to the chemical. She's completely back to normal now. But the performance is really not good. We consulted the patient over the while she's in. Unfortunately, they said because the performance status is not good, they cannot go and get radiation therapy. So I was like desperate. I don't know what to get. Back to this day though. You are positive, I found the result, and let's see.
Did you repeat the receptors on the other tissues?
When they do the pathology, I think it was less than 20%, it was 10, but I think this is the only time that we did not repeat the pathology, I think, here. Because she was responding, continuing to respond nicely. I know this patient very well. I picked up this problem. Unfortunately, we have functional status deterioration and very related. What functional status is called all the time, we can do these things in them. Even if the case is further, we can give them the at least this is she remains like the past after a while, but not at the time.
So here the treatment is palliative by the end. The surgery will not be an option for her. So it will be like a palliative treatment.
She's not metastatic. We don't know how she responds after the after some time after the letrozole. If she responded beautifully and the function status improved, I think because there is no focus of mass whatsoever, a lot of groups are stable. If we push for that, hope that she can metastatic, and we say now therapy is out of option. Out of our options, the most people are very fine, and then they are still within the time of diagnosis, the same time. The problem is after they're still the not people so they don't do like so there is no evidence of the between what is actually human location and performance really not good. I need to mention that we have in contact with So this is what made the scenario actually work.
I heard the word delirium. Is that correct? Because delirium is a medical problem. It's not a psychiatric issue. So this could indicate either encephalopathy from the immunotherapy or maybe leptomeningeal disease, etc.
This part, or within the hospital, she has acute confusion, and we refer her to but the state was always part of it. Yeah, she was one the little one, she was inpatient, bad with the eye. And now this is the cause of we can't admission. She was every now and then go home to the house. Every other month she's in the hospital because of the eye. So it can lead to during that period, and I think that was the cause of her acute pain of having that. Otherwise, she was fully awake and oriented. Even in the group, which is last
I'm sorry, I'm having difficulty hearing the discussion. Could you repeat the last question?
Mentally, she's okay, she's fine, she's having psychiatric depression, and she's on treatment since a long time. But when she had been seen by the surgical team at that time, she was having confusion because she was suffering from an acute attack of UTI.
I think this was the only reason for the acute change in mental status. Otherwise, she's fine. It's a very interesting case. My question is, suppose a scenario if she was in a good performance status. My question is, we have a data that early stage when they have a relapse with the receptor changes 10 to 15%. What if it's the metastatic? Are you going to do the repeated biopsies to assess the receptor or biology or anything? Anyone has any comments or any data about in metastatic setting with the repeating the biopsy? Because this patient might have a different biology. I don't know. I don't know the data about. Do you know other about this in metastatic setting while patients are getting therapy and then changing the receptors?
Yeah, so I think receptor switching is absolutely something to keep in mind. We know, for example, that the HER2 signal is actually quite unstable and changes from biopsy to biopsy. So for sure, for the HER2 status, we do see HER2 upregulation and previously HER2 low or HER2 negative tumors in about 10 to 20% of the situations, depending on the study that you're looking at. And there'll be additional updates on this in San Antonio Breast Conference coming up in December. So I think the question you're asking is a good one, which is that if it's been a long time since her prior, this is essentially the way I would treat this patient as an unresectable, locally advanced situation. I would follow what I would do in a typical metastatic setting, which is that if it's been a while since her tissue has been examined, I think it is an opportunity to recheck receptors and even consider next generation sequencing for additional targets. I also didn't hear if the patient had germline testing. I think it's a consideration because if she does have a germline alteration, that brings up another series of very well tolerated treatments such as PARP inhibitors. So just something to keep in mind in terms of opening up her options.
No, she refused.
Actually, we patients have been counseling regarding genetic testing, but patients decline to go for any genetic testing.
Sure. We also have data for the limited data on the efficacy of PARP inhibitors with those with somatic alterations. So another benefit of a repeat tissue examination could be that you could send it for sequencing and essentially look for the somatic DNA repair alterations. And that would be another way that, it may open up additional targeted therapies that she could have and could be more tolerated for her with her limited performance status. So I think a repeat biopsy is a good idea.
Okay, thank you so much. Thank you. Thank you for interesting in them. So we'll move to the next case. It will be by Dr. Ala Ali. She's the staff physician at King Abdulaziz Hospital, King Abdulaziz Medical City, National Guard. She will present a case about stage 4 breast cancer local therapy. So please, Dr. Ala.
Assalamu alaikum. Good afternoon. First of all, I would like to thank Dr. Nafisa and the organizing committee for giving me the opportunity to present this case here. So I have here a 43 years old female where she initially presented to us at her mid-30s with the left breast mass with on and off pain. There was no nipple discharge or skin changes. She has bronchial asthma and dyslipidemia, and she was with a strong family history. Her mother was with uterine cancer, and her brother diagnosed with colon cancer at his 50s. She is para-4 + 2, and she was not using any hormonal treatment or hormonal induction. On examination, she was with perfect performance status. She has 2 centimeter left breast mass at 3 o'clock, and the mass was mobile and with ill-defined lateral aspect. The right breast was normal, and also as well as the axillary examination was normal. So at her breast image, we found there was like 2.1 by 2.4 centimeter at 3 o'clock. It was like irregular, ill-defined, and axillary examination were negative. This is her breast ultrasound. The biopsy result came positive for infiltrating ductal carcinoma, grade 2, ER strongly positive, and PR weakly positive, +1, HER2 +1, and Ki67 40 to 50%. Her staging workup was negative for distant metastasis, apart from left internal mammary lymph node, 1.1 by 1.2 centimeter. So the case was discussed in the tumor board, and the plan to give her neoadjuvant chemotherapy was seen in our oncology clinic in April 2017. At that time, her baseline tumor marker was normal, and echo was normal. We started her on LHRH, and we sent for BRCA test. In April 2017, she was commenced on neoadjuvant chemotherapy and completed in September 2017. And in October 2017, she had the needle localization left breast lumpectomy and axillary lymph node dissection. And this is her pathology after the surgery. It showed a residual tumor, 0.5 centimeter, and the staging showed the T1A and 0. In November 2017, she was started on tamoxifen, waiting to start her on adjuvant radiotherapy, and she completed it by November 2018. In March 2018, started in Xeloda, completed 6 cycles. And then in February 2019, the genetic test came positive for BRCA2. So what will be the next? We have here a young lady with early stage breast cancer. She completed her adjuvant treatment and currently on hormonal tamoxifen plus LHRH. We sent her to the genetic clinic, and we counseled her regarding the prophylactic bilateral mastectomy and bilateral oophorectomy plus hysterectomy. Initially, she was refusing that, but at the end, she agreed. Of course, she was under follow-up of gynecological team for the because she was on hormonal treatment on tamoxifen, and she had ultrasound in March 2019, which showed endometrial thickness with irregular wall, but both ovaries were normal, and the Pap smear came negative. She had another mammogram in March 2019 and was normal. And also her restaging workup in April 2019 was normal with no distant metastasis. In July 2019, she had the prophylactic hysterectomy and bilateral salvage oophorectomy, awaiting for her bilateral breast mastectomy. And actually, her pathology came positive. The right ovary was positive for metastatic carcinoma, consistent with her breast primary. So what about the breast surgery now? Now the patient labeled as stage 4 breast cancer by the ovarian pathology. So what will be the next? We are going to do for her the prophylactic mastectomy, or what do you think? So I think most of us will do like that. So she was seen in July 2019 in the breast surgery clinic and as patient labeled as metastatic breast cancer. So they mentioned that no rule for prophylactic bilateral mastectomy. She was continued her follow-up in our oncology clinic, and she had PET scan in August 2019, which showed focal uptake in her right breast. For further assessment, she had MRI breast and showed the benign changes only. So what will be the next? Do we need, because now she is stage 4 breast cancer, do we need to start her chemotherapy, to continue the same hormonal treatment, or to change her hormonal treatment, or to start other systemic treatment? What do you think? Can we make it interactive?
The only lesion in the ovary are removed. And removed.
Yeah,
And removed. So there is no disease now.
Yes.
There is no disease. Okay. So, Dr. Azhar.
You know, first of all, this lady, you could argue about her hormonal therapy. AI plus ovarian suppression versus the tamoxifen. And since she's young, she had N2 disease, internal memory, and having neoadjuvant chemotherapy, I would consider AI plus Zoladex or ovarian suppression as hormonal therapy. The ovarian finding, which showed metastatic, was an incidental finding with a PET scan showing no other disease. So I would say she was lucky where you have, I don't know if the tumor was invading the capsule or it was very limited, but what was the size? But that's good for her. I think that is potentially curative surgery. So I would definitely go for aggressive primary, aggressively removing the primary or if there is any source, like positive PET scan, I will do definitely a lot of workup, including MRI, ultrasound, biopsy, to prove there is a residual disease and go after it with a curative intention.
There is no primary. They are speaking about the prophylactic mastectomy.
No. But we have a PET scan which shows there is an uptake in the primary site, in the breast. So that needs to be sorted out. We have to do further imaging, further workup to see there is a disease or not in the primary site. Because the management will be slightly different. You know.
Actually,
if she did not.
No, PET scan. If you see, there is look, there was a breast uptake as presented. You know. No, in the middle. Maybe
actually, we did for her MRI after the PET scan. We did for her MRI breast and showed only benign finding.
So it was benign.
Benign, yes.
Yeah, I would still go for a curative intention in this lady and go.
Prophylactic mastectomy.
The prophylactic is when you have, by definition, when you have no evidence of disease elsewhere initially. But this is a resected stage 4 disease with no evidence of disease. So yes, I would, extrapolate and treat her similarly for a, if you quote unquote prophylactic mastectomy. Yes.
Yes, Dr. Mariam, please, if you can.
Sure. So I don't want Dr. Goswami to comment on the surgical question first, or I can go.
And sorry, because this was such a long story, the patient has a hereditary mutation to breast cancer and ovarian cancer, or no? I missed that.
Yes, yes.
So, really interesting kind of story and situation. I think the folks many of my colleagues that I've met in the Kingdom of Saudi Arabia know my thoughts on the role of local regional therapy in the stage 4 setting. This is a little bit more nuanced in terms of the timing of an identification of metastatic disease. Certainly there is discussion and some support for treatment of oligometastatic disease. And the only randomized data that we have that's been presented yet not published yet is from NRG-BR002, which had a population of patients that were treated with standard of care, and then there was role of either stereotactic body radiation or surgical resection of the newly identified oligometastatic disease. And in that case, most of those patients were actually metachronous and not synchronous, so somewhat like this patient. And there was no difference in survival or progression-free survival or overall survival. With that being said, this is a little bit more not typical presentation, and certainly, one option is to consider continuing with, I would say, we'd call it standard screening for the hereditary group and alternating MRI and mammogram every 6 months with tomosynthesis. But if she's otherwise healthy, I think, this would be a case where you could consider bilateral mastectomies with or without immediate reconstruction. I'm a little torn about that, but it's not wrong to do, except that this excitement that, she is treated and it's oligometastatic, and that the outcome of that is so much different in terms of what we do either to the metastatic sites or to the primary site. I do not think that that's been definitively shown that the local regional treatment is going to improve the patient's overall survival. So that's kind of a 2-cent summary.
And from a medical oncology perspective, I think, just to recap, these drop gynecological ovarian metastases actually are not that uncommon. We see it in, depending on the retrospective study and autopsy reports, they're seen up to 20% of the time, much more common in lobular cancers. In terms of outcomes that we see in the literature, obviously limited by the retrospective nature, but many of these patients do end up progressing to overt metastatic disease, even with a resection of this primary ovarian metastases. So in my opinion, I do agree that I think I would have a frank discussion with the patient that is indeed a possibility. I think I would follow a stage 4 algorithm for her. And I do agree that given that she has no active disease right now, I think certainly first-line aromatase inhibitor therapy and saving the CDK4/6 inhibitor until she has further disease. And at that point, the CDK4/6 inhibitor can be certainly combined with fulvestrant is how I would approach this as well. But I don't think we're in the clear with this patient in terms of 5-year survival rates for patients with ovarian metastases are about 25% at 5 years. So I think the odds are more, unfortunately, that she will progress to additional metastatic disease.
Thank you, Dr. Mariam. Yes, Dr. Kauthar. Dr. Kauthar, yes.
Any thoughts about elaborate as an adjuvant, second adjuvant, or as a metastatic? This patient is disease-free now with a second metastatic disease as a second adjuvant,
or any thoughts?
She is metastatic now anyway.
Okay,
Not to have to give any.
Actually, this story is in 2018. And since 2018 until now, the patient on letrozole and under continual follow-up in oncology clinic with regular scans and mammogram. And she is now free from cancer from 2018 until now. All her images were normal. So this is her last mammogram in December 2022. And this is her last PET scan, which was done in January this year.
Yeah, actually, that was the reason, because, you know, the local recurrence is different in BRCA positive versus BRCA negative. She has a very, very high chance to have another primary in either of the two breasts. And it's different from somebody who's BRCA. I know each case has its own flavor, you know. It's different from somebody who had no BRCA and had this myths, and she's 5 years free. And if there is a breast recurrence, which is can be missed, you know, whatever we do by the current standard imaging, there is a lot of interval cancers in these patients. So that's why I'm more towards 5-year free, young patient, high chance of another primary in either breast. That's the reason I was thinking of it may be reasonable to go for mastectomy.
Okay, taking in consideration that
Yes,
this is a
Dr.
patient
Alwalwa.
which she wants to feel safe, yani she's not requesting to have bilateral mastectomy.
Dr. Alwalwa, yes.
This, in this case, this is not the scenario. My view of patients with PRCA mutation carrier who are already developed cancer. It might involve the local regional role and prevent recurrence. However, there's no data to support that it affects the overall survival whatsoever. So it is a discussion with the patient. It means thorough discussion, and patient wish should be taken into consideration. She's young, she's fat. And I tell them frankly that I do the surgery to make you feel comfortable rather than preventing metastasis. Even with skin sparing, even with mastectomy, there are chances of just for recurrences that you can never prevent. I can do it. However, it needs a thorough discussion with the patient because it's a lengthy procedure. It's not easy. The recovery takes time, and if she accepts, well and good. If not, I will do surveillance with mastectomy with the mammogram and regular MRI. However, I need to make sure that the patient understands that the surgery is not to prevent survival and not to improve survival, and the surgery is not without complication. I had a patient who did a fantastic job in doing bilateral. He had a chest wall recurrence with a sixth. He insisted on mastectomy, and she had bilateral immediate reconstruction. And unfortunately, that missed her soul. She died of bleeding. So the surgery is not without a complication.
Yes, but
procedure, and the patient needs to understand that there is a risk and benefit, and she should go to it with her mind 100% that this is what she wants.
Yes, but Dr. Alwalwa, the prophylactic mastectomies will reduce the risk of another primary, which is very high in her case, as Dr. Athar mentioned here.
Her chances of getting another metastasis is higher. So
After 5 years from resection of
not improve. There's no data on improving the survival. Unless you have a data that it improves survival, please share it with me.
you will not find data like this.
Sorry, it was hard for me to hear the second half of the conversation, so I'm happy to try to answer.
What I'm saying that prophylactic mastectomy in patients who are already diagnosed with the breast cancer and positive breast cancer, we don't have evidence that it will improve the survival.
There is meta-analysis. There is definitely ovarian surgery improves survival, and also in meta-analysis, the breast surgery does improve survival. There is more strong evidence with the TAH, BSO, or bilateral salpingo-oophorectomy that improves survival, but there's also evidence in meta-analysis that prophylactic breast surgery also improves survival. I'll share with you that data.
Yes, Dr. Meira.
But we would also want to know, again, it's the setting that we're talking about, whether it's, you're talking about just someone who has a BRCA mutation, no breast cancer, a non-metastatic, patient with a hereditary predisposition to breast and ovarian cancer versus metastatic. I think those are three, very different scenarios. And we certainly know that in the non-metastatic setting that the improvement is much more into the role of the oophorectomy and salpingectomies as opposed to the breast cancer surgery, the breast prophylactic or the breast cancer surgery. Again, in this setting, I think we're talking about a very different timeline. And once you have stage 4 breast cancer, I do think that the role of therapy to the breast is very different.
Okay.
It is cured for 5 years. No physical meds. Dr. Roshan, the scenario is a little different here. It was an incidental oligometastatic disease, which is resected completely, and she is as a metastatic disease, completely disease-free for 5 years. Will you consider her still in stage 4, or will you consider still a prophylactic mastectomy will not have any role?
Well, I don't think we can change her staging just because of the length of interval of time between when that disease was identified and how her course is now. I'm relieved that she, is doing so well and that, she continues to thrive. But again, in terms of, reducing her risk of a new breast cancer forming with bilateral, mastectomies, I guess the longer the interval you go from the original metastatic site to consideration of this, then I think it's maybe not unreasonable to do as opposed to continuing with surveillance.
I think this is one of those situations where the tincture of time will help us decide the best course for this patient. And sounds like, yes, prior to the first 5 years, we were not aware of the drop metastasis and whether it was there all along or whether it developed or became more apparent as part of more of an endocrine resistance to tamoxifen. I think these are questions we don't know. So I know she's been on letrozole for a little bit of time now. So I do favor just kind of seeing her course a little bit longer to see what disease biology she ultimately declares. But ultimately, a lot of shared decision-making with the patient and really clarifying that even having more extensive breast surgery does not in any way eliminate the future risk of further metastatic progression. I think that would be part of the discussion that I would definitely have with this patient.
Okay, thank you so much. So I think now this is clear, maybe need to be discussed with the patient to see if she agree.
For us, we sit with the patient and after multiple tumor boards, Finally, the decision was to go for prophylactic mastectomy with immediate reconstruction by next.
And she agreed for that.
And she agreed for that. She strongly agreed for that.
Okay.
Pushing, yes.
Yes. Also, I am agreeing with this.
Thank you.
I think as everyone said that as long as my colleague said, she understands there is a risk of reemergence of metastatic disease and strongly pushing for it and, done by a discussion. I think it's a reasonable option.
This is what we are saying from surgery side. It's a patient decision. We are not saying we will not do it. It's a big, but it needs to be a patient decision. She's going 100% for it.
Okay, thank you, Dr. Ala. So we will go for the last case, but definitely not the least one. Dr. Haytham Hamdan is a staff physician at King Abdulaziz Medical City National Guard. He will present the last case. It will be about the duration of immunotherapy. Please, Dr. Haytham.
Okay, assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Amin, Dr. Athar. Thank you, Dr. Nafisa, and the organizing committee. I promise that I will be quick. I will not take much of your time. Our patient today, she's a 51-year-old female who was diagnosed with left breast cancer back in June 2017. She has no past medical history of note, and she has negative family history of cancer as well. The biology came to be a triple negative with a high Ki-67, 90%. Clinical stage was T2M0M0, stage 2A, and she was BRCA negative at that time. Okay, anyway, we started the treatment journey with neoadjuvant chemotherapy, 4 cycles of PEG, followed by 12 weeks of paclitaxel. That was followed with modified radical mastectomy in June 2018. The pathological stage was T2N0. 16 lymph nodes were removed and all were negative. Okay, now after we finished our treatment, we started the adjuvant settings of her journey. She underwent she received the adjuvant radiotherapy with 50 gray in 25 fractions, finished May 2018. Then she finished successfully the adjuvant chemotherapy, capecitabine 8 cycles, November 2018. So the treatment journey now finished totally November 2018 without any problems. Everything was okay. Now the patient kept on regular follow-up since then. Exactly like 1 year, almost 1 year after she finished her treatment, October 2019, unfortunately, she developed a disease recurrence at the mediastinum. And the biopsy was taken, and it confirmed that it's of breast origin, and the biology was the same, triple negative as well. She developed new left lower lobe mass, which was abutting the descending aorta. And as I mentioned, it was concerning for metastasis. So now, as I said, she was diagnosed June 2017, finished her treatment journey November 2018. Now 1 year and on follow-up, she developed recurrence and it's confirmed of breast origin. What's next? What do you think that we are going to give now? What's the option of systemic therapy or any local therapy, if you think of, that we will start? Any interaction or? PD-L1 is 5%. It's positive, it's 5%.
No.
Yeah. Yeah, it's November.
Genomic testing?
It's October 2019 and BRCA1 and 2 negative.
Is it the only reason?
Yeah.
No?
Yeah.
Can we go which? Resection?
At that time, it was discussed in the tumor board and it was, according to the thoracic surgeon, it was not possible.
Reveal negative.
HER2 negative. Yeah, yeah.
She has metastatic chemotherapy there.
What?
Metastatic setting, no chemotherapy.
No, no, not yet.
Chemotherapy that she did and excessive. So you see, AC,
She received the SPEC and paclitaxel 12 weeks, yes. And then adjuvant Xeloda. Oh,
Taxol received it in the adjuvant, I think. Taxol in the neoadjuvant.
Yeah.
Is the neoadjuvant. She received Taxol.
She received, yes, in the neoadjuvant.
It's been greater than 12 months.
That
since
time
her
was not
taxing.
available.
What she is there.
Yes, yes, Dr. Mariam.
Oh, I was just saying, so it's been greater than 12 months since her taxane exposure, so we could make the argument that she could get not paclitaxel based therapy plus immunotherapy. I think with her PDL status being positive, I think that would be kind of
Okay.
the first line metastatic treatment that I would consider here.
Okay, so let me continue now. She was started on atezolizumab and nab-paclitaxel. That was, as I mentioned, November 2019. She tolerated her therapy very well, and images which was done a couple of months after she started the therapy, it showed initial impression of reduction in the size of that left lower lobe mediastinal mass, as I mentioned before. Okay. So she completed a total of 2 years of atezolizumab, and as I mentioned before, she had excellent disease response. Actually, I remember maybe less than a year, there was no evidence of the disease. And that was confirmed in January 2022, after she finished total of 2 years, as I mentioned, that all images showed no evidence of any recurrence or distant metastatic disease. Okay? Yeah, that in January 2022. So now, my question, okay, she treated radically, she developed recurrence 1 year after, she received the 2 years of therapy, immunotherapy plus nab-paclitaxel initially, and now she is disease-free after 2 years.
To continue, let us continue.
That's my question. What's next?
Continue on atezo. Why to stop at 2 years?
This is why
There's
you
a
are
question.
presenting the case, just to know your.
She's an exceptional responder, and most patients are not fortunate enough to reach a complete response with such long persistence of being disease-free. So we have a lack of data in this particular situation because these cases are so infrequent. But I do agree with my colleague that in this setting, if she's not having significant immune-related toxicities, I would discuss the pros and cons with the patient, but I would generally favor continuing single-agent immunotherapy in this situation unless she was having significant toxicity.
The only toxicity, it's worth mentioning that the only toxicity she developed was the hypothyroidism induced, of course, by immunotherapy, but it was well controlled and thyroxine replacement, and she was under regular follow-up with endocrine department.
Discontinuing immunotherapy or HER2-directed therapy in somebody who achieved complete response is a very, very debatable subject with very, very little data.
Yeah.
There is more data in HER2, at least the ABC now say you may consider stopping therapy if somebody is in complete remission, but that's again, a lot of people disagree with that. In immunotherapy, the data is even less and less. I have one case report, but that was a patient on a clinical trial on durvalumab. And as per the study mandate, we have to stop durvalumab at 2 years. And that patient is still in remission 3 years after stopping, but that is a very, very low evidence. So I really agree with our colleagues that you have to continue the therapy because that will be the standard of care.
Okay, so let me continue. So what was happened that the patient was kept under regular follow-up. Therapy was discontinued. December 2022, almost 1 year after she completed the 2 years of immunotherapy, during the regular follow-up, she had a suspicious mediastinal lymph node enlargement on the CT. We had a PET CT, which confirmed multiple hypermetabolic, subcarinal and left chiral lymphadenopathy, of course, representing a disease relapse. So the case was discussed in the tumor board, and our colleagues in the thoracic surgery had an excision of the mediastinal lymph node, which was in January 2023. And again, the pathology came consistent with metastatic carcinoma of breast origin. And just to mention also that we repeated the PD-L1 and it's positive, but this time it's high, 70%. So before I proceed, I just summarize quickly. 2017, she was diagnosed, local disease, treated radically, November 18, kept under follow-up, 1 year, she got the recurrence, then atezolizumab, nab-paclitaxel, 2 years, then stopped, and then 1 year of follow-up, then she developed the recurrence at December 2022. What's next?
And there is no disease now. There is no disease.
She had a recurrence.
No, after resection. After resection now, completely the metastatic.
No, it was excisional biopsy.
Biopsy, okay.
It was excisional biopsy.
Okay.
PET CT showed multiple hypermetabolic left carinal lymph node.
We will put her back. I will put her back on atezo. I don't know. So because she's responding nicely to atezolizumab, so I will put her back on atezo with this high PD-L1 positivity.
So in the United States, the atezo indication was withdrawn. So I understand there may be regional and international variations in this, but atezolizumab was the indication for breast cancer was withdrawn after Impassion 131 failed to show a progression-free survival advantage and overall survival advantage. But we have the pembrolizumab indication for patients with PD-L1 positivity. So that indication is based on Keynote 355, which is in combination with chemotherapy. So the question here is, do we, given her high PDL positivity, do we consider putting her back on essentially chemotherapy in combination with pembro, or consider single agent pembrolizumab? And I think you can argue it both ways. In Keynote 355, the chemo backbones were paclitaxel, nab-paclitaxel, or gem-carbo. So those are kind of the possibilities. We also have data from Keynote 119, which looked at single agent pembro versus traditional chemotherapy in the second or third line setting. And what this study showed, it was actually impressive responses to single agent pembrolizumab in patients who had high PD-L1 expression. So since there are a lot of gray zones in this particular situation, I think given her impressively high PD-L1 positivity, I think it's not unreasonable to consider single agent immunotherapy. But you could also make the argument to kind of put her back on some type of a chemotherapy backbone as well.
I totally agree with you. I would go with the pembro single agent. Taking into consideration, seeing such a high PD-L1 is kind of rare, 70%.
Any other? Brother?
Again, I will agree with my colleagues of Pembro, but this is a case where is a progression after another immunotherapy. So again, cases don't fall into the category of clinical trials. So if somebody progress on one immunotherapy, what is the data of using another immunotherapy? Zero. So, but still, as our clinical judgment, as this is maybe, second line immunotherapy after immunotherapy, I think it's reasonable with giving CPS. But again, this case does not fall in the category of clinical trials. It's a progression. Yeah.
Almost 1 year.
Yeah, 1 year.
And she has additional options. I think with close monitoring, once starting immunotherapy, she of course has additional options with antibody drug conjugate therapy upon progression. So I think it's worth a try, understanding that, as my colleague stated, it is a bit of a data-free zone. Hopefully she'll respond for a period of time.
What you did, Hazel.
Great. We have a lot of thoughts.
Yes, let us go ahead.
What we did, she was started again on atezolizumab and nab-paclitaxel.
This is only 2 months.
Yeah, the plan was to finish 6 cycles of nab-paclitaxel and then to continue on single agent atezo. She finished almost, I think, 2 or 3 cycles only. She just started recently.
But now atezo is withdrawn from
Yeah, actually, that is why I brought this case, just to hear your opinion regarding which immunotherapy shall I go for. So we know that the initial test was different method. It was not the DACO test, which is now we are using for pembrolizumab. So it was 5%. It was positive. So we started atezolizumab. She had excellent response, actually. This patient came in at the time of recurrence with severe shortness of breath, severe cough. She was really symptomatic. She's in a very bad shape. Immediately after the first 2 cycles, there was no symptoms. So it was very impressive. I cannot forget her shape when she came for the first time with the recurrence, and when she came after 2 cycles. It was marvelous response, clinical and radiological after that. So I was so impressed with her response. After 2 years, there were no side effects. But if you notice, most of the trials are saying you continue immunotherapy for till you get side effect, or maximum 2 years. We don't have a solid data saying that we continue immunotherapy beyond 2 years, especially in the clinical trials. Most of the clinical trials, they're stopping, they are saying this piece of information. So I discussed it with the patient. I said, I can continue. What do you think? She's from Qasim. She's not. She said, Doctor, I will have some rest. If I had any symptoms, I will come back to you and we can resume it. Okay, so it was like shared decision between me and her. So we agreed to stop it. For 1 year, she was good. She was fine. Immediately when we stopped the treatment, she underwent PET CT scan. The PET was completely negative. I was thinking that we can give local therapy for that area. But Dr. Salim said, since it's not a PET avid, so no need to give radiation, just keep observation. Exactly after 1 year, she came, she said, Doctor, I'm having the same symptoms that happened 2 years back. Now I cannot walk for a few steps, dyspneic, having cough on and off, not like before, but I had a feeling that I'm having the same symptoms. So the new images showed recurrence, the PD-L1, the high PD-L1 was very encouraging to resume immunotherapy. But what type of, what is the immunotherapy? This was really difficult for me. Deep inside, I know that she did very well with atezolizumab. And I have strong evidence that she hopefully will do well with pembrolizumab because we have very strong evidence. But really, I put her back on nab-paclitaxel atezolizumab because of her previous response. But I know atezo was withdrawn for breast indication.
That's good now.
She's reasonably well. With only 2 cycles, I think. We don't have restaging CT scan.
Not yet.
But I think she will be fine.
Thank you. This is a really interesting case because just we have wide range of audience attending with us. I think we have
also to take into account this is a very special case. Atezolizumab, the approval was withdrawn from breast cancer, so we have to be very careful because yes, she has a very nice response. However, if this patient end up with life-threatening pneumonitis or hepatitis, is going to be an issue because this medication has been withdrawn. So I think I want to shed some light about this for our virtual attendees.
Dr. Nafisa, are you going to continue or you will change the immunotherapy? Okay. Yeah. Okay. Okay.
If no progression. Oh, yeah.
Okay. But Dr.
difficult question.
Yeah. Dr. Nafisa, Dr. Al-Garni, he mentioned a very valid point here about the atezo, which is already
withdrawn.
Yeah.
Yes, but if there is any problem with side effects or something like that, it will be as if you are giving a patient medication which is not.
We have a Saudi FDA, which also withdraw the medication. So I agree with Dr. Garni. If there is a problem, medico-legally, you may be in trouble because then you cannot justify. And patients, they have the right, when they get a toxicity, they change their attitude. And then you might be in a difficult situation.
Yes. Okay. So any comment, anything?
Thank you.
So thank you so much. So
you.
this is the last case. Thank you for Dr. Mariam. Thank you for Dr. Mera for your kind contribution and valuable input. And also thank you for Dr. Asar Sayed. And with this, we will finish this session. So I will give the mic maybe to Dr. Garni or to finalize.
Thank you so much for having us.
Thank you.
Have a good evening.
Okay, thank you very much. It was a very interesting session. We have come to the end of this meeting. I would like to thank our speakers, our moderator, our physical and virtual attendees, and our sponsor as well. And hoping to see you soon in another meeting, inshallah. Assalamu alaikum.
Assalamu alaikum. Thank you for attending the 2 full days of this scientific meeting. Please be informed that to take the CMEs, you have to be eligible to receive CMEs as per your specialty in the Saudi Health Council. Also would like to mention that to get your CMEs, also you have to be from those who attended the 2 full days. We'll share with you now the short, let's say, conditions to receive the CME. Please be informed that if you are eligible and you attended the 2 full days, you will be receiving an email from CBD activity at Al Faisal University. Based on that, you'll be eligible to receive your certificate. Thank you.